Hi guys, Thomas. Do you guys have the programs there which you can share? Do you have the program with you so that you can share it? Just to say good morning to everyone, and good morning to colleagues all over the country and probably Africa at large. We will be starting shortly. I think we will give probably 3 more minutes, and we'll start at exactly 5 past. So just bear with us, but in exactly 5 minutes time, we should be able to kick the program going. You guys are responding. Great. So it is exactly 5 past 8. Like I've already said that, good morning to you, colleagues from all of Zimbabwe and also from Africa. I believe we will have some colleagues from Africa will be joining us today. This meeting is a refresher course. I don't know what is happening to the team who are sharing the program. Please remove there's a blank screen you have put. If you could just remove it to allow the program to be seen. It is a refresher course in fetal medicine. For the past close to 3 years, the fetal medicine team has been teaching on various topics in the field of fetal medicine. Fetal medicine is a fairly new subspecialty in our country. And I think they should, please keep the screen still the one we are sharing. So it is a fairly new subspecialty in our country, and a lot of teaching has happened in the last 3 years. But sometimes in life, you always ask yourself and say, what is the real evidence when it comes to medical teaching that indeed learning has taken place? So it is this question that always whenever you reflect, sit down and reflect on the process and everything that is happening around you, you look back and say, probably learning may be happening in a very slow way, and there's always need to continuously repeat information over and over again until learning eventually takes place. So this is the purpose of this refresher course, to just go through the basics again, over and over and over, until learning takes place. Some may ask and say, what is your evidence? Why are you saying you do not think learning has taken place? Of course, it is a very good question. But whenever we see cases in the fetal medicine unit, or where they've been practiced, the sharing team, please stabilize your screen. It's always changing. Whenever you see cases in the fetal clinic or in fetal medicine units at SAL and PARI, you always see the old habits or the old ways whereby people are still managing cases in a way that is too short the need to continuously learn. And besides, the field of medicine requires what you call lifelong learning. Lifelong learning means you cannot stop learning. You have to continuously learn. If you could bring back the program, I'll just run through it before I hand over to the speaker. You have to engage in continuous lifelong learning. So there is nothing like you've stopped learning in the field of medical practice. So it is incumbent upon all of us to have an insatiable appetite to learn and to never stop learning. Today, the program is populated with budding experts in the field of fetal medicine. The team that you see, if you could share the screen with us again, so that everyone could see it. It is filled with budding experts in the field of fetal medicine. We have Dr. Ndagura, who has been a fellow of fetal medicine with us for the past 3 years, and she has been running clinics in multiple pregnancy clinics and also the placenta disorder clinic, and she has mastered this subject. So she will share you from her experience and the reflection of her work, which is very important. We have Dr. Fachayo, who has also been running our placenta disorders and multiple pregnancy clinic and a fellow of fetal medicine. Through her own work and the experience that she has had all these years, she will show you how to manage fetal growth retarded babies based on the reflection that she has had. We have a lot of speakers amongst us. We have our esteemed colleagues, the sonographers. We are now more subspecialist sonographers in fetal medicine. We have been running things like preterm clinic. We have been measuring women's cervixes. They will teach us about cervix assessment. We have some teams we have been working with in the fetal defects clinic who will take us through doing fetal anomaly screening. We have a number of speakers lined up for you. So we are hoping you are going to enjoy this program and you are going to learn as much as you have to learn today. And on top of that, we want you to know that you will be given certificates with CPD points. The full meeting is a CPD points, 8 CPD points. So during your attendance, because this is a webinar you have registered, your attendance is going to be easily tracked in terms of the number of hours you have attended, and points will be allocated 1 point because it's an 8-hour meeting roughly. So depending on the hours you attend, you will be given the points that measure with the number of hours you've attended during this course. So CPD points will be attended because this is a course. A course certificate of attendance will also be given at the end of the meeting. Do not worry, you have registered. This is a webinar, so our team have your details. So through those details, they will contact you for your digital certificate, which they'll send to you. If you want a physical certificate, you can always get in touch with our team. The meeting will be administered by the Fetal Medicine Foundation Zimbabwe, and at some point, I will ask them to share their contacts, both their mobile and their email address to you, so that you can contact them for any queries or any questions that you may be having. This will be a course. Speakers at some point may try to interact with you, so please feel free to participate. We are aware it is a webinar. Only panelists will have the right to speak. But if you do have questions, share with us the questions in the chat box. There will be people who will be watching that chat box. So your questions will be responded to. Lastly, I'm Dr. Verenga. I will be the moderator for this course, for this refresher course. If anything happens to me, I'll make sure in between the course, I'll make sure there's always somebody who will be moderating the course and will be able to respond to your queries during the course. So without wasting much time, I'll ask our first speaker to be allowed to share a screen now, so that as soon as it is 15:15, she will get going. So our first speaker will be Dr. Ndagurwa. I've already introduced her to you. Dr. Ndagurwa is a Fetal Medicine Fellow. We have worked with her for the past 3 years, and she has been running multiple pregnancy and placenta disorder clinics, and she will take us through the FMU protocols for managing multiple pregnancy, because it's a subject which is scarcely or sparsely addressed in our country in terms of our national protocols. But this is a field we feel will need attention, and everybody who is involved in pregnancy care, whether you are an obstetrician, a midwife, a sonographer, a radiographer, or any other professional, you need to know how multiple pregnancy should be cared properly for good outcome. So I will hand over to Dr. Ndagurwa. Thank you.
Okay. Morning, Dr. Verenga. Morning, everyone. Can you see my screen, Dr. Verenga?
Yes, Dr. Ndagurwa, we can see your screen. If you can show your face or your video, that would be great if your network allows, so that people can see you as well.
It has been disabled. If the host can enable it, yeah.
All right. So the host kindly allow panelists to share their face so that people can see them. Otherwise, you can go ahead for the sake of time, Dr. Ndagurwa. Then as soon as they allow you, you should be able to share your face.
That's okay. Thank you, Dr. Verenga, for the introduction. It's a pleasure this morning to speak to you on multiple pregnancy protocol for the fetal medicine units in Zimbabwe. As Dr. Verenga mentioned, I'm Dr. Ndagurwa. I'm a specialist obstetrician and gynecologist, and I'm currently a fellow in the fetal medicine unit. Sorry, I need to stop the share and start again. Can you see my screen, Dr. Verenga?
Your screen is clear.
Hello. Yeah.
Yeah.
Okay. Fine. So I I just thought, well, we should all be reminded about why we are making a big fuss about multiple pregnancy care and everything else that Dr. Verenga has been talking about. We have to know that multiple pregnancies are sort of a common occurrence in our setting. Actually, a more an occurrence that is actually encountered more than more than what we think, and more than what is noticed in the first world countries. The good thing about our multiple pregnancies is that they are naturally occurring. Most of them are naturally occurring. So if we are looking at multiple pregnancies that occur naturally, the highest rate has been noted in the sub-Saharan African region, and at a rate of 18 per 1,000. So we also have to remember that with that high multiple pregnancy rate, we also have the highest neonatal mortality rate. And for that neonatal mortality rate, our multiple pregnancies are contributing about 15%, which is a significant figure. Also, we also have the highest under 5 mortality rate in the sub-Saharan African region, and the multiple pregnancies are contributing about 11%. So with this background, we need to understand what it has contributed to us to we are. It is basically because multiple pregnancies receive insufficient care in our setting. Most of the pregnancies are monitored in the local clinics and the district hospitals with just a peanut stethoscope and palpation. We should all know that that is insufficient care, because if there are some complications that are taking place inside the pregnancy, you won't be able to pick them. For example, if the woman is having twin-to-twin transfusion syndrome, you are not going to pick that using palpation or even a peanut stethoscope. Even a Doppler, a sonicate cannot pick that. So that insufficient care is what has gotten us to this place where we are being recorded as contributing to, as having the highest neonatal mortality rate, the highest under 5 mortality rate, and with our multiple pregnancies contributing significant figures to those rates. In Africa, most of the guidelines on obstetrics, they have been silent, or some are still silent, on the special care that multiple pregnancy patients and their babies need. It is because of that silence that healthcare practitioners then practice without enough knowledge as to how they should manage multiple
Dr. Ndaguro, I think we have lost you there. Are you still there? I think we lost you a little bit. The admin team try to get in touch with Dr. Ndaguro, find out if we know she's talking, but we can't hear. Sorry about the glitch. I think Dr. Ndaguro will come back into the meeting soonest. If need be, the team, the admin team, you could share a presentation from the office. Then Dr. Ndaguro may present through probably another, without even to share the screen if the internet is not stable. Admin team, please, let's action that so that we don't lose time. We need to move. We are sorry for those who have just joined us. We just had an internet glitch. Our presenter, we lost her in the internet glitch, but we are hoping she's coming back soonest to continue her presentation. Admin team, we need a response from you. If you are having any challenges, well, just let us know so that if the second speaker is ready, we can probably activate the second speaker and Dr. Ndagura can follow through after the second speaker so that we don't lose time. Do we know if Dr. Ndagura will be able to continue presenting while we are sharing the screen? If we can activate that, the better. Admin team, did we manage to get hold of Dr. Ndagura? We want to know if she can still continue right now, or we ask the next presenter to chip in, then she will come after.
We are trying to get hold of Dr. Ndagura. We are failing to get hold of her.
Is Dr. Hlachaya ready to present? Let's activate the next speaker. Dr. Ndagura will probably follow after the next speaker if we can't get hold of her. We do not want to lose time. We have a packed program for the day. We are sorry to all our guests. These are some of the challenges that come with modernization, with the Internet of Things. Our internet in Africa is unreliable. It disappoints us, but we are not going to give up because we believe this is the future of learning. Learning has to be blended. That's the future of modern learning. So it's a challenge we have to embrace and soldier on with it. So let's activate the second speaker, then we can ask Dr. Ndagura to go to a site or to come to the office so that as soon as Dr. Hlachaya finishes, she can chip in. To go to a site which is, okay, she's back. All right.
Sorry, I'm back. Can you see my screen?
Yes, we can. Please proceed.
Okay. Okay, fine. So I was saying against the background that I had explained, we then established 2 multiple pregnancy clinics. These are clinics that are dedicated to scanning just multiple pregnancies, as in twins, triplets, quadruplets. Those are the multiple pregnancies that we have scanned so far. And we are able even to scan higher order multiple pregnancies. These clinics, we have one at Salim Mugabe Hospital and one clinic at Paride Nyatwa group of hospitals, and they run for 1 working day per week. They are manned by fetal medicine midwives, specialist obstetricians, and our fetal medicine specialist with Dr. Verenga. So I've already mentioned that we have 2 clinics per week, and we see those multiple pregnancies that are referred from both the public and the private sectors. For the management of multiple pregnancies, there are 2 important factors that I should highlight before going any further. we need to understand that determination of the gestational age is very important. This should be done timely and preferably in the first trimester, where we are able to see all the fetuses and the placental masses, so that we can also assign chorionicity at that time. Determination of gestational age is important because that's what is going to determine what we are going to do at what point. And this includes even when we are going to deliver the pregnancy, when we should give antenatal steroids, when we should give all sorts of things. So it is that important. And when you are referring a patient, make sure you refer them on time, and especially in the first trimester. If they present at your clinic or at your working place in the first trimester, don't say you have come too early. It's the best time for you at least to see something about that pregnancy. And if you are able to refer them to the next level of care, then you have to do it. Chorionicity is the most important determinant factor of everything about multiple pregnancies. It helps us to plan what we are going to do for that particular pregnancy, as in the surveillance. It helps us to plan when we'll be seeing the woman. Are we going to be seeing them every 2 weeks or every 4 weeks? The complications that we should anticipate. For example, if it's a monochorionic pregnancy, you can then start to think, or you can actually screen for twin-to-twin transfusion syndrome and other complications that are peculiar for monochorionic pregnancies. It is also the determinant factor of the outcomes that you are going to have for that multiple pregnancy and the possible morbidity and mortality that can actually take place in that pregnancy. And we have to keep at the back of our minds that monochorionicity has the worst morbidity and mortality of all the multiple pregnancies. So in our units, we start following up multiple pregnancies from the first trimester around 12 weeks. And if they are able to come at any time from 11 plus 0 to 13 weeks plus 6 days, that is also okay. At that point, we perform a detailed ultrasound scan. This scan is done transabdominally and also transvaginally. We confirm the type of gestation. Is it a twin pregnancy? Is it a triplet, quadruplet, or whatever it is? We confirm viability of all the fetuses and the pregnancy location as well. And then we assign the chorionicity. For the chorionicity, we can count the number of placental masses if all the placental masses are visible. But if there is one placental mass, we use the T or lambda sign to say this is monochorionic or dichorionic. I'll cover that in the next slide. We also label the fetuses because we don't want to cross-scan them. So we label them, and for the methods that we use mainly the fetal positions. For the fetus who is on the right-hand side of the mother, we label them as twin 1 or triplet 1 or quad 1. And then the one who is on the left side of the mother becomes twin 2. And then if one is on top of the other, the one who is closest to the cervix or in the lower segment becomes twin 1 or triplet 1 or whatever the case. And then we can, if labeling using the fetal position is difficult, we can also use the gender. If the genders are different, if there's a boy and a girl, then we can label them as such and follow them up as such. We can also use the placental location. For example, in quadruplet pregnancies, it may be difficult to say left, right, or upper or lower segment. So we can use the placental location and or even the level of the condensation on the placental mass. We go out of our way to label the fetuses like this because we don't want to cross-scan them. We want to monitor twin 1 as twin 1 up until delivery. And then we want to monitor whatever twin or triplet as such up until delivery. We don't want to scan the abdomen of that one and then go on to scan the head of that one and come up with the fetal weight. So labeling them helps us to follow up each baby as it is up until delivery. In the same sitting, we screen for aneuploidies, trisomy 13, 18, and 21, and also Turner syndrome. We also check for major fetal abnormalities like holoprosencephaly, anencephaly, gastroschisis, omphalos, all such things that are very important. We use the uterine artery Doppler studies to screen for preeclampsia, and if they screen positive, we commence them on aspirin 150 milligrams once daily until 36 weeks or at a point of delivery if they happen to deliver preterm. We also just check for adnexal masses like ovarian cysts and uterine fibroids as well. So I'll just go back to determination of chorionicity because it is the most important determinant factor of whatever that we are going to do. So everyone should understand how we do it. So you can see in the first image here, we have two distinct placental masses, one in the anterior segment, this one, and another one in the posterior segment. So we can easily label that pregnancy as dichorionic. We are only able to do this if you send the patients in the first trimester or at the earliest point when you have seen them. If you send them later on in the second and third trimesters, it will be very difficult to assign chorionicity. So if there is one placental mass, like what is shown in this image, and there is a thin intertwin membrane here, if the amniotic membrane is very thin and looks like a T, like what is illustrated here by the red arrow, we label the pregnancy as monochorionic. If there's one placental mass and there is a thick intertwin membrane, and then and there's a thick intertwin membrane like what is shown here and demonstrated by the red arrow, we label that pregnancy as dichorionic. So after the first trimester scan, we then go on to say, to classify the pregnancies into twins, triplets, quadruplets, or whatever order that we will be having at that point. For the twins, we can have monochorionic, dichorionic, or conjoined twins. The monochorionic can be further classified into diamniotic or monoamniotic. For the triplets, they can be trichorionic, triamniotic, meaning to say we have 3 placental masses and 3 amniotic sacs. We can have 2 placental masses, which will be a dichorionic, triamniotic pregnancy. We can also have a monochorionic triplet pregnancy, whereby we have 1 placental mass and different relationships on the amniotic sacs. However, this is very rare. On the quadruplet pregnancy, we can have a quadrachorionic, quadramniotic, meaning to say we have 4 placental masses and 4 different amniotic sacs. We can have 3 placental masses, which will be a trichorionic, quadramniotic pregnancy. We can have 2 placental masses, which will be a dichorionic pregnancy. And on the dichorionic, we can have 2 fetuses on each placenta with whatever amniotic sac relationship that they'll be having. So these are the different types of multiple pregnancies that we can see, and each one is managed according to the order. Is it a triplet pregnancy? Is it a quadruplet pregnancy? And also according to the chorionicity, because even if it's a triplet pregnancy and there is a monochorionic relationship on 2 of the babies, we can actually have twin-to-twin transfusion syndrome. We can, in that case, it will be fetal-fetal transfusion at that placental mass. So it's important to establish the chorionicity so that you can anticipate the complications that you can face for that particular pregnancy that you will be monitoring. So now we will look at the monochorionic pregnancies. We will start off by looking at twins, and we'll look at monochorionic twins. After the 12-week scan, we start following them up from 16 weeks. We start at 16 weeks because twin-to-twin transfusion syndrome can actually start developing from around 16 weeks. So we see them every 2 weeks, and at each visit we'll be assessing the fetal growth, whereby we check the biometric measurements, the head circumference, abdominal circumference, and the femur length and of all the babies. And then we also assess the Doppler studies, the umbilical artery, cerebral artery, and ductus venosus. We assess the amniotic fluid in each sac, the fetal bladders for each fetus, and we also measure the cervical length to screen for preterm labor. For the cervical length, we perform a transvaginal scan. At 18 to 22 weeks, we perform a detailed fetal anomaly scan because we know that congenital malformations are more common in multiple pregnancies, and especially in the monochorionic type. If we have diagnosed twin-to-twin transfusion syndrome, we also perform fetal echocardiography. For the timing of delivery, if it's a monochorionic, dichorionic pregnancy, which is uncomplicated, we recommend delivery at around 36 to 37 weeks. If it's a monochorionic, monoamniotic, we recommend delivery at around 32 to 34 weeks. The monochorionic, monoamniotic type is very rare, and even in our setting, I think so far we've managed less than 5 sets of monochorionic, monoamniotic pregnancies in the about 600 multiple pregnancies that we have scanned so far. The most common complications that we see include twin-to-twin transfusion syndrome, twin anemia, polycythemia sequence, selective fetal growth restriction, single intrauterine fetal demise, preterm labor, and twin reversal arterial perfusion sequence. So for the monochorionic pregnancies, when scanning them, we scan them like as if we are scanning one fetus. So we scan them at the same time. If we are assessing the head, we assess the head for twin 1, and then we go on to assess the head for twin 2. So we put the measurements on the same window, like what is shown in this image on my right side, on the right side of the screen. So let's say this is for twin 1 and this is for twin 2. You can actually see that the abdomen for twin 1 is bigger than that for twin 2. So we fly them at the same, on the same window at the same time, so that we can actually compare them real time and see the differences in growth as we scan. So after doing the biometric measurements, the head circumference, abdominal circumference, and femur length, we come up with the estimated fetal weight, and then we calculate the discordance between the two babies. We subtract the weight of the smaller twin from the weight of the bigger twin, and then we calculate a percentage from that figure. If that percentage, so that percentage is the estimated fetal weight discordancy. And if it's more than 25%, then there is a significant discrepancy in the growth of the two babies. And we label as twin-to-twin transfusion syndrome or selective fetal growth restriction, depending on the other features that will be present in that pregnancy. We assess the amniotic fluid volume at the same time, like what is shown in this image, and we'll be comparing the amniotic fluid from twin 1, from the sec for twin 1, and from the sec of twin 2. And we subtract the smaller value from the bigger value, and that difference is the discordancy. And if it's more than 6 centimeters, then there is a significant difference in the amniotic fluid volumes of the two babies, and we can diagnose twin-to-twin transfusion syndrome. We also look at the membrane. Is the membrane firm and floating freely? If it's folding or stuck on one of the babies, then it means there is reduced amniotic fluid in that baby. We compare the fetal bladders as well, because we know that the fetal bladder is also part of the classification for twin-to-twin transfusion syndrome. So part of the staging, sorry. So we compare the two bladders, we put them on the same window, and we compare the filling of the two bladders. Is one of the bladders empty? Is one of the bladders too full? Or are they comparable? If one of them is empty or one is big and the other one is very small, that also becomes a diagnostic factor for twin-to-twin transfusion syndrome. We also look at the fetal Doppler studies. As I mentioned earlier on, for the umbilical artery, we'll be looking at the pulsatility index and end diastolic flow. For the middle cerebral artery, we also look at the pulsatility index, the end diastolic flow, and the peak systolic velocity. We note any discrepancy in the middle cerebral artery peak systolic velocity because it is diagnostic of TAPS. We also look at the ductus venosus, the pulsatility index, and the A-wave as well. So for twin-to-twin transfusion syndrome, we start screening for this condition from 16 weeks, and we repeat the screening every 2 weeks. It's like we are actively looking for twin-to-twin transfusion syndrome, doing the things that I mentioned in the previous slide. And we use the Quintero staging system for classifying and also for planning further management. Unfortunately, in our setting, we can only do conservative management where we continue monitoring growth and the Doppler studies. But we can do serial amnio reduction where we tap about 1 to 2 liters per session. This is in pregnancies that are at least stage 1, twin-to-twin transfusion syndrome, stage 1, and are more than 26 weeks gestational age. In other centers, they offer laser ablation, septostomy, and cold coagulation. But for us, this is not yet available. In this diagram, I'm just showing what will be happening for us to end up having twin-to-twin transfusion syndrome, where we have at some point in the placenta, we have an artery and a vein from say twin 1 and a vein from twin 2. They are in close proximity, and because of the differences in the pressure gradients, we end up having blood flowing from the artery to the vein, at the same time transfusing the twin that will be sending blood is like transfusing the other twin who does not need that blood anyway. So we end up having one twin who is hypovolemic and the other one who is hypervolemic, and that's what we'll be following up using the growth, the amniotic fluid assessment, the fetal bladder filling, and the Doppler studies as well. And we are able to pick if there is transfusion at some point in the placenta, we are able to pick that using those assessments that I explained earlier on. And then I'll move on to selective fetal growth restriction. We are still talking about monochorionic pregnancies. For selective fetal growth restriction, we need to understand the differences between a selective fetal growth restriction and twin-to-twin transfusion syndrome. For selective fetal growth restriction, we have one placental mass, and one of the cause from say twin one has implanted at an area that will make that the vasculature of that cord to occupy at least more than 75% of the placental mass. And we have the other twin, the cord from the other twin inserting at the margin of the placenta where it will occupy, where the vasculature will occupy less than 25% of the placental mass. So we'll end up having discrepancies in the oxygen and nutrient supply to both twins. And the one who has implanted at the little corner there, here, will end up receiving reduced oxygen and nutrient supply, and they will not grow well. So if that has happened, we are able to pick that up if we are following up the fetal growth serially, like we are checking every 2 weeks, we are able to see that this baby is not growing well compared to the other. And if it's just the growth, plus or minus the Doppler studies, then we label as selective fetal growth restriction. For this condition, we don't have the differences in the amniotic fluid volumes, the differences in the fetal bladders. It is just the growth that will be showing a discrepancy. So like what I mentioned earlier on, we do measure we perform the biometric measurements. We then calculate the difference, and if there's a difference of greater or equal to 25%, then there is selective fetal growth restriction. If we perform the biometric measurements and one of the babies, the fetal weight of one of the babies falls below the 10th centile, that is also diagnostic of selective fetal growth restriction. If one of the babies has an umbilical artery pulsatility index that is above the 95th centile for that particular gestational age, it is also diagnostic of selective fetal growth restriction. Once we pick this, we follow them up every 2 weeks, performing the growth scans and the Doppler studies. And for the timing of delivery, it is determined by the gestational age of the pregnancy and also the Doppler studies of the smaller twin. If everything is okay and we've managed to push the pregnancy beyond 34, 35 weeks, we recommend delivery at that point. However, if the smaller twin, if the Doppler studies of the smaller twin are actually worsening, we recommend delivery even before 34 to 35 weeks. Again, on monochorionic pregnancies, we can have single intrauterine fetal demise, whereby one of the babies has demised at whatever gestational age. For the patients that we have followed up so far with monochorionic pregnancy and single intrauterine fetal demise, the survivor, the Doppler studies of the survivor tend to deteriorate faster compared to what we note in dichorionic pregnancies. So for this one, the outcomes depend at the gestational age where this insult has taken place. If it's a severely preterm pregnancy, we are most likely going to lose both babies. If it's an advanced pregnancy, in most of the times we are able to save, we are able to assist the survivor and they are delivered safely by cesarean section. So what we do is, once we pick that one of the babies has demised, we perform weekly Doppler studies on the survivor until a point where we think that they have stabilized. Once they have stabilized, we start following them up to every 2 weeks, assessing the growth and Doppler studies as well. In other centers, they are able to do MRI scan of the central nervous system of the survivor. But for us right now, we are just relying on ultrasound scanning. So we advise delivery once we have pushed the pregnancy beyond 34 to 35 weeks, or we have noted that the Doppler studies of the surviving twin are actually worsening. This is if the pregnancy has gone beyond 28 weeks. We have other fetal transfusion disorders that can take place in monochorionic pregnancies, and we can have TEPS, which is twin anemia, polycythemia sequence, and the TREP sequence. I'm not going to go into details on these two in the interest of time, but we just have to remember that for TEPS, we are having small arteriovenous anastomosis, which are deeply seated in the placental mass. These are very small vessels with a diameter that does not exceed 1 millimeter. So because of this anastomosis, we have slow transfusion of blood from the donor twin to the recipient, and you end up having discrepancies in the hemoglobin count. However, we do not notice any amniotic fluid volume discrepancies because there are no problems with volume. Rather, the problems are to do with the hemoglobin count. So we are able to pick this on ultrasound scan by using the middle cerebral artery peak systolic velocity. What happens is that in the donor twin who is anemic, they will have a high peak systolic velocity, and the recipient will have a sluggish flow of blood and a low peak systolic velocity. So we measure the Doppler, we perform the middle cerebral artery Doppler studies, and then we check on the nomogram. If one of the twins has a high peak systolic velocity and the other one has a low peak systolic velocity, that is diagnostic of TEPS. If this goes unmonitored, we can actually end up having a hydropic fetus, and one of the babies can actually die, and we end up having single intrauterine fetal demise. TEPS is staged using the Leiden system, which is just a modification of the Quintero staging system for twin-to-twin transfusion syndrome. In our setting, we are just managing these pregnancies conservatively, and we advise preterm delivery where it's indicated. Where we are able to push the pregnancy beyond 34 to 35 weeks, we then advise delivery at that point. In other centers, they are able to perform fetoscopic laser and fetal blood transfusion, and we hope in the future we'll be able to do this as well. For the TREP sequence, we have a pump twin who is supplying blood for both twins, and this twin tends to develop normally. And then we have an cardiac twin, and this one lacks a heart, and either there's no heart or the heart has been poorly developed. And in most of the cases, the upper part of the torso and the head and the limbs are also not visible. So on ultrasound scan, if you notice a mass and a baby, you need to refer that patient for to a higher level of care, because most likely it will be a monochorionic pregnancy with a TREP sequence. So when such pregnancies come to our unit, we manage conservatively because that's what we are able to do at the moment. We just continue with the fetal growth assessments, Doppler studies, and then if we are able to push the pregnancy to 34 to 35 weeks, then we advise delivery at that point. In other centers, they advocate for diagnosis in the first trimester. Once diagnosis is made in the first trimester, they are able to perform ablative techniques on the aberrant blood vessels that will be sending blood from the pump twin to the cardiac twin. They are also able to perform radiofrequency ablation and cord occlusion. So those are the methods that they use to occlude the blood vessels, the communicating blood vessels, and stop the communication and let the normal twin develop as a singleton pregnancy. Okay, so I'll move on to dichorionic twins. This is these twins, we refer them as the sort of good type of twins, because we see that the outcomes for these twins are actually very good and somehow comparable to that of singletons, though they are sort of, the outcomes are sort of worse compared to that for singletons, but they are better compared to the monochorionic twins. Again, we see them in the first trimester, but because the complications for these twins are less, we see them again at 18 to 22 weeks. So we start from 18 to 22 weeks, we start following them up every 4 weeks, where we'll be performing the biometric measurements that I explained earlier on to come up with the estimated fetal weights, and we compare them like what we do for the monochorionic twins as well. We perform the fetal Doppler studies and the cervical length assessment. If it's an uncomplicated dichorionic pregnancy, we recommend delivery at 37 to 38 weeks. The most common complications that we see include selective fetal growth restriction, which is sort of the most common complication that we see in this type of twins. Single intrauterine fetal demise, discordance for fetal abnormalities. This is sort of more common in dichorionic twins as compared to monochorionic twins. We also see preterm labor, and preeclampsia is also more common in dichorionic twins as compared to the monochorionic twins. For selective fetal growth restriction, the diagnostic criteria is the same as for the monochorionic twins, where we calculate the discordancy. If it's greater or equal to 25%, then we say there's selective fetal growth restriction, or if there's one baby with an estimated fetal weight centile that falls below the 10th centile for that gestational age, or if there's one baby with abnormal umbilical artery Doppler studies, then we diagnose selective fetal growth restriction. We follow up such pregnancies every 2 weeks, and then we deliver them after 34 to 35 weeks, or when the Doppler studies of the smaller twin are worsening. For single intrauterine fetal demise, the outcomes for the dichorionic twins are sort of better compared to that for the monochorionic twins. For these ones, we follow them up after every week after diagnosis. Once we have noted that the survivor has stabilized, we see them every 2 weeks, where we'll be performing fetal growth scans and Doppler studies. We deliver them at around 34 to 35 weeks if there are no problems, but if there's worsening of Doppler studies in the surviving twin, we recommend delivery, preterm delivery. Sorry, my slides have just stopped moving. Let me stop the share and start again. Sorry about that. Okay, so for the mode of delivery for dichorionic twins, in our setting, we mostly recommend cesarean section. This is because we do not have electronic fetal heart rate monitoring, and we do not have enough human resources to monitor the pregnancies as they should be monitored during labor. If we remember that we need 2 different practitioners who will be checking the fetal heart rates at the same time at a point that is 10 centimeters apart, and we do not have the human resources to do that when the patient will be in labor. So because of that, when we started, we just used to let the obstetricians decide how they are going to deliver the pregnancy. And we noted that for the dichorionic mothers, about 50% of them will go home with one baby. And especially the trailing twin will have a poor outcome. About 25% of the mothers will go home with no baby. This is at Salimugabe Hospital and Parinyatwa group of hospitals. So we then started recommending that at least if they are delivered by a planned cesarean section, we are able to control how things will take place during the delivery. And that has sort of improved the outcomes for multiple pregnancies at both hospitals. So historically, we have been taught that if both babies are in cephalic presentation, the mother can deliver vaginally. We also recommend that if the mother gets into labor and there are no problems with monitoring, of course, she can deliver vaginally. If the leading twin is in vertex presentation, of course, they can also deliver vaginally. However, if the leading twin is in breech presentation, or both are in breech presentation or transverse presentation, we recommend cesarean section, even if she comes when she is already in labor. We've had problems with mothers who presented in labor with one of the babies, the leading twin in cephalic presentation and the trailing one in transverse lie. In our setting, we do not have experienced people who will be able to manipulate and deliver the second twin properly. So in most of the cases, we ended up having the second twin with having fractures, or actually losing the second twin because the midwives who will be on duty will not be able to manipulate the second twin and deliver them safely. So it is because of this reason that we just say we mostly recommend cesarean section, unless otherwise she presents in labor with both babies in cephalic presentation. So now we'll move on to the triplets and the higher order. So far in our unit, we have the highest order that we have managed is the quadruplet pregnancy. For the triplets, we've had about 8 sets so far, and most of them, they present very late in the early 30, 31, 32 weeks, thereabout. And it's actually very difficult to scan them and to manage them properly. However, if we are able to see them in the first trimester, we also do everything that we do for the twins. And then we see them every 2 weeks because they are just similar to the monochorionic pregnancies. So for the monochorionic pregnancies and all the higher order, we see them every 2 weeks, where we'll be checking the fetal weights, the Doppler studies, and assessing cervical length for preterm labor, which is more common in the higher order pregnancies. We perform a detailed second trimester scan because the congenital abnormalities are actually more common in the higher order gestations. And the complications that can be picked also include the selective fetal growth restriction, twin-to-twin transfusion syndrome, single intrauterine fetal demise, and preterm labor. We have to know that the fetal transfusion can also take place in the higher order gestations because of what I explained earlier on, that there may be a monochorionic relationship on 2 or 3 of the fetuses. For the triplets, we advise delivery at 32 to 34 weeks, and for the quadruplets, we advise delivery at 30 to 32 weeks. That will be the end of my presentation. Thank you for listening.
Thank you so much, Dr. Ndagura. For the sake of time, we will ask the next speaker to get ready. You may unshare your screen. Very enriching presentation on multiple pregnancy. I know we may have questions. In the meantime, what we can do is let's post our questions in the chat box. Dr. Ndagura will interact with you in the chat box. We are going to have an answer and question segment after the next two presenters. So if you wanted to talk to you directly, she will address your question directly. But in the meantime, she will interact with you in the chat box. The next presenter is Dr. Hlachwayo. May you please allow me to share the screen. Dr. Hlachwayo is a Fetal Medicine Fellow, an obstetrician and gynecologist specialist. She's passionate about both twins and placenta disorder conditions, fetal growth restricted babies. So for the past 3 years, she has dedicated her time to scan placenta disorder cases and twins. So she has grown her expertise over time and she has broadened her knowledge in these subjects. So she's somebody who actually does the work of monitoring babies. So this is somebody who is hands-on, who actually sees babies who are not growing well. So she will take us through the fetal growth restriction protocol. The team, may you please allow her to share. I want to promise you all the guests in this meeting that we will try to stick to our time. We don't want to waste your time beyond what we have promised you, that we will keep you here up to. So presenters, please take note of this. Our guests have other things to do besides being here. So want to stick to the time. Please, Dr. Hlachwayo, may you please share your screen? Yeah, please share your screen, Dr. Hlachwayo. All right, please say something. Tell us you are sharing your screen. We can't hear you.
Good morning. Can you hear me now?
Perfect, perfect. So please go ahead as soon as you are ready.
Okay, thank you for having me. I just want to put this on slideshow. Can you see my screen?
Yes, we can, Doc. Maybe what you need now is slideshow. We can see it in normal presentation mode, but you may need to go to slideshow.
No, I did go to slideshow. On
yeah,
mine,
the
it's on
tab on
slideshow.
If you go to the 4th tab there, where it's a home button, insert design animation, then slideshow, you click that button. While Dr. Hlachwayo is bringing a screen, fetal growth restriction, we have the feeling that this condition has been underdiagnosed in our setup for years.
Can you see my screen again?
Yes, please go ahead.
Okay.
Yeah, click there. Resume slideshow, probably. If you look on slide number 1, Dr. Hlachwayo, on the left, the box for resume slideshow is just there. Just click that one. Or on your slide number 1, there on the far left, there is a message written resume slideshow. If you can just go there and click, it should work.
Because now it's on slideshow. So can I stop to share and then read?
No. Yeah. Yeah, please reshare again. Perfect. You are good to go now. It's on slideshow.
It's on slideshow. Okay, thank you. Thank you for having me share the fetal growth restriction protocol that we use in the fetal medicine unit. Without much further ado, I'm just going to give an outline of my presentation.
Dr. we've lost you. I don't know if you are still there. Admin team, just get hold of Dr. Lashayo. Let's find out what's happening. To save time, we should make sure that the next presenter is always ready to chip in. So admin, let's organize ourselves in such a way that if one drops out, the next presenter chips in so that we don't lose time.
Can you hear me now?
Yes, you may share your slides. If you are having challenges, Dr. Lachayo, you may, yeah. On the far left, it's written resume slideshow. On the far, not that, yeah, from just say from beginning, let's see. There is just a small tab written resume show, just on the far right there. If you can click that button, it should work. Oh. If you can reshare again, please.
I've reshared. Can you now see?
It's not on slideshow. Probably for the sake of time, you may proceed the way you are, because slideshow is not coming up nicely. Yeah.
Can you now see it's on slideshow?
It's not coming. If you go, there is a button written resume slideshow on. If you look on your slide number 1, the way your screen is right now.
Okay, my screen on my side here, it's on slideshow. We are not seeing the same screen.
All right, probably have 2 presenters, but try to move your slides. Let's see. Then you can start presenting the way it is, because I think we can see clearly.
Okay, I've moved my slides. Can you see me now?
No. Do you want to make sure you don't have 2 presentations open, Dr. Lachayo?
Okay.
Just make sure you have only 1 presentation on your desktop, because it appears there could be another presentation on the background. Just make sure you have 1, then you reshare. To our guests, we are sorry about the internet glitches, but we are hoping they will be fixed. Like I said earlier on, that look, we are living in the era of what we call blended learning. We have to embrace the changes of our times, which is to move to the digital platforms for meetings, for teachings. There will be challenges along the way, but we have to address them as we go, but we can't give up. So Dr. Lachayo, please try again. Let's see if we can see your screen again.
Can you see my screen now?
It should be good to go. Try to share your slides now. I think you are perfect.
Okay.
Slideshow. Dr. Lasha, just on the top, where it's animation, then slideshow. Then the next one. Alternatively, you may move the slides as they are for the sake of time.
Okay, I think let me try to move the slides is there. So I'm going to share the fetal growth restriction protocol for the fetal medicine unit. First of all, I'll start by giving definitions. This is the outline of my talk. Then I'm going to highlight the extent of the disease burden. And then we'll talk about the risk factors. And then we're going to discuss on diagnosis or how we identify fetuses with growth restriction. And then we'll discuss the two types of phenotypes of fetal growth restriction. And then finally, we're going to discuss the management of fetal growth restriction. Now we say a fetus has growth restriction if they are failing to achieve their genetically predetermined growth potential. What I want us to note about this is that this is a hypothetical growth potential. So we don't know when we are examining the baby in utero what their growth potential is, but we know that there's a hypothetical growth potential that they have. And the other thing to note is that this growth is a dynamic process. By this, what do I mean? We may examine the baby today and find that they are growing appropriately for gestational age. But if we viewed or examine the baby, that same baby again, after 2 to 4 weeks, we may find that actually they are now small for gestational age, or that they've fallen off their growth, the growth velocity curve. So growth is a dynamic process. So we can't just make a decision based on one scan to say that this baby is more for gestational age or is appropriate for gestational age normally. So basically what I'm saying about the fetal growth restriction definition, this is a functional definition which seeks to identify fetuses which are at risk of modifiable but otherwise poor outcome. Another term which I want to define is small for gestational age. Now, when we say a fetus is small for gestational age, this is when the fetal size via biometric evaluation falls below a predetermined threshold for its gestational age. Now, normally the fetal medicine units, and in many centers, they use the 10th centile as the cutoff. So basically what you are saying, if the weight is less than the 10th centile for that gestational age, then we say this baby is small for gestational age. When you compare to the definition of fetal growth restriction, this is an easier definition as there are clear cutoff points. And what we know is that small for gestational age fetuses in general are actually at higher risk of perinatal morbidity and mortality. And this risk is highest when the estimated fetal weight is less than the 3rd centile. The other thing that we are aware of is that the majority of fetuses who have fetal growth restriction are actually within this category. Therefore, the diagnosis of small for gestational age is actually pivotal in the identification of fetuses who are at risk of fetal growth restriction, because it helps us to define the population that is at high risk of fetal growth restriction. But let me hasten to say, small for gestational age and fetal growth restriction are definitely not the same. As you see here in this slides, which is describing fetal growth disorders and their diagnosis, on my left, you see that graph there, that line with those lines there. First of all, I want to highlight the solid line there. It shows babies who are for gestational age based on this graph here. These babies who are small for gestational age, they also start to fall off from their growth trajectory. And once they do this, then we say these babies are not only small for gestational age, but they are also there's also fetal growth restriction there. Then the second line that I want to highlight is this one, the lower one. This line here shows babies who are small for gestational age. but these babies do not fall off their growth trajectory. And so when they don't fall off their growth trajectory, this means that these babies most probably are normal small. And these ones, we normally say that they've constitutional smallness, and they're usually healthy, but small babies. And then when we look at this last line, dotted line here, as you can see, it is within babies who are appropriate for gestational age. But as we continue to follow up their growth of these babies, we notice that they fall off their growth trajectory. And once they do this, these babies, it means that they are also actually fit. There's also fetal growth restriction there, because basically they're failing to achieve their potential growth there because they are falling off their growth trajectory. And so the same thing is also highlighted in this right-sided chart that we have here. It's actually a study which was done by McCowan and others, where they were showing how customized birth weight centers predict small for gestational age pregnancies, which have with perinatal morbidity. What is of interest here is that in those babies who were small for gestational age, they actually find out there were 3 subsets. What are those 3? About 20% of them were normal within. Sorry about that. When I say normal small, it means that these babies following this line here, whereby they continue on their growth trajectory all throughout. And then there are abnormal small babies. These they form 15%. Now, when I say abnormal small babies, what it basically means that these babies had a pathologic problem which stopped them from growing well. So these babies who are abnormal small, for example, have trisomies, or may have been infected by congenital infections such as cytomegalovirus, and there's nothing that we can do to improve their growth, these babies who are abnormally small. And most important, there were these babies starving small, which form 65% of those small for gestational age. Now, the important thing is that when we talk about fetal growth restriction, we want to talk about these starving small babies who are subjected to an intrauterine environment which is not friendly, and then they fail to thrive in utero. So what we know is that fetal growth restriction is a common and complex problem in obstetrics. It affects about 10 to 15% of all pregnancies. And this depends on which studies and which population is being studied. So on average, it's about 10 to 15% of all pregnancies. These fetus is at increased risk of perinatal morbidity and mortality. But what is of interest is that also they have long-term complications. If they manage to survive the neonatal period, what happens is that in childhood, they're at high risk of having short stature, of having growth delay, neurodevelopmental impairment, and even cerebral palsy. Whereas when they become adults, they're also at high risk of what we call non-communicable disease, which is characterized by the metabolic syndrome. And by metabolic syndrome, I mean a group of diseases which are characterized by hypertension, dyslipidemia, obesity, type 2 diabetes mellitus, which increase the risk of coronary heart disease and stroke in these people. So in summary, it is imperative to diagnose fetal growth restriction if we are to avoid the risk of perinatal morbidity and mortality that is associated with it. And possibly we may also be able to avoid future handicap, as we talked about their problems in childhood and later on as adults. So the challenge to us clinicians is to identify fetuses with fetal growth restriction whose health is endangered in utero because of the hostile intrauterine environment. But at the same time, we should recognize that there are some healthy but small fetuses, and hence avoid iatrogenic harm to these fetuses. Now, which pregnancies are at risk? Basically, what we can say is that any pregnancy where either gas exchange and or nutrient delivery to the fetus is not sufficient, is compromised in other ways, to allow the fetus to thrive in utero will be at risk of having fetal growth restriction. Now, this may be due to maternal diseases or to even some maternal habits which cause a decreased oxygen carrying capacity. Now, if we think of it, we can think of critical heart disease. This may be some congenital heart disease that is cyanotic in nature, but even acquired heart disease, if it's very severe, it may still cause also fetal growth restriction. Then we think of also some hemoglobinopathies. In this case, in our country, we have sickle cell anemia. And then also some habits like smoking. If the mother is a chain smoker, then this may actually decrease also oxygen carrying capacity. We may also think of circumstances where there's dysfunctional oxygen delivery system, which may be due to maternal vascular disease. By maternal vascular disease, I mean hypertensive disorders of pregnancy, and also some autoimmune disorders, which may affect the vasculature leading to the placenta. Then also there's direct placental damage that may occur in some cases, like if the mother has some thrombophilias or some autoimmune disorders, or if the mother smokes, not only will the oxygen carrying capacity be decreased, but also this can cause direct damage to the placenta. Also, we think of people with chronic renal disease, whereby nutrients and gas exchange is compromised to the fetus. Then there's also recurrent, there are also individuals, they may not have these conditions which I mentioned, not in these groups, but also they may have a history of recurrent pregnancy loss, or they may have a history of a previous unexplained stillbirth. These people are also at high risk of having fetal growth restriction if they fall pregnant again. And those people who screen positive for preeclampsia at either the 11 to 14 week scan or the 20 to 22 week scan are also at high risk of having fetal growth restriction. So whenever we see these patients in front of us, we should always be aware that these patients may end up having a baby with fetal growth restriction. So they need to be under close surveillance. Now, how do we diagnose fetal growth restriction? We have two basic tools that we use: fetal biometry and Doppler velocimetry. When I talk about fetal biometry, basically what I'm saying is that when we do the fetal biometry, in the end, we'll get an estimated fetal weight of the baby. And we can use this as a criteria to be able to diagnose fetal growth restriction. Whereas Doppler velocimetry, what we're basically doing is just interrogating the blood flow within different blood vessels. And from there, we see the flow, where it's going, the direction of flow, and also the characteristics of the flow. So firstly, with fetal biometry, at any given point, if the dating is correct, that's one caveat that we have to be aware of. When we have proper dates for this baby, and also we've ruled out any congenital anomalies, any trisomies, no infections with no congenital infection like cytomegalovirus. These are what we would expect to be a healthy baby, but we see that it's falling at less than the third centile for the estimated fetal weight for gestation. Then this baby fulfills the criteria of being classified as having fetal growth restriction. Usually the babies don't come in this manner. What we see is that they may actually be small for gestational age, or they may have a decrease in their fetal growth velocity, where they fall off their growth trajectory. By this, I mean babies who are, for example, in this solid line, who are falling off their growth trajectory. So in this case, we may also be able to classify them as having fetal growth restriction. Also, these ones were within the appropriate for gestational age category when you initially start scanning them, but later on, they also start to fall off their growth trajectory. These also should be classified as having fetal growth restriction, but these are a little bit more difficult to diagnose. In terms of Doppler velocimetry, we can interrogate the maternal uterine arteries. The maternal arteries enable us to interrogate the uteroplacental function, basically. Normally in pregnancy, what should happen is that there is a physiologic transformation of the uterine arteries from high to low resistance vessels. But in preeclampsia, or in those who are going to have fetal growth restriction, what happened is that there is persistence of the high uterine artery PI, which is above the 90th centile, and this is associated with placental insufficiency. So this will help us to tell which pregnancies may be complicated by fetal growth restriction if we do it at the 11 to 14 week scan. Or usually this is for early onset fetal growth restriction, which tends to occur with early onset preeclampsia. Or if we do it at the 20 to 22 week scan, then it helps us to see pregnancy, which may later on be complicated by late onset fetal growth restriction. I will clarify a little bit later on this early and late onset fetal growth restriction. Still on Doppler velocimetry, we can also look at the uterine artery Dopplers. For the uterine artery Dopplers, placental vascular insufficiency is reflected initially by, as you can see here, a decreasing in the end diastolic flow. And as the pathology continues, then there may be an absent end diastolic flow. And as it gets even worse, then there may be a reverse end diastolic flow. This basically corresponds to a progressive decrease in the placental surface area, which is available for both gas and nutrient exchange. Whereas the middle cerebral artery and ductus venosus Doppler velocimetry can be done, but these ones now reflect the response of the fetus to the hypoxemia. Firstly, if I start with the middle cerebral artery waveform, what you see here on top is a basically normal waveform for the fetus, especially in third trimester. But in preterm babies, it may even be just you'll see here systole, and then at the end, so there might even be nothing there. This is again a normal tracing, especially in the very preterm. But if we find that the waveform has become like the bottom one, whereby the end diastolic flow has become much fuller there, it's almost like an umbilical artery Doppler there, then this shows that the baby has is suffering from fetal growth restriction. And then with okay, when we look at the ductus venosus, also in the ductus venosus, first of all, I want to just highlight the waveform that we should normally expect from the ductus venosus. It consists of the ventricular systole and ventricular diastole there, and then here there's an atrial contraction here. So all the waves should be positive, including the A wave here at any given time. But then if the A wave starts to decrease and later on becomes negative or absent, then it means that there's a problem. What basically happening in the ductus venosus is that there's a progressive dilatation of the ductus venosus isthmus in order to increase the blood flow towards the heart. And this is in an attempt to compensate for extreme oxygen deprivation. Now, this will result in initially an absent A wave and later on a reverse A wave. So here we see that the A wave has become very small there, and then here it's reversed the A wave. So these are some of the things that may actually happen as the baby continues to suffer from fetal growth restriction. So the role of Doppler velocimetry is threefold in this case. Firstly, it can be used for screening, as I talked about the 11 to 13 week scan, and also the 22 week scan where we can do the uterine artery Dopplers, which will help us to screen for babies for pregnancy, which may be complicated by fetal growth restriction. And then also we talked about diagnosis. They can also aid us in diagnosis to see that the baby has fetal growth restriction, especially when we see babies who are appropriate for gestational age. If we do Dopplers and find that they are deranged, then this is actually another diagnostic criteria to say that these babies have fetal growth restriction. Then it also helps us in surveillance and later on management of these complicated pregnancies. And now I'll move on to the recognized phenotypes for fetal growth restriction. Basically, there are two recognized phenotypes. There's early onset fetal growth restriction and late onset fetal growth restriction. Our cutoff point is 32 weeks. Those babies with fetal growth restriction at less than 32 weeks tend to have what we call early onset fetal growth restriction. And those who have fetal growth restriction from 32 weeks and going onwards have what we call late onset fetal growth restriction. This differentiation into early and late onset fetal growth restriction is very important. It's not only in terms of when they manifest, but even then the way that they manifest. First of all, let's talk about the prevalence. Those with early onset fetal growth restriction tend to be less, that there's 30%, whereas those with late onset fetal growth restriction are 70% of the whole of babies who have fetal growth restriction. And then if we do an ultrasound scan, usually we tend to recognize the ones with early onset fetal growth restriction much easier, because the fetuses tend to be very small. So we can actually say that these babies will be small for gestational age, or maybe might be very severely growth restricted, so that they are less than the third centile. But not so for late onset fetal growth restriction, as these fetuses may not necessarily be small. So it may be a dilemma to actually diagnose them. And then when we look at Doppler velocimetry, what we recognize in the early onset fetal growth restriction is that they have the whole full spectrum of Doppler alterations that they've seen early enough, that involves initially the umbilical artery derangements, then go on to middle cerebral artery derangement, and also ductus venosus derangements. Whereas in the late onset fetal growth restriction, it may only be the cerebral blood flow that is altered by redistribution. And hence it may be difficult to recognize this, especially when we send patients outside for other scans. They tend to do only the umbilical artery Doppler. So we may think that the baby is actually healthy based on a normal umbilical artery Doppler, when actually this baby has late onset fetal growth restriction if you were to do all the Dopplers. And then also in early onset fetal growth restrictions, they tend to be hypertensive disorders of pregnancy. They tend to be more frequent. And because of this, since they tend to be more frequent, they actually help us to have a high index of suspicion when we see a patient. Once we hear that they're hypertensive, then we think they may also have a baby with fetal growth restriction. Unlike in late onset fetal growth restriction, they may actually not have any hypertensive disorders. Then also when we look at the placenta later on histopathologic examination, the placenta tends to have poor signs of poor implantation, with the spiral arteries being abnormal, and the maternal vascular resulting in maternal vascular malperfusion of these spiral arteries. But when we look at the histopatology of the placenta in late onset fetal growth restriction, they tend to be less specific placental findings, mainly due to altered diffusion. And then when we look at perinatal mortality, obviously with all these things that are happening, it's going to be high in these 30% of babies with early onset fetal growth restriction, but it's lower in the late onset babies with late onset fetal growth restriction. And the main clinical challenge then in this is that early onset fetal growth restriction is much easier to recognize, but it is more difficult to manage. Whereas late onset fetal growth restriction is much more difficult to detect, but usually the babies are bigger, and once we detect it, it's easier to manage these babies. Okay, sorry about that. Now, in the diagnosis of early onset fetal growth restriction versus late onset fetal growth restriction, there are criteria which are almost the same, but there are some slight differences. Now, in early onset fetal growth restriction, as I said, we must have properly delayed this pregnancy, and there will be there must be an absence of congenital anomalies. If at any given time the abdominal circumference or estimated fetal weight is less than the third centile, or if at any given time the umbilical artery shows an absent end diastolic flow, then in this case we say that these babies have fetal growth restriction. Or another criteria that we may use for early onset fetal growth restriction, again, the estimated fetal weight is low, but in this case less than the 10th centile. And then also we find that the uterine artery PI is greater than the 95th centile. Then we say they have fetal growth restriction, or if the umbilical artery PI is more than the 95th centile. So these are criteria that we use to diagnose early onset fetal growth restriction. Whereas in late onset fetal growth restriction, Again, the estimated fetal weight may be less than the third centile. That is sufficient for us to make the diagnosis. Or we must have at least 2 out of these 3. That is, the abdominal circumference is less than the 10th centile. That is, they are fulfilling the criteria for small for gestational age. Or the estimated fetal weight or abdominal circumference actually crosses centiles more than the 2 quartiles on growth centiles. Or what we call the cerebral placental ratio is less than the 5th centile. When we talk about cerebral placental ratio, what we are basically saying is we have a ratio of the cerebral vascular Doppler PI, pulsatility index for that, and then the pulsatility index of the placenta blood flow. In this case, if we compare them and they're less than the 5th centile, then in this case, we can say that this baby has fetal growth restriction. Whereas also we can look at the umbilical artery PI. If it's more than on its own, the 95th centile, then in this case, we say that the baby who's small for gestational age actually has late onset fetal growth restriction. Now, once we recognize that this baby has fetal growth restriction, or even that they are at high risk of fetal growth restriction, we tend to put these babies on surveillance. And the surveillance tools that we have are biometric assessment of the baby and Doppler studies, which we use again to diagnose the fetal growth restriction. But in addition, when these babies are under surveillance, then also they must have we must do a fetal biophysical profile for these babies, and we also might use the CTG to also monitor these babies. Ideally, we should use a computerized CTG, but in our setting, we don't have this. So these are basically showing, slide is basically showing the surveillance tools that we have. And then what are our surveillance goals? Why are we putting them under surveillance? Firstly, we want to assess the extent of fetal hypoxia and or acidosis at any given time. We also want to assess the rate of clinical deterioration of the fetus as we look at the way that they are growing and also the way that their Dopplers are becoming more and more affected. We also want to assess whether at that particular time that we are seeing them, they are at risk of intrauterine edemas or at risk of stillbirth. If we think that the risk is sufficiently high, then we may want to plan delivery. So to decide on timing for delivery. But if we think that the risk is not that high for intrauterine edemas at the particular time that we are seeing them, then we may want to plan for an appropriate interval for their next review or for their next assessment. And then we also, if we are to decide on, if we think that delivery is near or is imminent, then we may also want to administer antenatal steroids. And also give, once we have decided that we are going to deliver definitely, then we also want to give magnesium sulfate to the very severe preterm babies who are less than 30, who are up to 33 weeks and below. So those are our surveillance goals. Now, in terms of surveillance for early onset fetal growth restriction, we have different scenarios. So the first scenario which I'll talk about is if we have said that the baby has fetal growth restriction, but the fetal Dopplers are still normal. Then in this case, we're going to subject them to surveillance every 2 weeks, whereby we do growth scans. And at those times when we do growth scans, we also do their Dopplers. So every 2 weeks, we are seeing these babies. Whereas in scenario number 2, we have said that this baby has fetal growth restriction, and now the fetal Dopplers are also abnormal in the form of a high umbilical artery PI or a low middle cerebral artery PI. Then we want to see them more frequently, these with abnormal Dopplers. We now begin to see them weekly. Scenario 3 is when fetal growth restriction is there, and now there's further worsening of the Dopplers. By further worsening, we mean that the umbilical artery is now absent or is reversed. In this case, we want to see them every 3 days. And when we see them, we do not only do the Dopplers, but we also do a CTG. So when do we deliver? We're monitoring these babies either every 2 weeks or monitoring them after weekly, or monitoring if the situation has become dire every 3 days. Now there's a Doppler criteria that we use to be able to decide that it's time for delivery if the baby is less than 32 weeks. We use what we call the absent or reverse ductus venosus A wave. Once this ductus A wave becomes reverse or is absent, then it is time to deliver the baby. And when we want to deliver the baby, we don't dilly-dally. We should deliver the baby urgently within 24 hours. The truffle study is the one which guides us in making this decision. It showed that evidence that time of delivery based on ductus venosus plus, in this case, they had computerized CTG, improves long-term neurodevelopmental outcome in the surviving infants. Whereas now, when it's late onset fetal growth restriction, as I said, diagnosis is a little bit more challenging. You may have an abnormal uterine artery Doppler, but you find that the umbilical artery Dopplers may actually be normal or mildly abnormal. And then for you to diagnose it, then there's abnormal middle cerebral artery Dopplers. So once this criteria is fulfilled, then we say that there's late onset fetal growth restriction. And then in terms of surveillance for this late onset fetal growth restriction, we have also a number of scenarios, 3 scenarios, which I'm going to describe. In scenario 1, fetal growth restriction, but with normal fetal Dopplers. Then in this case, we want to see these babies every 2 weeks, where we do growth and Doppler scans for these babies. Scenario 2, now there's also elevated umbilical artery Doppler PI. Then we see them weekly for these Dopplers, but in this case, we also do the biophysical profile and score them. In scenario 3, where there's now very low MCA PI, or the cerebral placental ratio is now low, then in this case, we want to see them every 2 to 3 times per week, and where we do Dopplers and also biophysical profile score. When then do we deliver these babies? In this case, the decision to delivery, when the babies are more than 32 weeks or they've late onset fetal growth restriction, is guided by these abnormal Doppler. If the umbilical artery Doppler PI is greater than 95%, and the middle cerebral artery PI is less than 5%, and the baby is at term, immediately at term at 37 weeks, then we must deliver. If there's fetal growth restriction, but the fetal Dopplers have remained normal, then in this case, we want to deliver between 30 and 39 weeks, and not more than 39 weeks. We don't continue waiting once we have said that this baby is a late onset fetal growth restriction. These are the Doppler criteria that we use to make decisions in terms of when to deliver these babies. But what is important to highlight is also that there are other clinical indications for delivery that may be there, and we must pay attention to this. If there are obstetric complications such as placental abruption, or the maternal condition has become such that she can't continue with the pregnancy anymore because she has severe preeclampsia or preeclampsia with severe features, or they've actually fitted they have eclampsia, or they have HELP syndrome, then by all means, these mothers should be delivered at whatever gestation this baby is. It does not matter whether it's early fetal growth restriction or late fetal growth restriction. Why it's important for me, and why I think this slide is important, is because we often realize that our juniors, they keep patients in the ward saying that this patient came on Friday, but the fetal medicine unit is closed. So they wait for a scan, and then yet this patient came with preeclampsia with severe features, or they'd even fitted. So this is very important that besides the ultrasound scan criteria for when to deliver, there are also other clinical indications which we should pay attention to. Thank you.
Thank you so much, Dr. Fachayo, for a great presentation. To our guests, I want you to know that Dr. Fachayo will be available to answer a question on the chat box, and also she could answer them in real time after the next presenter. So after the next presenter, we are going to have question and answer segment to all the three presenters. So please be with us. And Dr. Lacho and Dagura, please stay around, guys, and respond to the question from the guests on this meeting, on this course. The next presenter, admin, you can allow, Dr. Lacho, you may unshare your screen, allow the next presenter to share her screen. The next presenter is a colleague. She's a specialist pediatrician and a specialist neonatologist, Dr. Masha Mangiza. Dr. Masha Mangiza, I have a special history with her, not the one which people may think, but we were together in France during our final year of residency. I was doing obstetrics and she was doing pediatrics. What we were exposed to in France caused our hearts to burn. I was burning in the area of fetal medicine, and she was burning in neonatology as she was looking at the gap that existed between our two worlds. One, the Francophone world, a developed country, and Zimbabwe, a country that is pretty much stuck in the 1970s. So we were discussing a lot of time, say, how can this be that our services are so backward and so unupdated? But I'm very glad that Dr. Mangiza went on to pursue neonatology as part of the transformation of our health service, because we need young people who want to go a step beyond the boundaries of our seniors. So I'm glad to introduce her, Dr. Masha Mangiza. She would be teaching us on how base fetal growth restricted babies should be looked after when they are born. Her talk will help obstetricians, sonographers, midwives to know how to talk to the women whose babies are affected by baby growth issues. Because they will obviously ask you, what will become of my baby? What will happen? The aftermath is what most women would want to be addressed. So please don't take this lightly. Admin, allow Dr. Mangiza to share a screen so that as soon as I finish, she can start. So remember, it is not the diagnosis that we have made that makes that this woman wants to be addressed. It is the aftermath of your diagnosis. To say, yes, you have told me the baby is small, what will become of this baby? So this is what Dr. Mangiza will teach us today so that we are better informed. For those who are not aware, neonatologists, these are pediatric doctors who went on to subspecialize in looking after sick babies, babies who are not doing well. That is their mandate, very preterm, extreme preterm baby. That is their area of specialty. Dr. Mangiza, the floor is yours, please. You may start.
All right. Thank you very much, Dr. Verenga, for the nice introduction. Like he said, my name is Dr. Masha Mangiza, and our job is to take care of the babies that you take care of for 9 months in utero. And then once they are out, we take care of them. I'm happy to be part of this presentation. Let me just try and share my screen. We're just trying to maneuver our way through this. I'm at the fetal medicine place. Please just give me a minute or two to try and find how I can share my screen. I don't think it's viable. Let's see. Password. Can I send it to you? Then maybe I use your computer.
Yes, I think.
Okay. Sorry, just a minute, please. Sorry.
While Dr. Mangiza is bringing the screen up, let me just remind all the delegates in this meeting that the CPD points will be given. As you are aware, your meeting, you registered it using your identity, and that is the identity that will be put on the certificate. If you have a different identity from the one you registered, you might have to directly communicate with the admin team. The admin team, please put your details on the chat box so that everybody knows know how to contact you. And the CPD points will be given depending on the hours you attended. It was a whole day meeting. We are aware that some people probably have 2 hours to attend this meeting. The total amount of CPD points is 8 points. So if you do, the system is able to capture when you logged in and logged out. So they will calculate your CPD points and allocate your CPD points and certificate depending on the number of hours you have participated in a course. Well, this is more of a course format. Because it is a course where certain main subject areas are being taught, we encourage you to ask as many questions as you can in the chat box to interact with the presenters so that they can address the concerns that you may be having on the subject area. Dr. Mangiza, when you are ready, you may proceed right away. Maybe to just save time, while Dr. Mangiza is sorting presentations, we could open questions for the 2 presenters so that we will reduce the question time after. Any questions, just throw them in the chat box and the presenters will ask you or will answer you accordingly. Do we have any questions for the presenter? We encourage you to just have a working
Dr.
key.
Virenga. Yes, Dr. Virenga.
Aye, Dr. Ndagura, please go ahead.
There is a question in the chat box from Dr. Mushanga Jike. He had asked if we can classify fetuses with TAPes and hydrops as twin-to-twin transfusion syndrome stage 4 using the Quintero classification. I was trying to respond to his message in the chat box, but I failed to send the message. So I just wanted to explain to him that I don't think we can do that. We should not do that because TAPes is different from twin-to-twin transfusion syndrome. The differentiating factor is that, of course, there's fetal-fetal transfusion in both circumstances, but in TAPes, we don't have the oligohydramnios polyhydramnios sequence. So that is the differentiating factor. And we stick to the peak systolic velocities discrepancy in the middle cerebral arteries. So that's what we are going to use to differentiate the hydropic TAPes baby from the stage 4 twin-to-twin transfusion syndrome baby. Thank you.
Hi, it's Dr. Tlachwayo. I'm also failing to somehow answer in the chat box somehow. I don't know why, but there's a question which says after 30 is from Carol Van Roy, I think. It says after 30 weeks, if uterine Dopplers are abnormal and umbilical and middle cerebral arteries are both normal, can we still classify this baby as having fetal growth restriction? I think you remember what I said about these babies were a little bit more difficult to diagnose with fetal growth restriction. If you do one measurement only of the baby or several, you might actually find that this baby is in the appropriate for gestational age category. But what is important is that as we continue following them up, if they fall off their growth trajectory, then these babies most probably have fetal growth restriction. But to make that diagnosis, if they fall off this trajectory by more than 50%, the baby before, when you were measuring, they were growing at 70%. And next time when you measure them, after several weeks, you find that they are now growing at 20%. They've fallen off the growth trajectory by at least 50% or more. In this case, then we should say that they have fetal growth restriction. I hope that's clear. So these are babies are a little bit more difficult to diagnose because actually just one measurement will make us think that they are growing appropriately for gestational age. But once we follow their growth trajectory, that's when we'll be able to realize that they are failing to reach their growth potential because they are falling off their growth trajectory. Thank you.
And to just emphasize what Dr. Hachayo said there, and said this is one of the reasons why women with abnormal uterine Dopplers, uterine Dopplers, not umbilical, should be followed up. This is why they should have serial growth scans, because their risk is so high, so that if you just use an arbitrary cutoff and say they are within the 10th and 9th center, for sure you will miss this abnormality. So we should pay attention to the uterine artery Dopplers. They are very important in trying to identify babies at risk. So just to make the issue very simple, especially for our students who are in this meeting, myself as a student, I struggled to understand TEPS and also actually TTTS. Whenever you go to the pediatricians, I'm glad my pediatric colleague is in this meeting, but whenever you go to the pediatricians, they would speak of a pink and pale baby. In that condition will be assigned as TTTS. But when I did fetal medicine now, I learned that TTTS is an entity which is different from TEPS. TEPS is what gives us the pink and the pale baby. When they are born, the one is pink, the other one is pale. TTTS may coexist with TEPS in about 15 to 30% of the cases. So that the majority of TTTS cases may not show the pink and the pale picture at birth. So remember, TTTS is an imbalance of the fluid, while TEPS is an imbalance of the hemoglobin. But TTTS may coexist in TEPS, and it follows laser coagulation of vessels in TTTS in about 10 to 15%. You end up with TEPS. So probably it is this coexistence of this condition that has led to the confusion, which I highlighted when I started. Admin, do we know the situation of Dr. Mangiza? Because if Dr. Mangiza's situation is not happening, we could probably move on to the next speaker, and Dr. Mangiza would come after the next speaker.
Morning, Dr. Verenga. We are with Dr. Mangiza. We just had the internet problems, but we're almost connecting now. We're just connecting.
Excellent, excellent. So it's fair enough. So we're going to wait for Dr. Mangiza to share with us. I think a presentation is probably one of the most important presentation of this meeting. The subject of fetal growth restriction has been grossly discussed amongst the pregnant women care team. When I'm referring to the care team, I'm referring to everyone who looks after pregnant women, from the radiographer who does the scan, to the sonographer, to the midwife, to the GP, to the obstetrician. Women have good questions, real questions, whenever they come with small babies. They want to know, is my baby going to be like others at home? What is it going to be like after birth? How long is my baby going to stay in nursery? What are the special needs will my baby need as they grow? Are they going to go to school and become doctors like you? These are the real questions that pregnant women have when they are seated in front of you. So I feel that the presentation by our neonatal colleagues will help inform all practitioners who deal with pregnant women, because pregnant women need our service in its completeness, not in part. It's not right in 21st century to see a pregnant woman, you tell her that there's a problem, but you can't answer a single question that follows the problem you have told the woman. You need to have some idea, or to start somewhere when you know that others will finish off the talk, but at least you have some good idea of knowing where to start. What kind of message should I give them? How to package that kind of message, because that is what you call proper healthcare, where women have to be counseled concerning the condition that we have told them their baby has. So very important presentation. Are we winning that side? Or the floor is still open for questions. Those with questions, you can throw in questions to Dr. Tlachwayo and Dr. Ndagura. Thelma, please feedback to us. We want to know what we should do, whether we can allow Sister Chinama to come in, or Dr. Mangiza is coming in now.
We
Yes.
are winning. We're just trying to share the screen.
Perfect.
Yes.
Perfect. Yeah, if you go to slideshow, yeah, excellent. That part there.
Okay.
From beginning.
All right. Okay. I'm so sorry for the glitch, but nevertheless, I'll start my presentation. Mine will not be a very long presentation.
If you could go closer to the mic, Dr. Mangiza, because we are barely.
You can't hear me.
Yeah, it's faint.
How is it now?
Is it getting better? Thank you.
Getting better. Okay. All right. So as has been defined before, fetal growth restriction is defined as a fetal weight which is less than the 10th centile for gestational age. Okay. Infants are identified because they are born small for gestational age, with a birth weight which is less than the 10th percentile for gestational age, using specific growth charts. So, like what Dr. Tlachwayo had said, small for gestational age and fetal growth restriction are not necessarily synonymous. But in areas where there's a high prevalence of small for gestational age. In low resource settings, 1 in every 5 infants is actually born small for gestational age. Connection. Sorry, can you hear me? Hello?
Okay, we can hear you.
You can hear me. All right. So in low resource settings, I was saying 1 in every 5 infants, which is about 20% of infants, are actually small for gestational age. And small for gestational age contributes to 22% of neonatal age, so more than a fifth of neonatal age. And we find that the incidence of small for gestational age increases with decreasing gestation age. So when we assess these babies who are small for gestational age or who've got intrauterine growth restriction, we divide them into those with symmetrical intrauterine growth restriction and those with asymmetrical intrauterine growth restriction. The ones with symmetrical IUGR, it means that their head circumference is small and also their weight is small.
Guys, I think you may need to turn off one of the mics there, which are probably interfering with each other.
And their is also there's a lot of echo.
Mics, I think in the same place. I don't know where Kuda is. Is Kuda with you? I think one of her device is a mic.
Hello, Dr. Belena, how is it now?
We can hear you, but there's some muffling. Some people may need to switch off their volumes. Those who are not speaking, they should make sure the volumes, their devices are muted. Not just the mic, but the volume part. Yeah. You can try now. We can still see your screen, Doc. You just need to slide share.
Okay, all right. I think it's a bit better now. How is it now?
Yeah, we can see it. But we want to hear you. I think your mic is muted.
My mic is, but can you hear me now?
Your mic is muted. There's one mic for Kudakwashe which is not muted, but that mic we can't hear it. I think you muted the mic which you were using. You might want to mute the other one.
So we must mute one mic.
Yeah, we can't hear you. You may need to unmute. If you mute the host mic, I think the host mic is what you were speaking through, the Fetal Medicine Foundation host mic. Unmute the mic for the host device. The Fetal Medicine Foundation device is the one with the mic which was working. If you could unmute it. The mic.
Okay, it's unmuted. Can you hear me now? Hello? Hello?
Dr. Mangiza, or the team at the admin, they kindly unmute your mic so that we can hear what she's saying. Kudakwashe, your mic, we can't hear it, so allow the foundation one. I think that is what she was speaking through.
Unmute.
Yeah, it's better. Unmute it. You've muted it again. Just unmute it again, the foundation one.
Then mute it.
Yeah, okay now. Yeah, okay. Keep things the way they are. Then Kuda, you may need to mute your device because it's giving echoes.
I'm using Kuda's device right now.
Ah,
Or maybe should I use the other device?
okay, because we can hear you. If you are seated next to your computer, you may be speaking through that computer because that is what you can hear.
Okay, am I echoing or it's okay?
You're now better. You're now better. You could proceed.
Okay, all right. So I said we divide these infants into symmetrical IUGR and asymmetrical IUGR, depending on if the head circumference and the weight are both below the 10th percentile, then it's a spared and the weight is below the 10th percentile, then that's asymmetrical IUGR. Symmetrical IUGR commonly occurs when the intrauterine insult occurs early in pregnancy. And we find that most of these babies with symmetrical IUGR may either have chromosomal abnormalities like the trisomies, or they might actually also have congenital infection. The babies with maybe with late onset preeclampsia.
Maybe we can use this as audio, and I can't hear though. So what are some complications?
Okay, ndoyatiri kushandisa for maslides. Kondanotisa kuti yefoundation ya-unmuta futi, so I think ndozvazvikonzeresa maecho. I don't know why it's. All right, so she can use my machine for the slides and then audio. She can use it. All right, that's fine. That will be some. Okay. All right.
Am I unmuted?
I'm sorry for the glitches, but I think they are coming through. They are just having challenge where they are. Dr. Mangiza.
Okay.
Yeah.
Can I go ahead?
Yeah, you are more clearer now. Please go ahead.
Okay. All right. I'm so sorry about this. So sorry about this. Anyway, so what are some of the complications that these babies face? We find that these babies come in, most of the time they come in prematurely. So there's prematurity which is involved when the babies have got fetal growth restriction. And there's always the debates whether the baby is better in or better out. That's always something that we need to discuss with the obstetricians and the perinatologists and the Fetal Medicine Foundation team, whether it's better to get this baby out or better for the baby to stay in. And then what we find is that babies who are small for gestational age plus preterm have a 10 to 40 times higher risk of mortality than the appropriate for gestational age counterparts. They are also at a high risk of perinatal asphyxia. So if they don't come prematurely, they come late. I mean, they're born either term or post-term. And then when they're born term or post-term, we find these babies most commonly in our public institutions that come out with perinatal asphyxia, encephalopathy, they come out meconium stained, and they get meconium aspiration syndrome, and they get persistent pulmonary hypertension of the newborn. And it's very difficult to salvage some of these babies when the fetal growth restriction is not
is not recognized early and the babies are not taken out early, and then they come late with some of these complications, which we find very hard to deal with. They also have impaired thermoregulation. They tend to get hypothermic, so we need to nurse them in a warm place in order to maintain good temperatures. So we need to nurse them either in isolates or in incubators. Okay. And then they also have polycythemia and hyperviscosity. I think some of them, because of they're deprived of oxygen in utero, so they respond by getting polycythemic. And then they also have impaired immune cell function, so they're at a higher risk of getting infections. They have hypocalcemia, and they also have feed intolerance. Okay. So in terms of our management, when you let us know, when the obstetricians let us know that, you know what, we've got a baby who has we've got a fetus who's growth restricted, our management starts right in the delivery room. We need to be prepared. So preparation involves many things. It involves the if it's a preterm baby, under 34 weeks, we expect that the baby should get steroids. So I'd like to encourage our Fetal Medicine Foundation team that whichever centers they work in, it's good for them to actually be able to administer antenatal steroids to these mothers. I'll give examples that, sometimes in private, a woman might be diagnosed, fetal growth restriction, abnormal Dopplers, and then they say to the mom, the baby needs to come out early. And then mom needs to go for admission. But sometimes these mothers take quite a while to actually come to the hospitals for admission. So it's better if obstetricians or the Fetal Medicine Foundation team actually start by giving the steroids to the mother at their rooms or at the clinics where they are running, where they're seeing these women, so that at least the baby stands a better chance. So we also make sure that in the delivery room where we attend to these babies, it's a warm delivery room and with adequate equipment. And we also need skilled staff. So for centers like our Salimu Gabe, our government institutions like Salimu Gabe, we're always encouraging the obstetricians that when you have these high-risk babies, please make sure that you call the pediatricians, or it's pediatricians in quotes, because sometimes it might be the senior health officer who comes or the registrar, but it's good for these babies to be resuscitated by a team of people, as opposed to just having the midwife on her own resuscitating these high-risk neonates. Okay. And then when we admit these babies onto our wards, it's very important for us to actually accurately assess the weight of the baby. You don't know how important it is to actually get an accurate assessment of the weight. We also measure the head circumference and we measure the length. For us, most of our mothers don't have early ultrasound scans. If we're looking at centers like Salimu Gabe and Paringatwa Hospital, for us, the most accurate measurement of estimation of gestational age is by an early ultrasound scan, which is an ultrasound scan before 20 weeks gestation. So because most of our mothers at these public institutions don't have early ultrasound scans, we do a postnatal assessment of the gestational age. We use what is called a Ballard score, which is basically we're looking at the physical characteristics of the baby, we're looking at the neuromuscular activity of the baby, and we are also looking at the development of the baby, like the skin, the ears, the tone. And then we use this assessment to sort of assess the gestational age of the baby postnatally. But it can be off by 2 to 4 weeks, and it's also variable depending on the skill of the person who's doing it. And then we need to plot this gestational age and the weight on appropriate charts. So there's always a debate as to what is the appropriate chart to use. Currently at Salimu Gabe, we're still using charts which are probably not appropriate. We're using what is called the Lubchenco charts, which were actually meant to be fetal charts. But I think we are pushing so that we move towards using the intergrowth charts, which is what we're now using in the private unit, because these charts have been tried and tested on babies from many different parts of the world. And then it's also important to do a thorough physical examination on these babies, looking for dysmorphism and for signs of congenital infections. Like I mentioned before, we manage these babies' thermoregulation. Most of the times, these babies require respiratory support. If they're premature, they require CPAP, which is continuous positive airway pressure. If they are term babies, they tend to have, they are meconium stained and may have meconium aspiration syndrome or persistent pulmonary hypertension of the newborn, and they may require either CPAP or mechanical ventilation or even high frequency oscillatory ventilation. They're at high risk of hypoglycemia, so we need to monitor their glucometers, especially in the first 12 to 36 hours. Nutritional support is also important because these babies were starving in utero. So we try to make sure that we feed them well after they're born. And then investigation for underlying causes are done where it's not known. Where we know that severe preeclampsia, we don't usually investigate, but find the underlying cause. Okay, and then these infants are at risk of neurodevelopmental delay and cognitive abnormalities. So we tend to do what is called high-risk follow-up, and this together with the developmental specialists so that we make sure that they reach their best potential. They're also at high risk of adult growth about this a bit. They're at risk of getting hyper, need to be followed up period, but even into adulthood. So just for a bit of statistics, I'm going to present to you a study which I did as part of my MPhil in neonatology, which is actually looking at this specific topic. So the title of this paper, which is soon to be published in Frontiers of Medicine, is called Morbidity and Mortality in Small for Gestational Age, Very Low Birth Weight Infants in a middle income country. So I think this definition, we talked about it already. And then why we use small for gestational age, like I mentioned before, is because it's commonly used as a proxy for intrauterine growth restriction. And in settings with a high prevalence of SGA, it is most likely to be a result of fetal growth restriction. So I'll use the term SGA as a proxy for fetal growth restriction. Okay, so the burden of SGA is very high in low and middle income countries, and the mortality risk associated with being preterm and SGA is substantially higher than either alone. And yet the outcomes of these infants is not well described in low and middle income countries. Like I'll give you an example, the outcome GA preterm babies at our own unit at Salim Gabe is a known town where I was in neonatology. So the objectives of the study were to compare the mortality rates of SGA infants with appropriate for gestational age infants. And I also compared the morbidity rates of SGA infants with AGA infants. We know that preterm babies face different morbidities, so we wanted to actually compare, is there a difference between those who are SGA to those who are actually appropriate for gestational age? And then the last object versus those who are asymmetrically growth restricted. I think I'm symmetrical versus asymmetrical. Okay, so what I did is I obtained data from the Vermont-Oxford Network Grusa-Scale database. So the Vermont-Oxford Network is a very big neonatal network. It's based in America, but it's got they have many centers all over the world. So what they do is they collect neonatal data from different neonatal units all over the world, and then they collate it up and they come up with they produce papers, they come out with recommendations from the data that they collect in different centers. So Grusa-Scale Hospital in Cape Town, where I trained in neonatology, is part of the hospital collects data, which also is part of the Vermont-Oxford Network database. So it's actually a very low birth weight database, which enrolls infants from 401 grams to 1,500 grams. So only the small babies or the tiny tots are included in this network. So we included infants who were between 501 to 1,500 grams at birth and between 27 to 30 weeks gestation. So we chose 27 to 30 weeks gestation because we wanted to capture both the SGA and the AGA who are within the weight band 501 to 1,500 grams. So we excluded neonates with major congenital or chromosomal anomalies, and we also excluded our twins because we know that the twins come out SGA because of constitutional, being constitutionally small, not necessarily because of fetal growth restriction. So for gestational age, we used an early ultrasound, which is an ultrasound less than 30 weeks to estimate the gestational age. But unfortunately, Cape Town is also a middle income country. So only about 30% of the women actually had early ultrasound scans. So the rest of them, we used the Ballard score or the postnatal foot length were used to estimate the gestational age. We used the Fenton growth charts for this study, which is a bit debatable because Fenton growth charts are actually not meant for developing countries like South Africa, but that's what we were using at that time. And then mortality was defined as death before discharge. Respiratory distress syndrome, which is also synonymous with hyaline membrane disease, was defined as the need for rescue surfactant, and bronchopulmonary dysplasia was defined as the need for oxygen at 36 weeks post-menstrual age. Okay, and then we also looked at intraventricular hemorrhage, and this was defined according to Papill's criteria as grades 3 or 4, which is severe IVH. These babies were also screened for retinopathy of prematurity and defined as severe retinopathy of prematurity. We defined early onset sepsis and culture and late onset sepsis and culture. We worry a lot about late onset sepsis because we believe it's hospital acquired and that we clinicians have something to do with it. All right. So in my study, in this study, we enrolled about 1,800 infants between 27 to 30 weeks, and we found that 12.7% of them were actually small for gestational age. This is quite high. In developed countries, you find that only about maybe 5% or to 7% of their very low birth weight infants are actually small for gestational age. But our study found that about 13% were small for gestational age. So this is just a table showing some of the demographic characteristics. So the gestational age was synonymous between the SGA and the AGA. And as we expect, the birth weight was much smaller in the cohort amongst the SGA, with a mean birth weight of 799 grams in the SGA group. The head circumferences were smaller in the SGA compared to the AGA group. Most of the babies who were SGA, their mothers had maternal hypertension, as expectedly so. And 73%, almost 74% of the SGA group got antenatal steroids, possibly because the ones who are fetal growth restricted are diagnosed and there's time, whereas sometimes the AGA group is a mother who just comes in labor and she's actually not received any steroids. We found that there were more females in the SGA group than the AGA group, but the prenatal care and whether the babies were inborn or outborn was similar between the two SGA and AGA. All right, this is just another graph just showing the proportion or the percentage of infants by SGA. We see that at 27 weeks, about 10% of the cohort was SGA, whereas by the time we got to about 30 weeks, maybe about 30% of the cohort was SGA. Then the results, these are risk ratios for morbidity and mortality. So what we found is that the overall mortality in this study cohort was about 19.7%. So about 20% of the infants in this cohort died. But we found that the mortality was much higher in the SGA group. In the SGA group, about 29% of the infants died, whereas in the appropriate for gestation gestational age group, it was only 18.5, and this was actually significant with 0.7. We also found rates of babies with bronchopulmonary dysplasia, necrotizing enterocolitis, and late onset sepsis in the babies with the SGA. I think those are the ones that are highlighted in bold in black. And then we also looked at the differences between mortality and morbidity in those who were symmetrically growth restricted versus those who were asymmetrically growth restricted, but we didn't find any differences. So we found a significantly increased risk of mortality among the SGA infants, and this is in keeping with other studies. The incidence of bronchopulmonary dysplasia was generally low in the study population, but it was significantly higher in the SGA group. So we find that these SGA infants get stuck on oxygen. There's a lot of theories which suggest that there's a lower prevalence of RDS in the growth restricted infants, because the theories say that because they are growth restricted, they get cortisol in utero, and then they tend to get less RDS, but our study did not find this difference. So if these mothers with growth restricted babies still need the antenatal steroids to help these babies, because there's actually no difference in the RDS between the two groups, according to our study. Okay, necrotizing enterocolitis was significantly higher in the SGA when looking at the entire population. So this suggests a high mortality for SGA babies who develop NEC. So what we found is that most of the babies who were small for gestational age died of had necrotizing enterocolitis. So we may have to, we might have to have protocols which actually make sure that the SGA babies get mother's milk, because if they don't, they're actually at a very high risk of getting necrotizing enterocolitis. And also SGA infants had an increased risk of late onset sepsis. Other studies have noted increased rate of use of central venous catheters due to delay in reaching full feeds. So what happens with these SGA infants, just from my experience, is that most of the time they've got feed intolerance. So in Cape Town, we were actually able to give total parenteral nutrition to babies who struggle with feeds. So the moment you start giving total parenteral nutrition and you're putting central lines in these babies, there's actually a high risk that they get sepsis and they can actually die from the sepsis. So our study also showed a high risk of late onset sepsis in SGA infants. So the strength, it was a large sample size study which was done I looked at data which had been taken over a 6-year period. It's good quality data. All the data which goes to the Vermont Oxford Network database is really scrutinized, and we've got strict and standard definitions, and there are people who are employed at Groote Schuur Hospital to actually collect this data, who actually work specifically on collecting this data. But one of the limitations that we had is that only about 30% of the study population had an early ultrasound scan, which is a common problem or common issue in low resource settings like ours. So in conclusion, SGA, small for gestational age infants at GSH, have approximately twice the increased risk of mortality compared to their appropriate for gestational age counterparts. They also have an increased risk of dysplasia, late onset sepsis, and necrotizing enterocolitis. So these findings are important for perinatal decision making, and this is a study that was done in Groote Schuur Hospital in Cape Town, but can also be comparable. We know that these infants between 27 to 30 weeks, their risk of mortality is also high. So it's important for us when we are counseling the mother, and even for perinatal decision making. So this is just some of my references. So some of the take-home messages that I thought I'll just put through across from this presentation is that fetal growth restriction significantly increases mortality in neonates, and we need to accurately assess gestational age. We're really happy that there is the Fetal Medicine Foundation society or team. It's important for us to encourage our mothers to book early and to have an early ultrasound scan so that we can actually have a good estimate of what the actual gestation of this neonate is. Like at Harare Hospital, we hardly ever see mothers with early ultrasound scans. And then we need to use charts that are suitable for our population. I talked about the intergrowth charts. And then we need to improve data collection on our outcomes. Sad to say, we at Salim Mugabe Hospital, we have the NeoTree, which collects data on outcomes of neonates. But at the moment, we're not yet collecting, we don't have any data that is specific for small gestational age. But just from our clinical examination, we can tell that most of the babies that are in that unit are actually growth restricted. And then there's always need for collaboration on perinatal decision-making as you, the obstetricians, see these mothers. It's important for us to discuss together as we make decisions and also as we counsel these parents. And then I'll just end my presentation with a slide of one of our pretty tiny tots. This was a little girl who our team managed. She was a growth restricted baby born at 28 weeks plus a couple of days with 800 grams. You can see that her head is a bit on the big side. It was an asymmetrical IUGR. She spent about almost 60 days in hospital and then finally discharged at 1.8 kgs. We struggled with feeding her, but we pulled through even without total parenteral nutrition. And that's a current photo of her now. She's 5 months and she's lovely. Thank you.
Thank you so much, Dr. Mangiza. Very eye-opening. I'll open the questions, some burning questions that we may have for Dr. Mangiza. I think the first two presenters with the opportunity to ask. Do you have any questions you want to ask Dr. Mangiza right away? We may pause, or if you're a panelist, you are more than welcome to speak on the questions. Well, probably while questions are coming, let me comment, Dr. Mangiza, and say I think I'm just happy that your study there showed us that there is a difference between babies who are SGA and those who are AGA, but more or less in the same weight category. I think if we could give you a challenge to say, I think on your indices, the ones you report, the perinatal indices, we know we are still doing the age categorization of babies, where we are saying between 500 and probably 1,000, what is the take-home rate? If we could subclassify those babies into those who are FGR and those who are not, I think it will give us a better message. Because honestly, you may be born 800 grams because you are 26 weeks, but if you are 29 weeks and they are born 800 grams, you can't have the same survival rate for sure. The other one was starved in their mother's womb and they become malnourished, kwashiorkor in the uterus. The other one was just unfortunate that their mother's cervix was not strong enough to hold them inside. So all these issues, I think we need them to become more clearer so that the management protocols can address these babies according to their need.
Yes, that's very true, Dr. Verenga. We need to work on that. Like I said, currently our NeoTree, which is the database that we have for Salim Mugabe, is actually not classifying these babies into those who are fetally growth restricted or those who are appropriate for gestational age. But I think it's very important for us to do. And like I also highlighted to you, I think we actually need to start by dating the pregnancies accurately, because at Salim Mugabe, we really struggle to get an accurate assessment of gestational age, because the women have never had a scan. The last normal menstrual period is very, it's not a very good measure to estimate gestational age. So maybe if we will probably try and get accurate charts, but I don't know how we can encourage our women or to at least get an early ultrasound scan, or I don't know if we are able to get services for many women to get early ultrasound scans.
Maybe I may come through. Let me say for Sally Mugabe, probably, I think we've sort of done a chunk, half a chunk of the women who come to Sally. They have a scan. I think it is now incumbent on your team to look for the dates which have been validated by the fetal medicine units, because what we are trying to do in the fetal medicine units throughout is all women we are seeing, we are trying to validate their dates by the best estimate. So you will see that Sally Mugabe, I think 50% now, almost 50% of the women, except those who come already in labor, but anyone who gets admitted invariably has a scan from fetal medicine. So if you just encourage your team to check the ultrasound scan report that these women will be having in their books. But more than half of women, I can assure you, if their dates are validated by the fetal medicine unit team. So yeah, so it's something to check out. Do you have any questions for
Okay,
Dr.
I think we'll try.
Okay, for Dr. Mangiza,
and see if we can get more numbers with of women with actually validated scan.
Excellent, excellent. Any question for Dr. Mangiza? Dr. Mangiza told me that she's on call today. You know, they work as a team of 3 neonatologists and they rotate their call. So she actually took time off her call duties to come and present to us. And we really want to appreciate to express our appreciation to you, Dr. Mangiza. Thank you for making this sacrifice. We believe it will go a long way in improving our understanding of the small babies and also how they are looked after post-birth. So thank you so much for doing this, and we really appreciate it.
Thank you, Dr. Verenga. It was a pleasure. Thank you very much.
Thank you so much. The next presenter is one of our pioneer fetal medicine midwife. When we started fetal medicine, we realized that there is no way we can start anything without the midwives. So we went searching for the midwives. We went to the matron's offices and we sat down with the matron and said, look, matron, we want to start a unit here and we want some midwives. So some midwives, 2 midwives came to me and they expressed their passion and they never left. So Sister Chinama is one of the pioneer fetal medicine midwife. She's passionate about fetal medicine, and throughout the 3 years we have been practicing, she has dealt with a number of women who go through some very traumatic experience. There is the other side of fetal medicine, which people who are not in the field may not be aware. Let me say around between 15 to maybe to 30% of the women we see, unfortunately, we make them cry, these women, because the outcome of the baby will be very bad. As you are aware, the fetal growth restriction, which was presented just now, some babies will start having severe fetal growth restriction at 26 weeks, and the estimated fetal weight is 250 grams due to severe placenta damage. And the question is, what kind of message do you tell these women? Of course, we are going to tell them in our own good way that this baby unfortunately will not go home and this pregnancy cannot be viable. All this is not good news to women, and it has caused a lot of pain on the women. So there is a counseling component of fetal medicine, which Sister Chinama is going to bring out now. We also have got fetal defects. Our women are not done early scans. They come with a holoprosencephaly 35 weeks. When everybody who matters in their life is celebrated their pregnancy, when their husband is gone to South Africa to do preparation, and the Sekuru of the tribe is already planning to donate a beast. And all we have to tell this woman is that unfortunately, this one is not going to join the tribe. So this kind of message is heart-wrenching, is traumatic, it bursts the big bubble. So we have a proportion of women we really cause a lot of pain, whether we like it or not. And as a result, there is a counseling component, which Sister Chinama is going to bring to us now. Sister Chinama, you may go ahead and share your screen, Sister Chinama. Counseling issues in fetal medicine. Yeah, Sister Chinama is ready. So you can use the same device that Dr. Mangiza used because it was working. Please go ahead, Sister Chinama, once you are ready.
Thank you, Dr. Can you hear me?
Yes, Sister, try to slide share. The team you have, can you slide share? Because you are not sharing the slide yet. If you go to slideshow, yeah.
All right, Kuda is doing it for me, don't worry.
Okay, perfect. Good, please go ahead as soon as you are ready.
All right, thank you, everyone. Good morning, everyone. Thank you, previous speakers. You have actually opened my discussion today. I'm going to present on fetal medicine counseling. Oh, sorry, just a minute. All right, fine. It's going to be based much on experience, what we have seen in the unit, what Dr. Verenga has taught us, what we have done for the patients previously in our units. So fetal medicine has got a flow chart whereby we receive our patients, they pass through the fetal medicine midwife consult room, and then in the private sector, they can have observations done, and then they go for the scans, that's in the scan room, and thereafter we have counseling session. We actually have first counseling or second counseling as well, depending by like attendance, whom has the patient come with. And then if like the woman or the client has come alone, it means usually would like her to bring a partner or someone to support her or to hear the news with. So we have a second counseling, and this will then lead to informed decision. Usually the counseling fetal medicine needs support. It's not a one-man band. Usually the only one woman cannot withstand the message or the informed decision. So this is the new norm. Previously, we used to have sonographers. They'll just give you an envelope with results. They tell you to go see your doctor. And then that's when in the doctor's room, you get like the breaking news or to have explanations of what's in your letter. But now fetal medicine counseling, that's the new norm. You have it done in one-stop shop. You have it done in the unit. You get you move out of the room with all the results, with all the management or expectations. So sometimes it's never a room for good news, the fetal medicine scan room. So allow the patient to break down, give them time to make informed decisions, and let us be empathetic and sympathetic about our patients. What do I mean? It's all about our reactions. What do we do after receiving the message? Or after giving the patient the medication, the message? It means somehow you also have to be attentive, you have to be respectful. You can offer solving materials, the patient is crying. Even a touch would also go a long way, depending on the community you are. So this is about the fetal medicine counseling, the new norm. So the aim of fetal medicine counseling is to give high quality evidence-based. Previously or in the past, evidence-based could be queryful, whereby it could be, of course, without the scan, we can't have evidence-based. And without fetal medicine, you can't have the high quality. So to give high quality evidence-based care or knowledge to the woman with complex pregnancies, that's why it is necessary for the medical practitioner to know and understand the condition of the fetus. Anyway, now my high quality evidence-based, it also depends on the medical practitioner. The medical practitioner, the doctor, the midwife, and now we also have the sonographers in the unit. They're supposed to know well the condition which they've diagnosed, so that in counseling, they can actually explain well, using the perfect jargon the patient can understand. So we need to read more as fetal medicine medical practitioners. And so the aim of fetal medicine counseling is also to reassure the clients, especially in minor disorders, about the expected outcome, and also to give options of management, either conservative or termination of pregnancy, depending on what we would have diagnosed, and to enhance cooperation in the serial or subsequent visits. I think the previous presenters also talked about serial visits or surveillance tools, whereby we need these patients to come very often, depending on conditions. So we need to enhance cooperation in serial or subsequent visits from the patients. What is it that we offer in counseling in fetal medicine? There is preconceptual counseling and genetic counseling. I think you're all well of that. Like when we talk about preconception, we discuss about the family history, the medical conditions, lifestyle risk factors, and then to plan about the pregnancy the pregnancy the patient wants to have. Now, since we have history about the patient, some of them, we actually told them in the current pregnancy that when in your next pregnancy, can you please visit us or visit the gynecologist for counseling prior to your pregnancy? And also genetic counseling. This would also come with different conditions as a way of the people to understand how genetic illness can affect their families or their lives. So we offer genetic counseling as well. And we offer perinatal counseling or prenatal counseling. In perinatal counseling, mostly we have prenatal counseling. That's about Down syndrome screening. And I think it's there in my presentation, I'll explain more. And then the perinatal loss counseling. And this one is just so devastating. One was we had bonded with their pregnancy, expecting to have a baby, and things just go the other way. So we also need to be very empathetic. It's just the room, the scan room is never really an easy room. Well, going ahead, we have who are the people who are supposed to see fetal medicine or the candidates for fetal medicine counseling. I've just mentioned a few. I know you might have a lot. You can add later on in the question and answer segment. So we have fetal defects, we have fetal growth restriction, monochorionic pregnancies. I think about the fetal growth restriction, Dr. Thatcher explained well, and you have seen now when she talked about complications and the surveillance tools, it means when we talk to the lady now, we need understanding and we need to explain more so that she cooperates and also understands our aim, which is like what the neonatologist was explaining, to reduce those 20%, 29%, ma'am, all those percentages she was explaining about the fetal deaths, especially in preterm pregnancies, etc. So in monochorionic twins, Dr. Thatcher has also explained, Dr. Ndagura also explained well the risk factors. It's not a good pregnancy at all. Patient has to prepare to deliver early and also serial visits. So all that we have to tell our clients or to cancel our clients of the expectations. And we have intrauterine fetal demise. I think this one I'll explain later. And then the recurrent pregnant losses and the pregnant disorders and placenta disorders. Placenta disorders, the same as more or less the same with the fetal growth restriction, but There are also a lot of conditions like the placenta previa, in which the patient has to know and understand, and also in respect of visits and activities to do, and when to expect delivery. So I think these are some of the candidates we see in fetal medicine counseling. Well, the challenges come now with misdiagnosis. This is what we also face in fetal medicine counseling. Mild condition, we have referrals from different sonographers, and we sometimes receive patients who have been misdiagnosed. So we can receive patients who have received mild conditions, yet they've got major conditions. And we sometimes receive patients with major conditions, yet they have minor conditions. This one is better than the latter. Why? It's so heartbreaking and unbelievable and hard to understand or to appreciate or to receive, to say that like baby has been diagnosed with mild ventriculomegaly by the sonographer. Yet doctor, when she comes to Dr. Verenga, she realizes that she has got holoprosencephaly. And holoprosencephaly is a lethal condition. Now we are talking about termination. Yet she expected like minor disorder to continue with pregnancy and expect a healthy baby later on. But now it means doc has to explain about the neurodevelopmental disorders, how baby will not manage life, and I can see how devastating it is in the counseling room. So
yeah, she wants to stay with you. Go and look for Josh and say happy birthday. Have you seen Josh? Go and say happy birthday, Josh.
I think your device is, please continue, Sister Nama. There was just a small, issue. Please continue. Sister Chinama, do you want to continue your presentation? We can't hear you now.
Yes, can you hear me, Dr. Verenga?
Yes, we
Hello?
can hear you now.
All right, thank you. So we also have family support and male involvement issues in fetal medicine. Most of our patients come without escort, whereas the counseling after diagnosis of major defects or even some of the conditions, preeclampsia or early delivery, would also need support. So most of our patients come without escort, whereas the counseling after a diagnosis of major defects would need support from the beloved ones. And family belief or husband belief versus termination. I still remember we had a patient who had a fetus who had neurodevelopmental defect, and the family was saying the Murora shouldn't terminate, and the husband also didn't opt for termination. Fortunately, this lady was learned, and after she was a nurse, and she really understood the effects of the baby later on. So she said, "I'll take the termination besides what the family was saying." So it's also a challenge in our community where we were brought up to make these kind of decisions, and also give the family time to make an informed decision. So when it comes as a family or a partner, let's give them time to think about what would have offered, and then they come back with a comprehensive decision. And all right, fine, I had put it across like challenges in fetal medicine counseling. I think this is also lost, but these challenges also come with religious beliefs. Some people feel like they have betrayed God by allowing some of the activities of fetal medicine, because we offer several activities like feticide, termination of pregnancy, which might not be acceptable according, depending with one's belief. Some would say we're told not to kill. So if we say, let's take feticide, I'm killing a baby. So those are some of the challenges we meet in fetal medicine counseling, and also level of education. This one, possibly I'll put it across like all of us as practitioners, we need to assess the level of knowledge the patient has, and then we give what we have. Sometimes we might even talk of what the patient has known or has Googled about, especially this community of Internet of Things, whereby people come to consult, yet they have the knowledge already. What they just need is your service, but the knowledge they've already Googled about. So we need also to understand, so that we won't irritate our patients. Let's not think that we always see patients who are not learned or people who are just backward. It's high time we also improve ourselves in management of our patients to give them what they deserve, or what can I say, I'm not sure of the word, but what they deserve. Because you might think patient has come to you, it's just because she doesn't know, you are the expertise. Yes, you are the expertise because you've gone to school, but they've got an idea, assess their level of education. However, on a level of education, it's also hard to break news or to give knowledge about the fetal condition to a patient who is not learned. Of course, I've seen doc. He tries by all means to even take a paper and pen, draw the brain, divide it, so that a patient understands what has actually happened to the fetus brain. And when he says it needs termination or conservative management, what is it that he means? So it's also a challenge, yes. And then family support is minimum. In the African setup, family support is just minimum. People just think you have got your pregnant, that's so pregnant. And not only because of that, we also believe in witchcraft. So when I've got my pregnancy, I just think it's mine. If I try to shout about it or to tell people about it, they might bewitch me. So it's a win-win thing. Like, she doesn't have family support because she doesn't want people to know, or just because the family is not supportive. And then we have counseling placenta disorder. As I mentioned before, it depends on condition. Is it placenta previa or FGR? And then if FGR, you heard doc, she explained, well, is it constitutionally small? Is it abnormally small? Or what's really happening with the baby? And mainly the goal is on cooperation or subsequent visits and to have a live baby. And counseling multiple pregnancy. She also explained well when usually it becomes more worrisome in monochorionic pregnancies about the chorionicity and in higher order pregnancies. So you just need that you need to be knowledgeable. Doc has explained more. Yes, we have counseling pregnancy disorders. For example, in diabetes, in pregnancy, PIH, and many more conditions like lupus, hypothyroidism, and many more other conditions we meet in hospital. So patient has to understand her category, and we categorize our patients according to our findings. Like I've said, it's now evidence-based. Is it about the Doppler studies? Was it about the uterines, the fetal Dopplers? Is it the patient's condition? Is it what the fetal conditions? So we categorize our patients, and then from there we then talk to them according to specific conditions. So we need to offer individualized care. And then the main objective is to have adherence in our appointments so that we monitor the fetus and the mother will have her baby. It's so good to adhere to this, to our management or to protocol of management, because sometimes the outcome is just good. it's also, it makes us happy to have a mother with a live baby. So I think most of our work is also talking, communication is a key point in fetal medicine counseling or in fetal medicine. And she has to understand options of management, including early delivery and also multidisciplinary approach. Thank you, Dr. Mangiza, with the previous presentation. It's so crucial in fetal medicine to have multidisciplinary approach. We refer our patients either to endocrinologists, we refer our patients to the neonatologist. We need to prepare delivery. And I think the counseling later on should be just in one approach, whereby we talk to the woman, she understands us, she also understands the activities later. Because it's not about, like what Dr. said before, it's not about your child has got FGR or you've got abdominal fetal defects, but it's then what is it that you are supposed to do for the woman? What best can we do for the woman? Either to have perinatal loss, but in safe hands, and actually understanding what's happening to her, or to have early delivery with a preterm baby, but also understanding what's happening. So counseling in fetal medicine is really a key issue. The prenatal counseling, that's usually is that first trimester counseling from 11 weeks to 13 plus 6 days, whereby we do aneuploidies and screening for either risk for preeclampsia in pregnancy. This is done. So counseling for Down syndrome. This is done in first trimester. And if results shows Down syndrome positive, you go on to check for associated defects, for example, heart defects, and also to offer the management, like I've said, patient has to make an informed decision. Does she need conservative or termination? But you'd have given all the information. I don't want to go into details about give what information, because this is what we usually do every day. But here's the patient got the information, the right information, and all the information. And then offer management and support patient decision. Of course, we know sometimes that the decision the patient has made is not the right decision. It's a right decision, but you think termination is better than conservative. It's okay. That's what the patient wants. You've done your part. You've given all the information. So support the patient decision. If in supporting of the patient decision, if it means she has chosen to conservative management, then plan for subsequent visits. And then if it means she has offered termination, then also liaise with the teams and go ahead with the termination. And then we have perinatal loss counseling. You need to understand and explain about the probable cause, especially in the patient will be managing. It means we'll be having history about the patient. So you can explain having a background of what was really transpiring, or a patient who may have seen on like a walking patient. Still, after having history, you can deduce what might have happened. Some will tell you I had high blood pressure. Some will tell you of recurrent pregnancies and recurrent losses, and also history of stillbirths. You can deduce what to explain to the patient, either according to history or what she has presented. So you need to explain about the probable cause. Now, here comes the issue of being knowledgeable as a medical practitioner, because I come back to the issue of evidence-based. You don't need to know the recurrence risk, the prevalence. and also explain to the patient if pregnancy was under high risk management, explain to the in other situations, this might also need amniocentesis to check if there are associated chromosome abnormalities, educate on subsequent pregnancies. That's where we now talk about the preconceptual care I've talked before, or if you kind of deduced genetics, you now talk about the genetical counseling as well in subsequent pregnancy. So I think the most part here is also for the healthcare to be knowledgeable and to offer as much information as possible, and being, since she's someone in the grieving process, you need to also offer grieving counseling so that the patient comes to terms to what would have happened. And also remember that in grieving process, these patients, what would have done to them, it goes a long way. It doesn't fade out because she had a loss. No, even in a subsequent visit, in a subsequent pregnancy, she would also still remember about the loss and what has happened to her and what the staff, the medical staff had actually done for her. So let's all be professional and be in their shoes when you offer the perinatal care or perinatal loss counseling. So we have activities like feticide and in fetal medicine, and invasive procedures like the amnio drainage, chorionic villus sampling, and there might be more, but these are procedures which needs patient to understand and also to be counseled prior, of course, with the termination of pregnancy as mentioned above. So I think just to mention, as I said before, religious background, does God allow that? These are some of the challenges in acceptance of the procedures, lack of family support, or even the level of education. And as health care workers, give as much information as possible and let them make informed decisions. But do not force matters, please. So just like any other counseling session, we just follow the steps. We need to have relationship building, and then go into depth with the information you have, goal setting, what should we do, and the interventions available, and also the interventions to be done, and patient has to understand. So I think that's the counseling, the 5 steps we have in counseling. So the medical practitioner has to know the exact condition. Please, we need to widen our reading so that we know what to offer for the patient, what to tell the patient. And if it's you need also to know, if it's a fetal defect. I'm sorry, I think I lost my slide about fetal defect. If it's a fetal defect, is it an isolated case or genetics? And then should we go ahead with amniocentesis? What should we really do? And then the medical practitioner should know the natural history of the condition, and the intrauterine and in the lifelong, how would this baby survive? So when you tell the patient, she has to understand and to know intrauterine life, how this baby would survive, and life in the life run, how would this baby survive, and effect of condition on mother and fetus, and the interventions and management. Thank you very much for listening.
Thank you very much, Sister Chinama, for the presentation. Very informative. There are questions in the chat box, Sister Chinama. If you look carefully, I think there is one question that is asking how counseling is done. I don't know why I'm losing question. Let me see. Yeah, there we are. So, Sister Pande, from your experience, which comforting words are more palatable to patients who are facing pregnancy termination? Do you tell them, don't worry, it happens? Is God's will? What can one say without offending them? That's Imelda who is asking this question.
Thank you very much. With fetal medicine, like I've mentioned before, it's evidence-based. So it's not about, of course, you need to explain to the patient with a jargon she understands, and she has to understand and see that that's what has happened. It's, of course, we don't use, we have never used it's God's will or don't worry, but to actually give information. Fetal medicine counseling is all about giving information and giving it effectively and compassionately. I'm not sure if I've answered well.
Maybe Imelda wanted some specific words of what, how can one tell?
All right, Saka, usually some of our patients are in Shona and sometimes in English, but you need to use those words. I'm sorry, unfortunately. I understand. Kana kuti tiri kushona tinototaura kuti sorry nezvaitika mwana zviri kufamba so nezvakadai because wanga usingazvitarisire, asi zviri kutaridzika kuti mwana zvinofamba zvakadai inhumbu inogona kuti inobviswa asi zvisingamanikidzwe kana ichikwanisa kuti iwe unoda kuti ienderere mberi yoenderera mberi, but we have words like sorry, unfortunate, you understand, and also your reaction matters, and ndopamwe patinoita giving tissue papers to the sobbing patient. So it's integrated issue in my activities anenge akawanda, but use those compassionate words.
Yeah, thank you so much, Sister Chinama. I think it's well answered, that question. To be honest with you, I think we are up with our time now. The next presenter may get ready. Sister Chinama, you may stop the slide sharing while the next presenter gets ready. We will break for lunch. But thank you so much for the talk, and to our guests in this meeting. This is a very important concept of fetal medicine, counseling. Like I told you that we only make about close to 30% of the patients who come to see us. We make them sad, we make them cry, because we won't be telling them good news, unfortunately. So as a result, we should be good counselors, people who know how to break bad news, people who know how to console and comfort those who have lost. So it's a very important part. This is why our consults are very long. Well, somebody once asked me and say, why is it your consult is 1 hour long? It is 1 hour long because people receive bad news differently. You cannot chase away somebody who is sobbing and tell them, look, your time is up. I want to see the next patient. We have to wait for them to go through the short bereavement process that everybody has to go through when bad news is broken. So yeah, please be aware of this, that there is a lot of counseling work in the background that has to happen as we see babies with abnormal conditions. And the disadvantage is that the mothers are well. In most cases, these are healthy people, and suddenly tell them that their baby is not going to be like them. It's so heart-wrenching and devastating. The next speaker is Mr. Lyman Kumbula. Mr. Lyman Kumbula is a specialist sonographer, a lecturer in the University of Zimbabwe. Mr. Lyman Kumbula, we work together in the fetal medicine unit. Is currently running the preterm clinic at Salim Gabe. So he's the man who is probably in the last few months has done more transvaginal scan than probably most people might have done throughout their whole career. Because there are lots of transvaginal scans that have to be done for this kind of clinic. So he does them every week. Probably 10 to 15 women have to be done transvaginal scans. So he is a man who is growing in this field and whose knowledge is broadening in the field of cervical length assessment. So Mr. Lyman Kumbula, and you also touched a bit on transvaginal scan to try and demystify the area. You agree with me that 90% of gynecology scans, which doctors, midwives, nurses, obstetricians order to be done in this country are being done in the wrong route. They're being done transabdominally for non-vigo intractor women, which is wrong practice, outdated, and belongs to the 1970s. Yeah, ultrasound scan was already there. Yeah, so Mr. Lyman Kumbula will come and try to demystify this field so that everybody who wants to learn can learn, and so that the right examination is done for women, so that we stop missing PCOS, we stop missing adenomyosis, and we also stop missing women with short cervix, women with vasa previa, women with placenta previa. Please go ahead, Mr. Lyman. Mr. Kumbula, you may go ahead.
Thank you so much, Dr. Verenga. Good morning, everyone. I hope you can hear me loud and clear. So just a quick exercise. I'm just assuming everyone on this platform at some point you're involved in obstetric ultrasound. So in the chat box, we need to see how many are performing transvaginal scans. So you can just post in the chat box if you perform transvaginal scans routinely in obstetric scans. Right, so my talk today will be on transvaginal scan, preterm birth screening, and surveillance. Right, so this will be the outline of my talk. So we're going to have an introduction on what preterm labor is, the Zimbabwean situation currently, then prevention mechanisms. Then I'll also talk about the protocol, which involves the technical aspects on how to measure cervical length, then also the common pitfalls. So I agree with Dr. Verenga that the current practice, we are still in the 70s with regards to the pregnant and non-pregnant imaging of the pelvis, particularly because of lack of skills, particularly because of lack of equipments. But we have no excuse because we are now in the modern day. It's better for you to have the skill or to know and lack the correct apparatus. So just to get a brief epidemiology of preterm birth. So about 130 million babies are born annually globally. And 4 million of these, they die in the first 4 hours of life, which is the neonatal period. And the main direct cause of these deaths is attributed to preterm birth, severe infections, and asphyxia. So our talk will focus more on the preterm birth rates, which are continuously rising despite the advances in knowledge of risk factors and mechanisms that are related to this preterm birth. So there are two reasons for this. One being that there is absence of an effective screening test to identify the women at risk, and also lack of an effective intervention to prevent this complication. So you find that in our protocol, for any pregnant woman at 20 weeks, we routinely check the cervix. That will be the mid-trimester scan when we do the anomaly scan. So this is the current situation in Zimbabwe. to say the perinatal mortality is 29 per 1,000, and 34% is attributed to preterm birth. So currently, cervical stitch insertion is an obstetric intervention that is being practiced. And since the inception of the FMU, the preterm surveillance clinic since 2019 has identified a significant number of women who have got short cervix. Some have got cervical stitches inserted, which would then follow up. And amongst these are those with an existing history of preterm birth. So what is transvaginal scan? So this is the measurement of the cervical length through the vagina, and it identifies those women who would be at risk of preterm delivery because of the cervical lengths that we would detect at that instant. So this is our current data. So since 2019, we've been gathering data, and amongst the patients that we've seen, we've noted that about 667 have experienced preterm deliveries, and the majority of them being in the 31 to 35 weeks gestational age, which we feel we can improve through a well-structured and effective screening mechanism, which we hope to implement across our nation, so that we bring all those 10 to 15 weeks, 20 to 25 weeks preterm births to at least go beyond 36 weeks. That is the target. So amongst the patients that we've seen, the outcomes, you find that 74% have been alive. We also feel that's a percentage that we can also improve through all these this course that we've been going through. You find that there was golden experience and knowledge that was being shared. So if we implement these techniques, we hope to have at least beyond 5% of deaths attributed to preterm deliveries, stillbirths, etc. So any birth that occurs before 37 weeks of gestation is defined as preterm, and they can be subdivided according to the time of delivery. So if it's less than 28 weeks, that's extremely preterm. Then 28 to 30 weeks, that will be early. Then moderate, 31 to 33 weeks. Then mild, 34 to 36 weeks. Now, in predicting preterm births, so between 20 and 24 weeks, for those pregnancies that deliver at term, the mean length of the cervix is usually 34 millimeters. Then for those that have a cervical length less than 15 millimeters, 20% of these cases we have spontaneous preterm birth at less than 34 weeks. Then for those with less than 25 millimeters, this group, we have 40% of cases that have spontaneous preterm birth less than 34 weeks. So the risk of preterm birth is inversely related to cervical length that we see between 20 and 24 weeks of pregnancy. So we therefore require a model whereby we combine the cervical length and obstetric history. So the obstetric history will now include those who would have had previous preterm births, and those who would have short cervical length at the time of scan. So this will improve the sensitivity of the screening and lead to decreased preterm births. So prevention of preterm births in women that would have a previous preterm birth. So cervical sacrilege will reduce the risk of birth before 34 weeks by about 25%. Then there are two options in the management of these patients. So first, when we do the 11 to 13 weeks and we determine that there are no major fetal abnormalities, so these women will be offered an elective sacrilege. Then secondly, there will be measurement of the cervical length every 2 weeks. and placement of a suture if cervical length becomes less than 25 millimeters. Then for those that would be seen to have short cervix, they will also be offered progesterone from 20 to 34 weeks, which will reduce the risk of birth before 34 weeks. So at the preterm surveillance clinic at Salim Mugabe, we see these patients on Thursdays, and depending on the gestation, we'll rebook them and see them every 2 weeks, whereby we'll be checking for any changes. If the cervix is progressively shortening, then for those with the cervix that will be shortening, they are the ones that will be offered progesterone. Then for those that would have a stitch inserted, to also be monitoring the pre-stitch and post-stitch length, which we'll see in the following images. So yeah, I think I've talked about this slide. Then for twin pregnancies with short cervix, their rates of preterm before 34 weeks is higher. It's at 15% compared to 2% in the singletons. Then in both singleton and twin pregnancies, the rate of preterm birth is inversely related to cervical length at 20 to 24 weeks. Then the protocol that we currently use, so this is now important for you to take note. So you'd find that there is a practice currently whereby pregnant women are asked to drink maybe at least 1.5 liters or even more before they get their obstetric scans. Well, you'll be subjecting them to unnecessary torture, as you find in the images that will follow. So we require that the woman empties their bladder, and then they are placed in the dorsal lithotomy position. Then the probe is covered with a latex or condom. Then some gel will be smeared on the inside the condom and also on top of the condom. Then it is gently inserted into the vagina, directed in the anterior fornix. So some literature say you can ask the patient to insert on their own, or you can insert, but gentle insertion. And you insert on direct observation, meaning as you've been setting the probe, you should be checking your screen to see if you're not exerting any unnecessary pressure. So a sagittal view of the cervix is obtained, and the endocervical region is used as the guide to determine the true position of the internal os, which will limit the confusion with the lower segment of the uterus. Then electronic calipers are used to measure the linear distance between, you notice a triangular area of echogenicity at the external os and a V-shaped notch at the internal os. So pre-stitch and post-stitch lengths will be measured in those that would have a stitch inserted. Then as we check for the cervix, we also get to check the viability, because there is no point in continuously monitoring a stitch without confirming viability. So we also check if the fetal heart motion is positive. Then you also check the position of the placenta in excluding placenta previa. So this is all done transvaginally. And each examination should be performed over a period of 2 to 3 minutes. So you realize that if you limit the time, sometimes there may be some contractions which may give a shorter or maybe shorter measurement. Then this is important before anything else. Consent. So in our unit, we usually request verbal consent. And for the studies that we are currently performing, we also have the written consent. Then there's also need for a chaperone. So for the gentlemen, ensure that you have a chaperone, also considering these global trends. You know, sometimes even if you are female, you may need a chaperone as well before performing this examination. Then infection control. So after the examination, ensure that you disinfect the probe to avoid cross-contamination. Sorry, we just lost connection on the screen
I
sharing
think you lost
device.
your screen, Mr. Kumbula there. Bring your screen back.
Okay, just a moment.
While Mr. Kumbula is addressing the screen issue, I think there's one question which Dr. Bonga asked about whether what is happening at these two big hospitals can also extend to Chitungwiza. For sure, it should be able to extend to Chitungwiza, but I think one of the biggest challenge we are facing in trying to implement or to introduce subspecialty services in units, it is a shortage of human resources. Some hospitals, they will tell you they do not have personnel to dedicate to do certain things. So human resource shortage is one of the biggest issue which we are facing as we try to replicate the situation in some of the hospitals, central hospitals. So yeah, but obviously there is a need for all our hospitals to have fetal medicine services and to have neonatology services, because that's the only way our hospitals can deliver their mandate. You can't have a high-risk hospital without these services and win against both maternal and perinatal morbidity and mortality. It is impossible to do it. Please, you may continue, Mr. Kumbula.
All right, thank you. So I was talking about infection control to say, ensure that you disinfect the probes after examination. Then you also need to dispose the used condoms properly. Then transabdominal sonography, like I was saying, some are using transabdominal assessment to check the cervix. So this one fails to visualize the cervix in a high proportion of cases, in particular those with a short cervix. So there are images that will come in the next slide. So transpenally, the cervix can be also examined by placing a curvilinear probe sagittally between the labia majora. Right. So the image on the left, let me use a pointer. Right. The image on the left. So you realize that this is a full bladder, this is the cervix. So if the bladder is too full or too empty, that may give problems. If it's too full, it will forcefully elongate the cervix. So you forcefully reassure the patient that their cervix is long, then hours or days later, then they enter into a preterm delivery. So you realize that for this same patient, the image on the right, there's a yellow trace. So actually this cervix was even less than a centimeter after performing a transvaginal scan. So transabdominal ultrasound in assessing the cervix, highly unrecommended. And right, there's another image, transabdominal. So you may not get a clear representation of the cervix. Let me try to trace. All right. Right. So you realize that if you are to comment, well, I don't know what kind of eyes one will be having, but it will be
Mr.
difficult.
Kumbula, I think we are losing you a little bit, probably.
Oh, okay, okay.
We are
The
losing
audio.
you a little bit. If you can draw closer to your device, please.
Okay, that's fine. Is it better now?
It's better.
All right, thank you. So I was saying transabdominal assessment of the cervix. Well, the image on the screen, you realize that you won't get a clear representation to say, is this cervix open? Is it closed? Hence, our recommendation for us to perform transvaginal assessment. So this is one image of a patient who was at 34 weeks. Everything is okay. They don't feel any pain. However, performing a transvaginal scan, we now we discovered that the cervix was even shorter. It was at 7.7 millimeters, and there was some funneling, which was not detected transabdominally. So in predicting preterm births, sonographic measurements of the cervix length are useful in those asymptomatic women who would have a previous history of a preterm delivery, and those with uterine abnormalities like unicornuate uterus. This cervix length should be measured every 2 weeks between 14 and 24 weeks of pregnancy. So in asymptomatic women, we also perform these TVS scans, and this should be carried out routinely at the time of the mid-trimester scan, 20 to 24 weeks anomaly scan. Then you perform your transvaginal scan in trying to predict the risk of preterm delivery. Right. So the following groups of patients are the ones that are at increased risk of spontaneous preterm delivery, and they should be offered appointment in the preterm surveillance clinic. So those who would have experienced pre-prom or spontaneous preterm delivery at 16 to 36 weeks, then those with history of sacrilege or progesterone in previous pregnancies, despite them having a term delivery. And also those who would have a sacrilege in situ. So we need to monitor this sacrilege because there are also cases of sacrilege failure. Then also those with congenital uterine anomalies. So in predicting delivery at term, transvaginal scans can also be performed in those who would have an elective C-section. And we measure their cervical length at 37 weeks, and this will give a picture in trying to reach a decision whether to carry out the delivery at 37 to 38 weeks or delay it a bit depending on the cervix length. Then in women that would be undergoing induction of labor, the pre-induction cervical length will give a very important prediction of the induction to delivery interval and the likelihood of vaginal or cesarean section delivery. Right, so that image just shows a very long cervix, which was assessed transvaginally. We don't see the bladder anyway. Then what you need to be mindful of are the following. So first, you need to ensure that the anterior aspect of the cervix and also the posterior wall, they're of almost equal lengths. Then the bladder should be emptied. So if the bladder is partially full or even over full, that may forcefully elongate the cervix length. Then this was a transvaginal scan image performed at, performed at 17 weeks, and there was already bulging of membranes beyond the internal os. So these are the kind of images that will inform the caring obstetrician or the obstetric teams, the midwives, of the status of the cervix in a bid to lower down preterm births. Then this was another image. It's another image showing a very short cervix. Then for those who would have cervical stitch inserted, we also assess post-stitch insertion to see if the stitch would have been correctly placed. So in the image, you notice that these echogenic structures are the knots of the stitch, and you can see one is even in the amniotic cavity. Then the cervix was even short. So people may continue with their pregnancy saying the stitch is in situ, is correctly placed without any assessment. So this is why there is need for us to continuously monitor these stitch post insertion. Then the images on the screen now, they just show us the correct measurement and also assessment of those who would have their stitch inserted. So the one on the left upper corner just shows how to measure the cervix. So you need to first measure the length of the whole cervix. Then you also determine the cerclage stitches, which should appear as echogenic structures, is highlighted on the image on the right upper quadrant of this screen. So from there, you now measure the length from the internal os to the diagonal line joining the two stitches. That will be the pre-stitch length. Then you also measure the post-stitch length, which would be the distance from the diagonal line from the stitch to the external os. Right, so the common pitfalls, so if you scan on a full bladder, that will forcibly elongate the bladder and you won't get the typical images that will allow you to give a precise measurement of the cervix. Then if you put too much pressure on the anterior cervix, again, this will also affect the measurement. You will forcibly shorten or forcibly elongate. Right, so with these words, here ends my report. So if there are any questions, you can drop them in the chat box, then we'll respond to them. Right, over to you, Dr. Verenga.
Thank you so much, Mr. Kumbula. Like Mr. Kumbula said, if there are any questions, let's drop them in the chat box so that he could respond to them during the next talk. I think we should all agree that we need to change practice. No one is going to come and tell you to change. This is the right platform to tell each other that we need to change our practice. Those who are still assessing women transabdominally for their cervical length, we need to move away from that. Of course, if the woman refuses to consent, you have to make it clear to them that the method they have agreed to be assessed with is one of the most inaccurate methods which may falsify the cervical length. But we need to change our practice. We can't be stuck in 1970s because no one is going to come and change us. It is ourselves who determine that this practice is archaic. No woman who is a modern woman who has an iPhone 15, I don't know where the iPhones are now, deserves to be examined this way if they have a gynecological problem. Neither they have an obstetric bleed. The best they can be done is to be checked transabdominally, and they are forcibly reassured that you are okay when their cervix is almost popping out. So it is this kind of practice that we have to change, and it is up to us to change because we are the practitioners, we are the clinicians, we are the ones who examine these women. So I will do the next presentation, and my presentation will focus on aneuploid screening. It is another area in our country here where we still lag behind, where we are still stuck in in ancient days of clinical practice. So I'm going to address some of the issues which I think we may have to reflect as practitioners in women's health, so that we can try to improve ourselves as a people, and also individually as a practitioner. You would want to practice in an ancient way when you are a modern person. So that is what I want to try and address with my presentation. I'll just share my screen. Admin, you can just confirm. Thank you so much. I think I was muted, but now I'm not. So I was saying thank you so much, Mr. Kumbula, and it was a pleasure to hear you speaking. So what we need to do now is to move on to the next talk, which will be on unemployed screening. Like I highlighted that, look, the times have moved and we need to move with them. So I'll just take you through the historical line, which may make you understand why certain practice is too prevalent in our own country here, and probably beyond our country in Africa, because Africa is a village. When Dr. Mangiza was presenting, only 30% of women in Cape Town, which she labeled a middle income country, book their pregnant or had a scan or had a dating scan, something like that, book their pregnancy for a dating scan, which is probably the same as ours. So Africa is a village. We all practice in the same way, more or less, but our ways need to be updated because they are now outdated for our populations who are global citizens. They travel everywhere. They've been to every part of the world. They know what it means to have arrived and to be behind. So it is for this reason that I've decided to share with you my thoughts on this topic. So if you look on the left here, in 1970s, it was okay to just tell a woman that, look, you are above the age of 35. Down syndrome babies are known to occur to women above the age of 35. Go and have your amniocentesis jab so that we can know if your baby has got Downs or has no Downs. It was okay in the 1970s, but there was a problem in those 1970s. Babies with Downs continued to be born in women who were below the age of 35. Before then, the 35 years and older were making up 5% of the pregnancy population. So more than 50% of Downs occurred in women who were below the age of 35. So people discovered that it was not enough to just be above the age of 35. They introduced alpha-fetal protein. Alpha-fetal protein, which picked a modest number of Down syndrome. This is why you see that some of our laboratories are still stuck in 1984. In 2021, we have a laboratory which is still reporting alpha-fetal protein. And they will tell you that this alpha-fetal protein is high. Go send somebody for a high-resolution scan to exclude myelomeningocele. Who does that in 2022? It is just a stuck mindset, where people are now doing scans, where spines can be examined properly, and
excuse Dr. Verenga.
Yes.
Dr. Verenga. We are seeing on your screen the 11 to 13 pre-course quiz. We are not seeing the slide you are presenting on currently.
Right, sorry about that. Admin, please be vigilant. I was asking about this. Let me do something to make sure I present to you the right. Okay, so you are seeing the 11 to 13 week
pre-course quiz.
Okay,
which is not in slideshow as well.
Okay. So probably it's okay. I'll just briefly run the quiz, then I'll continue with my presentation. I jumped the quiz, but let me just briefly run them to just see how good we are performing. So in the next probably 30 seconds, just look at that picture there. I hope it's clear where you are. Which one is the ductus venosus in the picture shown? So if you could just identify the ductus venosus using the arrows, which one is the ductus venosus? That's 11 to 13 week image of a ductus venosus. So which one of that, where the arrows are pointing, just try to identify the ductus venosus. Then this is an image of the ductus venosus. You can just look at it and tell us if the ductus venosus is normal. You don't have to send your answers. You will mark for yourself by the end you finish this talk. You should know whether you got it or you didn't. So is the ductus venosus Doppler normal? That's 11 to 13 weeks ductus venosus assessment. So ask yourself this question and you answer on your own, then you mark for yourself so that you know whether learning took place or it didn't. Is the nasal bone present or not? So that's the image there. This more applies to people who scan. Of course, people who don't scan it, this will be very difficult to answer. But people who scan, is the nasal bone present or absent? Then which one is the knuckle translucency? You can try to identify it on this image. I'll show you the same image before I finish and tell you what the correct answers are, depending on your understanding of my talk. Is the tricuspid regurgitation present here? Is it present or it's absent? Tricuspid regurgitation. Is there tricuspid regurgitation? Thank you. That's the short quiz. Let me minimize this so that I could share the other presentation I was on. Maybe I'll just close it. Cancel. Just give me a second. I'm going back to my presentation. I'll just stop the share and reshare with you. I believe you can now see a new screen. Admin, please confirm a new screen with evaluation of aneuploid screening.
We can now see a new screen, Dr. Verenga.
Thank you so much. Thank you. So I was saying there has been evolution over the years. Where we started in the 1970s, it was okay to just tell a woman that you have 35 years because you are somehow 35, go for Down syndrome screening, because that is what people had seen, that if you are above the age of 35, the probability of having a baby with Downs is higher. So women were just given a jab, an amniocentesis jab, 35. But alas, more than 50% of women above the age of 35 continued to have babies below the age of 35, continue to have babies Downs. So people noted that, look, we could still have babies Downs in women who are below the age of 35. As a result, serum alpha fetoprotein was introduced to try and improve the detection rate with still a modest increase. This is what I was saying, that unfortunately, Africa being Africa, you will see that our laboratories, whenever you ask women to be screened for Down syndrome, using either first trimester, especially using first trimester screening, they still go on and report things like alpha fetoprotein, sometimes serum alpha fetoprotein. Even when you do amniotic fluid, sometimes you see them reporting alpha fetoprotein when they are looking for chromosome abnormalities. But what I'm saying is medicine has moved in such a way that some of the markers which was to want to apply in this day, have been overtaken by better screening methods. So triple test was introduced to try and augment the effects of the performance of serum alpha fetoprotein. But this screening method could only identify up to 2/3 of potential downs. So it was about 65% the detection rate if you use the triple test here. Of course, you could improve it with the quadruple test to around 80%. But the problem of using the triple and the quadruple test is that these are second trimester tests. In other words, they are late tests. They come in very late for good antenatal care kind of plan. It is better to screen pregnancy at the beginning than to screen for pregnancy halfway. We know that the trauma to the parents is more devastating if you tell a woman who is 24 weeks that your baby is good Downs than to tell a woman who is about 15, 16 weeks. So this is the problem with this triple test. It's a test which is still happening in our country, but it's not a test that we desire to have because its performance is very questionable. If you tell a woman that I'm going to subject you to a test that will only pick 2/3 of potential problems, everyone will run away. Even if it is you yourself, you run away from that kind of test because you're saying there's a potential that 1/3 of the baby's downs can be missed. So it's not a good test. And it was introduced in the 1980s. In the 1990s, Professor Nicolaides discovered that the nuchal or the fluid behind the baby's neck had some prediction for Down syndrome. And he noted that almost 60% of babies with Down syndrome have some abnormal nuchal, and it was introduced in the 90s. But the problem of using the nuchal alone is that it was picking about 60% of babies' Downs. So that means it could potentially miss the others who have otherwise a normal nuchal translucency. I think generally in our country, and probably other African states, we are still stuck here at the nuchal translucency. Most women in our country, they actually go and they have a scan and have a nuchal scan, and they are told your baby has no Down syndrome. Whenever we ask women, have you been screened for Down syndrome? The next thing that they are going to tell us that I went for a scan and they measured something behind the baby's neck and they told me that my baby is okay. It is wrong. We are not in the 1990s when evidence was paused concerning this condition. In other words, we are keeping women in 1990s when we all know that we are 20 something people. Because medicine moves, we can't be stuck. It is not right to be stuck in some ancient times and you continue there like nobody has moved. Everybody has moved. Then in the 2000s, the group of Professor Nicolaides and others, they discovered that there are some chemical substances produced by the placenta, which are papier and free beta HCG, which can be added together with the nuchal translucence, the woman's age, and improve the detection rate to almost 90%. So this is the test that was applied to women and is still being applied today. However, in our modern times, in the 2010s, there around 2012, people discovered that there is actually some small pieces of the baby's DNA in the woman's blood. So whenever the baby's DNA breaks down, some free or loose DNA, which is outside the nucleus, outside the cells, go into the woman's blood and mingle with the woman's free DNA. Because all of us, when our DNA breaks into pieces, some of it get into our blood. So they discovered that it is possible now to harvest the woman's blood and compare the woman's DNA and that of the small pieces of the baby's DNA and come through a laboratory process, be able to predict Down syndrome, Edwards, Fetal. Now the test is being applied on chromosome number 1 to number 23, including some deletion syndromes. So this is where we are now. So you can actually gauge yourself. You can look at this chart and ask yourself and say, where am I practicing? You could be practicing in the 1980s, where you only see them in second trimester and told them to go for triple tests, or you could be stuck in 1970s. In 1970s, what was happening? Nobody was being offered screening for Downs. It was only those who were above the age of 35. There are people who still do this. They only offer Down syndrome to people who are above the age of 35. So what I'm saying is this belongs to 1970s. It's not modern antenatal care practice to do that. Some just offer NT. So this is 90s. This is 1990s where you are stuck. Then if you are offering combined tests, you are probably living in modern times. It's still a good option. So that means a scan plus blood test. After you have sent them for the nuchal scan, together with the nuchal scan request, you give them a blood test request so that they can proceed to the laboratory if their papillae and beta-CG measured and the results calculated based on the woman's age, the knockout translucency, and the results of the papillae and beta-CG. That's a combined test. That's a better test for screening for aneuploidy. If the woman can afford, it is even better to offer them fetal self-readiness tests. The people in our country are taking this test, believe you me. We will share with you at the Congress, the African Congress, what proportion of our women are actually taking NIPT as an alternative to the combined for Down syndrome screening. So this is modern obstetric care practice, where you offer women the screening. One of the reasons why probably we are still stuck in these times is because of this pyramid of care, which is still very much a 1929 pyramid of care for most of our women in Zimbabwe. Most of our women do not book early. As a result, they are not benefits, or they are not part of the invasion of the pyramid of care, which was discussed, or which was championed for by Professor Kipros when he argued that we need to turn the pyramid of care so that women can present at 12 weeks to be offered screening for pregnancy complications, amongst them aneuploid screening. So this turning of the pyramid of care is still to be realized in African settings. Other countries are moving so fast that their women are now presenting at 10 weeks to be offered fetal cell-free DNA tests and a very early scan for viability. But we have not even turned the pyramid of care at all in African settings. I'm addressing both the public sector and the private sector. To say most of the private sector, they are still here. But I'm saying this is old, archaic, and modern to continue to see women in second trimester or to do nothing when they come to us at 12 weeks. We should offer them aneuploid screening and preeclampsia screening, as another speaker will tell you in this meeting. So this is the modern way of practicing obstetrics. So the purpose of the 11 to 13 weeks is something that we all know, that we need to assess women for risk factors, for major fetal defect, for HIV, Down syndrome, preeclampsia, and fetal growth restriction, and preterm birth. All these risk factors have to be assessed, and of course we need to do the basics. The basics are these. These are basics: the pregnancy, determine number of fetus, do chorionicity. My colleagues have emphasized that, and localize the placenta. Well, some women, you can see in first trimester that the placenta is really seated on the os, so that when they bleed, you're not surprised why they are bleeding. And this is what is against us, as you can see there, that these are the numbers for early booking, that is booking before 16 weeks, The same is in Cape Town, where probably I think 30% were being scanned. If you look at ours, only about 29% at best, close to 1/3 of our women only booked before 16 weeks. So we are still stuck in old times that make practice of modern obstetrics very complicated for ourselves. Then, however, our women actually come to the clinics more than we may expect, so that their base 89% of our pregnant women, they attend at least four ANC visits. So what it means is that our women have the practice in them, but we need to change the time of the presentation. We need to convince our people that there is no glory or there is no advantage in hiding pregnancy the first 3 months and only present when you are 5 months pregnant, so that they can understand that pregnancy is better managed if they present early. I've just put some key images that we need for the 11 to 13 week scan. I actually thought through this very hard and tough, because I discovered that we have been trying to train our fellows on how to perform 11 to 13 week scan according to Fetal Medicine Foundation protocol. But one of the stumbling block we are having is that we are not having enough numbers to be able to train up to good competency. We are not having enough numbers. As you can see from that chart which I presented, only 30% present after 16 weeks. We don't know what percentage before 16 weeks. We don't know what percentage present before 14 weeks. Probably it's way less. So as a result, we are having challenges even in trying to train people to gain competence. But I've decided that probably to try and improve or to make it quicker, when people decide to do 11 to 13 week scan, there are 3 very important images that they have to obtain. One of them is this one, the CRL image, the crown rump length image. What does it show? It shows us the baby's head here, nicely covered with the skull. It shows us the nasal bone. It shows us the baby's chin. It shows us the baby's neck. And it shows us that there is brain there. There is not too much fluid. On top of that, it shows us that the anterior abdominal wall is covered. And it shows us the fetal bladder and shows us the skin at the back. So with this image, we can actually screen for major fetal defects that range from anencephaly, holoprosencephaly. We can screen for anterior abdominal wall defects such as exomphalos, gastroschisis, and probably large myelomeningocele. The same image, this one is not as clear, probably this one is too dark, but this is good for measuring nuchal translucency. But if we zoom in on the image of the nuchal translucency, we can see the back of the brain here, the one we call the brainstem hospital bone ratio. It can enhance the screen for myelomeningocele. So for people who meet first trimester scan women, probably this is the image you need to obtain to rule out major defects that we have to screen for. Anencephalies, gastroschisis, exomphalos, large myelomeningocele, and probably bladder extrophy to suspect it, if we can obtain a proper CRL. Then the next image is of course to measure the nuchal translucency, which is demonstrated here. The settings are probably about right because you need to darken your screen to be able to see the nuchal space. What you are seeing below here is the amnion. The amnion is not fused to the chorion before 15 weeks. So do not mistake the amnion for the baby's skin and you measure this space. The nuchal in this case is this one. is not this space. And of course, the standards for doing it properly are outlined in the next slide here. Sorry. So the standards are what are outlined here to say how should you measure the NUCA. The baby should be in mid-sagittal plane. In mid-sagittal, that means you can see the nasal bone and the tip of the nose. This is the nasal bone below and the skin on top. And this is a maxilla. You are not seeing the zygoma. The moment you see the zygoma, you know that you are oblique. And you can see again the nuclear space here. And this is what I was referring to as because this is the brainstem, and this is the fourth ventricle, and this is the cisterna magna space. So this space can be used to screen for large myelomeningocele as well. But the most important image for the 11 to 13 week is this image after the CRL, which you have to use for dating. And remember, nuclear translucency is assessed based on the CRL, whether it is normal or abnormal. And the neck has to be in neutral position, and the space has to be clear. You have to lower down the gain. You may have to increase it, depending on your machine, increase or decrease the dynamic range to get an image as clear as this one. And of course, the nasal bone and the tip of the nose should be seen, and your image should only have the head and the thorax in the screen. That's a standard and a very important image for the 11 to 13 week scan. I will jump the actual process of Downs. I'll just go to some images. As a complement, when women come to us for screening for Downs, after looking at their age and the nuclear translucency, we go on to assess the ductus venosus. The ductus venosus, remember, is a continuation of the umbilical vein. And because it is cone-shaped, it narrows as it goes towards the heart. It causes aliasing, and the aliasing will give you an orange appearance on the color Doppler. So where you see the aliasing is where the ductus venosus is, because it's cone-shaped in shape, and it causes aliasing or turbulence or flow in the blood. And as you can see there. So that's the ductus venosus. This is the normal one. The one below here shows a reversal of the air wave in the ductus venosus. I think my other colleague has already explained the interpretation of the ductus venosus. Then on top of that, we check the nasal bone. I've already shown you in the other image that the nasal bone is a more hyperechoic area just below the skin of the nose. What you are seeing there is the tip of the nose and the skin of the nose, and the structure which is more hyperechoic there is the nasal bone. In a baby such as this one, there is no nasal bone here. What you are seeing is just the skin and something that is less echogenic than the skin. So this baby has an absent nasal bone, the one below, the picture below there. And this is the tricuspid regurgitation. How do we do it? We just put the pulse wave gauge across the tricuspid valve, put 1/3 in the atrium, 2/3 in the ventricle, and you record your pulse wave tracing. Within this pulse wave tracing, we're going to have what we call arterial systole waveform here, which you can see represented. And this is due to the flapping of the valves you see. But if there is indeed a regurgitation which is significant, you are going to see significant flow, which has a velocity of more than 60 centimeters per second, as shown on the picture below there, where there was tricuspid regurgitation. All these abnormalities I've mentioned, they aid to the screening algorithm, so that the screening algorithm, instead of picking up 85 to 90%, you improve the detection rate to above 95%. So in a country such as ours, where most of our women are not affording to go for the blood test, The blood test costs $70 by the way. So most of our women are not affording this $70 to go for PAPA and BTCG. We are offering them screening using these ultrasound markers and their maternal age. So we are using maternal age and all these markers. So in a country where the use of ultrasound is as prevalent as in Zimbabwe, in some towns, of course, it is better that sonographers who see 11 to 13-week babies at least know how to look for these other markers to try and improve the detection rate of the ultrasound scan-only based method. Because just using nuclear translucence on its own, unfortunately, you are going to detect less and less babies, and you miss more, and you falsify, tell women that their babies are okay when they are indeed not okay. So these skills, they need to be learned. We have a platform where we train, but we need numbers. We need people who see women at 11 to 13 weeks to encourage them and to let them know that that is the best way for pregnancy risk to be assessed, not at 16 weeks, not at 20 weeks, because that is late. The second most important image after those first two I showed you is this image which you see on the screen right now, is the image of the BPD in first trimester. This image should be done by anyone who decides that they want to look at the baby at 11 to 13 weeks. What do we see? We see the midline, we see the choroid plexuses here. And the moment we see this image, the way it is looking, we have excluded anencephaly, we have excluded allobar holoprosencephaly. Allobar holoprosencephaly, in our situation, I'm sorry to tell you that the median gestational age of diagnosis of allobar holoprosencephaly is beyond 28 weeks in our setup. Most women come to us in third trimester. If you ask them whether they had the first trimester scan, they will tell you, yes, I had the first trimester scan and I was told my baby is normal. The reason why it is like that is because people who do these scans are not doing this image, which I'm showing you right now. If everyone who does the scan makes an effort to just go and obtain biparietal diameter in a first trimester, we are not going to diagnose anencephaly at 30 weeks, holoprosencephaly at 35 weeks, like what is happening at the moment. So remember this image, very important image. I'm not going to emphasize the span. So we know that with early anomaly scanning, there are some easy defects which you can obtain using the most important images that I have already shown you. If we are able to do a proper first crown rump length of the baby, you will be able to see that this baby's brain doesn't look normal. It's not nicely covered as the one I showed you. And this is acrania, which will degenerate to anencephaly if the pregnancy continues. You'll be able to see that there's a large exomphalos here. Just with one image, you'll be able to pick up all these very bad defects. You'll be able to see that this fetus is a megacystis here. And you'll also be able to see that there is something that looks funny on the baby's back, which is a large myelomeningocele. And if you do the biparietal diameter, you'll be able to pick allobar holoprosencephaly. There. It is a very common condition you will see with our fetal defects that we pick it quite very early, quite often. Allobar, it's a leader condition. Nobody goes home, whether you're in Japan, Sydney, it doesn't matter where you are. If you have allobar holoprosencephaly, you are leader. Even if you are 40 weeks in your mother's womb, you can't leave. So it is this kind of conditions that makes us say, look, guys, we can improve ourselves. Those who scan can scan properly and pick up this kind of conditions. Right, so locally, what is it we are doing? Because we shouldn't be talkers. We should not just talk and do nothing. Because look, people who talk, they will not achieve anything. We have to be men of action to be able to do something about our situation. So this is what we have started to do. I've already told you that we are through the Fetal Medicine Foundation UK. Those who are involved in fetal medicine, you know that this is a global program that is used internationally to screen for Down syndrome. So for you to obtain this license, you have to be able to successfully pass the 11 to 13 week module on the FMF website, and to have your nucleus examined and be certified for competency. And you will qualify to have this program on your computer. It will be given to you for free as long as you maintain your license. The license is for free, courtesy of the Fetal Medicine Foundation. So with this program, we are able to calculate the risks for Down syndrome. When you are saying you have calculated somebody's risk for Down syndrome, they should have a known risk. You don't just say, I've done your nuchal, your risk is low. No, what is the actual risk? How did the nuchal modify their a priori risk? As you are aware, every woman who decides that they want to become pregnant, they have an a priori risk which is based on their age of Down syndrome. So the question is, when you do something on that woman, whether you do the scan or the blood test, how does all this affect the a priori risk? Does the a priori risk become worse or it becomes better? So this is what the calculator will be able to do for us. So we can use all these parameters for us to calculate Down syndrome. And these are the detection rates I've put there. But we are using this one for most of the government patients. For the private sector, we are able to use this. But for government patients, we are using this number 2. So we are screening for Down syndrome using that algorithm. These are the other conditions that the application screens for: preeclampsia, fetal growth restriction, and preterm birth. I will not talk about that now. And this is just the handling of the NT here, to say a normal NT is not equal to normal. The woman has to be offered combined test or fetal cell-free DNA. For those who are just doing NT, if your NT is normal, don't tell a woman you have no Down syndrome. They should proceed and have a combined test or a fetal cell-free DNA test, depending on what they can afford. If the NT is abnormal, it does not mean their baby is Down. They can proceed to have a combined test or a fetal cell-free DNA test. That is if it is below the 99th centile. The 99th centile is now about 3 millimeters. If they do this and it's a high risk, then of course we offer them CVS and the amnio. As you are aware, we're not doing amnio because Lancet is not handling CVS samples. So we are only sending amnios to Lancet. So what about if NT is greater than 3 millimeters? What do we do? If it is greater than 3 millimeters, because for an NT greater than 3 millimeters, the risk of having a chromosomal defects will rise to something like 25%. So the moment we have a 1 in 4 chance of having a chromosomal defect, you cannot proceed and do a screening test. You now can proceed and do a diagnostic test. Because we are saying the risk is so high, so that we cannot honestly want to do a screening test when the risks are that high. It's just like somebody with a holoprosencephaly. If the patient has a holoprosencephaly, the risk for trisomy 13 or 18 is 1 in 2. You cannot say, I want to offer you a screening test. What you want to do now is a diagnostic test. To just summarize this slide, because my main beef is people who just do nuchal and to tell women that you are okay, because we end up seeing some of these women for defects, and you are in a quandary talking to a woman who told you, Chiremba was screened for Down syndrome, and I'm trying to tell her that you were not screened for Down syndrome. So it is this kind of practice issues that bring us to here to say we need to go back and have a discussion amongst ourselves and say, look, we can do better than this. So NT-normal is an indication to proceed with the combined, not to tell the woman to go home and rejoice. NT above the 95th, but less than 99th, that is less than 3 millimeters. It is again a reason to proceed and do the combined test or a fetal soft-regenerative test if she can afford. Greater than 3 millimeters, it is an indication to do amnio, although in these days, because of how good fetal soft-regenerative test is, depending on other factors, if there are no defects, we will repeat the scan fetal medicine, check the baby thoroughly, and if we don't see any other telltale signs for Downs, sometimes we can relax and allow the woman to do fetal self-regenerate test. But we ask that we look for all the chromosomes in that fetal self-regenerate test. So sometimes we do that, but ideally it is amniocentesis they should be offered, these women. So let's understand how to handle the NT. Please don't tell women your baby is normal because you've done NT. This is just our cohort, probably the slide which is of interest here. I just wanted to show you that only 2% of women present to us in first trimester, which is a very minute number. Out of the 7,141 women we have scanned, just 2% come to us in first trimester. This is a disaster for modern health, prenatal care. To have your population, only 2% presenting for proper assessment. Probably they will have presented somewhere else, but I just want to show you the kind of picture. I think our national picture is not far away from that, of course. Then only 9% of women actually get a scan for dating in first trimester. And you need to be trained to do a proper first trimester scan. You cannot just wake up and say, I can do it. You have to be trained. Even how to do nuchal translucency, you have to be trained. This is what I mentioned when we started, that we are living in the era of lifelong learning in the field of medicine. If you say you want to do it, just be trained. We offer a training platform. What we are urging you is to refer as many 11 to 14 weeks scan to us so that we can create a training platform to train our doctors now, our sonographers, our radiographers, and midwives today for the sake of future generation of Zimbabwean people, so that they can get the right kind of care from their doctors, nurses, and sonographers. So when you are trained and you can be assessed using the FMF website, your image can be assessed for competency. Once you do that, as a practitioner, you will be subject to regular yearly audit. Myself, I'm also subjected to a regular yearly audit. I submit my results every year for assessment to make sure I'm still doing it in the right way. That is the only way you maintain the license and also to maintain that application, because the moment you stop renewing your audit, that license is taken away because you become a very dangerous doctor to women to continue to practice without being audited of how good you are doing it or how wrong you are doing it so that you can correct. So there is a platform for learning. So there is no reason for you to continue doing them without wanting to subject yourself to a proper internationally recognized assessment where you'll be certified and you'll be known globally that if you send the results of your scan to UK and you say, I've screened for Down syndrome, they can see your FMF ID and say, look, this one is certified. We can believe his result. So it is important to want to comply to international standards. Just to show you the uptake of the aneuploid screening, just look at this far-fetched pie chart. They don't worry about the rest there. You can see that 26% of our cohort here, which was a cohort of 320 women, and 40% of them are the ones that underwent, 60% actually underwent screening, and 26% of them went for the combined test. And this is the private sector data. And I don't know where the percentage is here, but you can see it's quite a big percentage. The biggest percentage, okay, second biggest percentage here, probably 30% of them went for the NIPT. So do not think that women are not going for the fetal self-readiness test. They are, because they are modern Zimbabwean women. They have traveled everywhere. Our people want more and want better from us. So we have to improve ourselves for our own people, because they expect better. Because some people think nobody's doing that test. They are doing the test, and you have to offer it. If you don't offer it, they will be auditing the practice and say, how come I was never offered fetal self-readiness test? I've been reading that this is what should happen to me at 11 to 13 weeks. So then about 30% declined with their doctors. We didn't go downtown in asking why they declined, but most of them, they will tell you that it doesn't affect my decision, my pregnancy decision, in terms of whether they will terminate or not. They'll say, I don't care whether the baby is down or not, I will have the baby. So this is the majority of women who decline screening at all. And only 4% have the second trimester serum markers. We do not want to do this test at all. But unfortunately, our women booklet, and we end up offering this test. In the fetal medicine, we don't offer this test. We either offer a detailed fetal anomaly scan than this test. It performs better than this test. So we don't offer it really. All right, I'm going to save you this. This is our audit. We passed our audit there. I just want to give you an example as I finish my presentation. So when we say we have screened somebody for Downs, what do we mean? Look at this lady. What is her age? Okay, her age was 38 years, this lady. And for a 38 years old, the moment they walk into your room, their risk for Down syndrome is 181. That's their background risk, their a priori risk. The one that caused them to be given the jab in the 1970s, it is this risk. Then trisomy 18, 2,113, 1 in 2,113. When they walk into my room, that's their risk. For trisomy 13, is 1 in 5,033. Then after I have adjusted now their risk, I did the scan, I put in the nuchal translucency, the nasal bone, the ductus venosus, and the fetal heart rate. Then the risk was adjusted. You can see that the woman's risk is now very much improved, which reduces the likelihood for Down syndrome. So this is what we mean when you say we have screened somebody for Down syndrome. We can tell them that your probability is now 1 in 3,623. And we will ask the woman and say, are you happy with your probability? This is private practice. We'll tell her that our risk cutoff is 1 in 100. But look, there are some women, if you tell them that your risk is 1 in 200, they'll tell you, look, this risk is too high for me. Please go on and do another test or a diagnostic test. Because risk perception varies. In private sector, where you have to individualize the care, we have to tell them their risk and tell, this is your risk. Are you happy with it? That if we take 3,623 women such as you, only one woman out of them is likely to have a baby with Downs. If they tell you, look, doc, I'm happy with this risk, then you can reassure them and let them go home and enjoy their pregnancy. But you have to tell them these numbers, not to just say you are okay. It's not good enough. These are the other conditions we screen. You can see this woman was high risk for preeclampsia and so forth. Then we had to put on aspirin. Right, so yeah, so I think I'll end here. I'll end here just to probably to remind you that when you are doing risk calculation, we have to input all these other women characteristics. They are very important in calculation of the moms, as well as the PAPI and beta CG, because they vary according to race, to whether women smoking, diabetes, the presence of all these other conditions. So they have to be taken into consideration. I think I'll end here. Thank you so much for your time and for listening. I'll open the room for questions. You. There are two questions in the chat box. Mr. Kumbula, there is a question for you. Maybe you can start. Where TVS is not available, is there a cutoff margin that can be used to suggest transabdominal that there is a high risk for cervical incompetency? Mr. Kumbula, you can respond to that one. Then Audrey Mukombwe, we are in the fetal medicine unit at Salimugabe. Preterm clinic is one of the specialist clinics that fetal medicine units run. So like we say that we have a preterm clinic, surveillance clinic, we have a placenta disorder, we have multiple pregnancy, we have a fetal defects, we have a fetal cardiac clinic. So the fetal medicine is multiple clinics which are run by specialists there. So it's found in the fetal medicine unit at Sali. That's where we have a strong preterm surveillance clinic. It's run on Thursdays if you want to join them. Mr. Kumbula, are you still available to answer your question? Somebody's asking you that if I do not have a vaginal probe, can I assess this cervix transabdominally? And what are the cutoffs? Admin, do you want to, is Mr. Kumbula with you? Kindly respond quickly if he's not around so that we know and we'll move on. Mr. Kumbula. I do not think Mr. Kumbula is around. So what I'm going to do is during the questions and answer segment, I think I will just take you through the post question now. I asked you some few questions. I just want to put them up again. Then you can answer yourselves. I'll give you the answers. Then you can mark for yourself and see how well you are performing in terms of assessing. Just confirm with me, admin, did I change my screen to the quiz one? Admin, confirm if I changed my screen to the quiz one.
Yes, Dr. Verenga, we can see it.
Thank you so much. Thank you so much, Dr. Due. So which one is the ductus venosus? It will be quick. I think in 5 minutes should be done. Then we'll break for lunch if there are no further questions. So which one is the ductus venosus? So the red arrow corresponds to the ductus venosus where we see aliasing happening. So that's the ductus venosus. You can mark for yourself and see how well you are performing. The ductus venosus is normal. It is abnormal. We have a reverse A wave in this ductus venosus here. So it cannot be normal, this ductus venosus. The nasal bone is present. In this image, I would say it is absent because you can just see a continuation of the skin. You don't see much below the baby. Of course, it's slightly oblique. Maybe it's just a small part of the zygoma there, but it's not convincing that we have a nasal bone there. The echogenicity is the same in this, this baby. Which one is the knockout translucency? If you picked this one, let me put a laser. If you pick this one, it is not the correct answer. This is the amnion. So you will have measured the baby's back and the amnion as your NT. But if you did put this one here, that's the NT, the knockout translucency for this baby, not this one. This is the amnion. Like I said, the amnion is not fused the chorion before 15 weeks. Tracheal regurgitation is present. Yes, it is present in this image. As you can see, the regurgitation jet is more than 60 centimeters per second here. This is the arterial systole, like I highlighted. that's the end of the quiz. So in a situation where you can still use 25 millimeters as the cutoff, because I don't think Mr. Kumbula is around to answer the question. So you can still pretty much use 25 millimeters as your cutoff to measure. If there are no other questions, I think it will be fair to take an early break. Instead of having a 1 hour break, because this is a virtual meeting, we could probably have a 40 minutes break and be back at 1:30, so that we, if possible, we can finish earlier than projected on the program, that people can go on with their Saturday. So in the afternoon, we have an exciting program. Let me ask the team to just share the program. Kindly share the program on this platform. But we have an exciting program. We'll be having some quiz on the fetal heart. Dr. Dube will take us through preeclampsia screening, a very hot topic in our times because preeclampsia is more common in Black women. Zimbabwe is predominantly Black. So there is lots of stuff to enjoy in the afternoon. And Mr. Chigayo will take us through assessment of the fetal anatomy. What are you should do? Then Mr. Zanga will round up with an approach to obstetric sonography, so that everybody is put in the picture in terms of what are the necessary steps we have to take to assess things properly. So remember this, we are coming back at 1:30 and we continue with the program. Otherwise, enjoy your lunch and thank you very much. Bye-bye.
Okay.
Hi, guys. I think we are almost there. I just wanted to find out, is Dr. Dule who is starting, right? Followed by by Simba, Mr. Shigare there. Dr. Dule, probably you can try the screen sharing and just make sure your things are working well so that exactly past will give you the floor to proceed.
Yes, thank you, Dr. Verenga. I hope you can hear me.
Yes, we can hear you. I'm hoping, Dr. Dway, you gave the ladies your screen at the office so that just in case if you drop off, they could move your slides from this side, right?
Yes, I did that.
Perfect. So the admin guys, please pay attention. Make sure Dr. Dway's presentation is ready on your screen, and be ready to share when it is time to share. So make sure it is ready, Dr. Dway's presentation.
Yeah, so let me try now to share from my side and see how things work out. Are you able to see my screen?
Yes, coming out nicely. Very nice. Just there is a question in the chat before Dr. Dwyer takes over. I'll just say they are moving very nicely. Your slides.
Okay.
Just before Dr. Dwyer takes over, I will address a question. There's a question there. The question is to say, I think I saw a question. There's a question that is asking on, where is it? I saw a question somewhere. Yeah. In the event that the patient is a transvaginal scan or no, this one has been, is it possible to recommend delivery based on the shortening cervical length? No. If delivery is to happen, it should be spontaneous. We don't recommend delivery because the cervix is short. More so before term, even at term, we don't induce a woman because they have a short cervix. The reason for identifying a short cervix so that we can do the preparatory work for delivering a preterm baby. So that if the woman we know is likely to deliver, we give antenatal steroids, we warn her not to travel far away from the hospital, and we also begin to counsel her. We warn her to also not to travel far away from the hospital, so that if problems do occur, people will be ready to attend to her. That's the reason for identifying a short cervix, not to deliver. Sometimes you may want to give progesterone for women who are below 34 weeks. There could be some benefits in giving them progesterone if preterm labor, the risk of preterm labor is high, but not to deliver them. Right, so it's now 28 or 29 past. I have 2 watches with me, so I don't know which one is correct. We will start the next segment of our meeting. So, like I said from the beginning, we have a wonderful team of presenters who are all local, which is a very a great achievement to have doctors who can address this complicated area of obstetrics. So the next speaker is Dr. Dwyer. Dr. Dwyer is an obstetrician and gynecologist at Mpilo, and is also a fellow, a passionate fellow of fetal medicine in Bulawayo. And his passion is preeclampsia. He feels the pain that most women do feel. Those who come with severe fetal growth restriction, those women who go through our labor wards with damaged kidneys, with CVAs. So Dr. Dwyer actually feels the preeclampsia. So there's no question that Dr. Dwyer is very passionate about preeclampsia, and he thinks we can do better than what we are doing to try and address the scourge of preeclampsia. Just like William Ballantyne said to his colleagues of Edinburgh in the 19th century, it was 1906, I think, where he told them that it was better to identify the evils of pregnancy early before they become pregnancy dangerous. So this is the topic of Dr. Dwyer today. He's going to be talking to us about preeclampsia screening. Preeclampsia is a pregnancy dangerous. It's causing pain, untold suffering, and a lot of damage to our women here in this country. For those who work in the high-risk hospitals, I'm speaking things that are close to you, that you witness every day. Probably we have doctors in the hospital right now. They are witnessing this scourge of preeclampsia. So please, Dr. Dube, take over and let's proceed.
Thank you very much, Dr. Verenga, for the opportunity that you've given to me to be able to make this presentation. And as we have rightfully said, so this condition actually has become a big thorn in my flesh. Day in, day out, I actually come in contact with some of these women who have been damaged by preeclampsia, who have delivered early due to preeclampsia, and who are predisposed to several long-term complications arising from this disease. So it also gives me great pleasure that I'm making this presentation in the month of May. And as some of you may know, this is our preeclampsia awareness month. And tomorrow, the 22nd of May, it is indeed World Preeclampsia Day. I'm very happy because this disease is now being given some form of recognition. There is an awakening in the world to say preeclampsia is a disease that we need probably to focus more on than we've been doing. And I also want to believe that a lot of effort has actually gone in reducing sepsis, postpartum hemorrhage, but not so much of effort has actually been put in us trying to predict preeclampsia and in trying to prevent it, especially in our setting. And for me, really, I really want us to talk about preeclampsia until it is given, I think, the same recognition as HIV. You know how HIV became so much of a scourge that we are actually routinely screening for it, even in pregnancy up to today. Although we know that we are being told that our PMTC has worked so well that it is now even rare for a woman, for a baby to get HIV through normal labor and delivery in our setting currently. That is exactly how I want us maybe to talk about preeclampsia until it has such recognition in our country. So what is it that we're talking about? I think FIGO in this article, they were quite clear and they were quite unambiguous in really characterizing the disease in this slide. They said that it's a condition that affects about 2 to 5% of pregnant women. In Africa, in some of the African countries, it is as high as 8 to 12%. And we know that it is actually the leading cause of maternal and perinatal morbidity and mortality, where it is estimated globally that 66,000 women die each year from preeclampsia, and globally 500,000 babies die each year from preeclampsia. And that the commonest deaths actually are occurring in our setting, especially in our low-resourced countries such as ours. We know that the effects of preeclampsia do not just end at delivery, but they may continue to cause significant morbidity in the woman in terms of developing long-term complications, such as some cardiovascular diseases, diabetes, obesity, and even the infants that are born to these women are usually born prematurely, and they also are at risk of several other long-term complications that in the interest of time, I will not be able to go through all of those. But what is surprising is that we know which patients are actually at risk of developing preeclampsia from risk factors alone, such as chronic hypertension, renal disease, autoimmune diseases. And we know that advanced maternal age, nulliparity, obesity, ethnicity, just being Black, like Dr. Verenga mentioned before the break, puts our women at higher risk of developing preeclampsia than at any other place in the world. But what's so surprising is that we do not seem to be doing anything about predicting it. We seem to be comfortable managing the condition, chasing after the complications, running day and night to deliver premature babies, congesting our neonatal intensive care units, delivering SGA babies, IUGR babies. So the amount of effort that I think we are putting in managing the condition might as well be put in predicting the condition. So there are a series of 4 questions that I want our attendees to be answering as we go along, so that they could be able to, at the end of this presentation, be able to mark themselves and see how much of the condition they know. So the first question there that I put up is, what is the detection rate for preeclampsia using maternal factors only? Is it 40%, 70%, or even 90%. We'll come to the answers during the presentation. So when I speak about this, some people may think Dr. Dube is deriving his assumptions from data elsewhere. So I said, what are the studies that have been done locally to be able to understand the burden of the disease? There's a study that was done in 2017 at Mpilo Central Hospital by Professor Solo Ayongwenya, which actually showed that nearly half of the babies that were born close to stillbirth and early neonatal death. So you can see the burden that this condition is presenting to our neonatal population. And that most of these cases, about 60% of them of early onset preeclampsia. And that 78.5% of these cases were delivered by cesarean section at our hospital. And all the cases were admitted to IC after a cesarean section. So you could see how much of a financial problem, how much of a setup burden this disease actually is in our local population. And currently there's a study that I'm involved in where we are looking at characterizing the burden of the disease further and also to assess the implementation barriers of a pragmatic screening protocol. So we have not finished analyzing the data, but this is what has already come out so far. So this data is actually derived from a study that we are doing where we looked at all cesarean sections that were done for an indication of severe preeclampsia or eclampsia in 2021. So from Mpilo Central hospitals, we did 3,528 cesarean sections in total in the year 2021. 392 of these cesarean sections were done for an indication of severe preeclampsia, eclampsia, abruptio, or HELLP syndrome. We then went further to say, what were the characteristics of these women that were operated for a complication of pregnancy, which is hypertension or gestational hypertension or hypertensive order in pregnancy? So you'd see there from the first paragraph on the left that these are fairly young women. 18.1% of these women were aged 20 years and younger. So you could see that these are 15-year-old, 17-year-olds, 16, 18-year-olds. You would also see there in the middle, the tallest bar there, that these are women who are fairly young, 20 to 35 years of age, 63.5% are already having a cesarean section for preeclampsia or for eclampsia. If you move on to the one where it's indicating parity there, you can actually see that these are women who are of low parity. 49.8% of these women that we operated last year at Mpilo for preeclampsia or eclampsia had no babies, were in their first pregnancy. So we're operating half of our women for preeclampsia at Mpilo in their first pregnancy. But however, I think if you look at the one that is at the bottom, let me put a pointer and see. Dr. Verenga, I think, came back to the slide to say, why do we seem stuck like we are doing? We are again highlighting there that for any preventive measure, like aspirin to work, we need to be seeing these women less than 16 weeks. It has been shown that it is that time or before that time when we are probably going to derive most of the benefits. But look at this graph, it is showing that 52.4% of our women came at a gestational age of more than 16 weeks. Only 29.8% actually came less than 16 weeks. Therefore, if we're to make any meaningful change, it was only going to be probably in this 29.8%, and that is not enough. In the middle here, we are saying, what were we doing? What was the indication for that cesarean section? You would see there that the commonest was preeclampsia, severe preeclampsia, followed by eclampsia. So we've got many of these women that are coming in with eclampsia. 23.3% of these women actually had eclampsia of the cohort that we actually looked at. Then we said, at what gestational age were we doing these cesarean sections? 44.7% of these patients were actually done at term. 55.3% were preterm. So we are delivering these women preterm or prematurely because of the underlying condition. Sorry, let me just then we said to ourselves, we said, what are the birth weight? We then went on to further deep dive into the data to say, what were the birth weights that we got from this cohort of women? You see there from the graph, 7.8% were less than 1,000 grams, 1,000 to 2,499, 51.7. So you'd see that the majority of these women actually were delivered prematurely, had low birth weight babies. We said, what about the APGAR scores? It's very terrible when you look at this graph, where 11% of those cesarean sections were stillborns, were IUDs. You would see FSBs, macerated births, 1 and 5, APGAR of 1 and 5, 18.4%, 6 and 7, 34%. Only 36.6% of these babies that we delivered had APGARs of 7 and or had APGARs above 7. So if you look at these statistics, they don't paint a very good picture and very good profile of our women. So I then went back and said, what has been proposed and what is it that the world feels we need to be moving towards? So in 2019, actually, we started an initiative on preeclampsia where they wanted to suggest a pragmatic guide for first trimester screening prevention. They were very unambiguous in what they said. They said all countries have an obligation to implement the best preeclampsia testing and management practice that they can, and that greater efforts are required to raise awareness of the benefits of early prenatal visits targeted at reproductive age women, particularly in low-resource countries. So you would see that we need to be doing something different from what is currently obtaining on the ground. Then I asked the question, so why should we be screening? We should be screening so that we're able to offer timely interventions as early as we can, because we know that early identification of women who are at high risk of developing preeclampsia is very important. And if these interventions are put in early, we're going to improve placentation and we're going to at least prevent or reduce the frequency of placental insufficiency. And even if we are not able to offer aspirin in those women who do not present enough, we are also able to ensure prenatal surveillance to be able to anticipate and recognize the onset of the clinical syndrome and manage it promptly. I'm going to come back to this point once again. So I'll pause here to put our second question to attendees to say, when should we screen preeclampsia? Is it at delivery? Is it before pregnancy? Or is it in the first trimester? Then I said for us to be able to understand the screening method that we are proposing or that has been proposed, we need to be able to understand a bit of the pathophysiology. I think we all know and we've come across the fact that although we do not completely understand the pathogenesis, and that it is, although it remains a bit unclear, but we know that there is a current theory that seems to suggest a two-stage process, where we know that there's shallow invasion of the trophoblastic tissue that results in inadequate remodeling of the spiral arteries. And this is thought to occur initially at 8 weeks, and that this is a subclinical phase. And it is this subclinical phase actually that then creates this window of opportunity for us to be able to predict and prevent preeclampsia. But once this subclinical phase has not been attended to, then there is presumed that there is now a second stage where then there's a maternal response to this endothelial dysfunction that then leads to some angiogenic and angioangiogenic factors. That these are the ones that then give rise to the clinical syndrome. So if you look at the bottom here, that we have got immunological factors, pre-existing factors, genetic factors, and an increase in placental mass that then feeds into an abnormal placentation. And because of the reduction or because of abnormal remodeling of the trophoblastic cells in the placenta, you actually now get reduced placental perfusion. And it is these anti-angiogenic and angiogenic proteins that become very vital in ending up with a systemic vascular dysfunction. This slide is proposing more or less the same thing, that as long as we fail to have normal vessel remodeling. We are on a downhill slope in terms of developing hypoxia, in terms of increasing this protein, decreasing some of these angiogenic factors, and we end up with endothelial dysfunction of maternal vessels that leads to a maternal syndrome. So it is thought that really at the biochemical stage, we actually have an imbalance of these two important factors that I'm going to speak about in the slides that follow. And it is this imbalance sort of that leads us to the hypertension, to the proteinuria, to the cerebral edema, and to the liver dysfunction. So screening. So when should we be screening for preeclampsia? So preeclampsia, in my own opinion, should not be a once event or a once in all event where you stay in the first trimester and you forget about the woman. But there is a proposal from the Fetal Medicine Foundation and the gurus in preeclampsia that screening at 11 to 13 weeks will be able to identify women who are at high risk of developing the condition, who can actually have aspirin or calcium, which can then substantially reduce the incidence of preterm preeclampsia. I know that in our setting, we're probably at the moment not going to be able to achieve this, but however, we still have an opportunity again, even in the second and third trimester. That though this screening may not lead to us giving aspirin or calcium, but however, it will lead us to be able to identify those women who are at high risk, where we can then offer them intensive monitoring that could lead to an early diagnosis of preeclampsia and, of course, a reduction in the adverse perinatal events associated with the disease. So all hope is not lost in our scenario where we cannot be able to find these women in the first trimester. We can still be able to do something even in the second or even in the third trimester. So I'm really not talking about something that began yesterday or something that began soon. So there has been quite a number of studies and a number of timeline and critical events dating back to the 2000s, where people actually started to recognize that preeclampsia was becoming a problem. But I want to highlight a few of these. In 2010, they came about the NICE guidelines. I'm going to discuss those in detail. That actually started screening for preeclampsia using maternal factors. In 2013, the ECHO guideline also came out. In 2016, that's where we've got the Fetal Medicine Foundation, first trimester prediction by computing this model. That model has actually been refined up to date. So to date now, we have got, in 2018, there was some latest ECHO guideline that actually came through. And in 2019, like I've already highlighted, FIGO actually endorsed the first trimester screening method as proposed by the Fetal Medicine Foundation using the triple test that I'll come to. I'm sure most of you are very familiar with the slide, where we've been using, even in Zimbabwe, we've been trying actually to use, or even without success, trying to use the binary scoring system, where we are categorizing women into high risk and moderate risk and looking at their risk factors to say who is likely to develop preeclampsia. These were proposed by the NICE, the ECHO Chemist's own guidelines, and even Society of Fetal Medicine came up with these guidelines. But however, it has been shown that though simple, the detection rate for preeclampsia using only maternal factors, that is for early preterm preeclampsia, is only 40%. So if you are going to be using risk factors alone, you are going to be missing probably 60% of women. These are the women who come fitting in labor, who come with severe preeclampsia, and you are wondering, where did all this eclampsia develop? When did it develop? It developed because even if you're to use these, strictly speaking, you are still going to miss about 60% of these. And again, like Dr. Verenga said, it is pointless to categorize someone as low risk or high risk. How high is the risk? Do they have a personalized risk? Give them a personal risk, because just saying high risk or low risk, how high is that risk? how low is the risk. So we need to be moving away from this and adopting this early prediction preeclampsia model by the Fetal Medicine Foundation that says you need to be able to identify a priori risk for this woman using the maternal risk. You add to that risk the biophysical markers, you add to that the biochemical markers, and you come to what they call an adjusted risk. So it is no longer business as usual or no longer recommended to be using maternal risk factors only, because we've seen that detection rate misses about 60% of women who will eventually develop the disease. So how did this model come about? This model came about through use of multivariate logistic regression analysis, where it uses a combination of maternal factors, the mean arterial pressure, the uterine artery peak systolic velocity, the serum PAP-A in some places where placental growth factor is not measured or cannot be determined, and at 11 to 13 weeks of gestation. And we know that if you to apply this model, your detection rate rises to about 3% and 36% for the prediction of early and late onset preeclampsia respectively, if we're to have a false positive rate of 5%. So it is superior to the detection rate of the traditional checklist-based approach, which relies on maternal factors on. And this model is actually evolved over these past few years to be the best model available at the moment. So how does it perform? So if you are to look at the blue, let's consider on the blue for now, for preeclampsia less than 37, for preterm preeclampsia. So you see, if you're going to use maternal factors only, your detection rate is only 45%. If we're to add the mean arterial pressure, that detection rate goes to about 51%. If you're to do an ultrasound scan of the uterine artery pulsatility index, it goes to 58%. If you're to use, that means if you're using the maternal factor, and the scan, you 58%. If you're to combine the three, the maternal factors, the mean arterial pressure, and the uterine artery Doppler, your detection rate goes to 68%. And if now you use the biochemical markers, you add placental growth factor to your screening method, that goes to about 75%. So you can see that there is an increase of around 30% detection rate that you're going to achieve by using this model rather than using maternal factors only. So how good is this model? Is this a model that can be applied anywhere else in the world? Yes, there have been many other validation studies of the same model that have been carried out in Europe, that have been carried out in China. But sadly, you can see that Africa remains alone and solitary. So it has not been validated in our setting, but it does not necessarily mean that it cannot be applied. So you can see that this is a model that that has been done in most populations, and it has actually been shown that it is able to give comparable predictive performance corresponding to original studies in the original populations in which it was done. So it is not a model that can be doubted. It is a model that can actually even be used in our own setting. So this will be my third question to our attendees, to say the recommended dose of aspirin prophylaxis. Is it 75 grams A? Is it 150 milligrams B? Or is it 100 milligrams C? So I went back to the literature to say, what are the screening guidelines that exist currently? What should we be doing? How should we be doing it? So we know again that mean arterial pressure must be measured as part and parcel of any preeclampsia screening method, and that it is more useful than measurement of the systolic and diastolic pressure. I know that in our setting, we usually say 160 or 110 is severe preeclampsia, but we need them to determine what is the mean arterial pressure. It has been shown that it is actually more useful than just determining the systolic and diastolic. And we know that in pregnancies that preterm preeclampsia, the mean arterial pressure is increased. Right. The other question that I want to ask, the last one is, if the cutoff is, if the cuff that we are using to measure the blood pressure is too large, will the mean arterial pressure be underestimated or overestimated? So this answer is a true or false. If the cuff is too large, are you likely to underestimate or to overestimate the mean arterial pressure? I also want to emphasize that this measurement of mean arterial pressure should not just be a haphazard means, it's not just done haphazardly. There are proposed recommendations on how this should be done. We know that the person must be sitting upright with their back straight. The arm cuff should be placed on the arm at the same level of the heart, that the hand must be relaxed, and that the patient must be sitting comfortably with their feet flat on the floor. We also know that we need to use an appropriately sized cuff. I'm not going to put much emphasis in this, but it is important that this measurement must be done after a rest for 5 minutes. I've seen some people who have just walked up a flight of stairs, they are measured the blood pressure, some are talking, some are engaged in other activity. So it is not the right way to be measuring the mean arterial pressure. Why am I putting so much emphasis in how the mean arterial pressure should be measured? Because we know that if there are errors in determining this blood pressure, we are likely to have some variations. For example, if the arm is unsupported, there is a variation of 10 millimeters in the blood pressure that you are going to get, in the mean arterial pressure that you are going to get. If you just wrap the cuff over clothes, which I've seen sometimes happening in some of our hospitals that I will not mention, you have a variation of about 5 to 50 millimeters of mercury. I know that it is winter, so people sometimes they don't want to cause hassles to the patient, but we need to apply the cuff on the skin and not over any kind of clothing. If the patient is talking, look at it, 10 millimeters of mercury variation. If they have a full bladder, if they are sitting with cross, so it is these seemingly a very simple things that may actually make you miscategorize someone, make you at the end of the day have a very wrong risk for that particular individual that we are seeking to assist. We know also that we need to be determining the uterine artery systolic or mean uterine artery pulsatility index. So it should be measured, or it should be done in the context of screening for preeclampsia. And we know that it tends to be high in pregnancies that have impaired placentation and at high risk of developing preeclampsia, and that it can be performed either transabdominally or transvaginally following a similar technique. And if we're to use it alone, your detection rate of late onset preeclampsia will be 26%, and the detection rate for early onset preeclampsia is 48%. So it seems to perform quite better for early onset preeclampsia. So it must form part and parcel of your for your screening protocol, whatever protocol you're going to adopt. Some of my colleagues, I think, have spent quite a lot of time discussing how this should be obtained transvaginally, abdominally, and what are the issues to do with method of determining it that you are going to be using. So I'm not going to spend a lot of time on this, except to say that there is a protocol that one is to follow from ISWOC, from the Fetal Medicine Foundation side of fetal and maternal medicine. There are many protocols that you can, but all of them really seem to suggest almost the same thing on how you ought to determine it, on how you ought to set the sampling gate, on what angle of insonation you should use, on what your peak systolic velocity should be, and how you should, in fact, be able to determine the average pulsatility index. So I'm not going to spend a lot of time on this, except then to come to this, say, there are very useful biomarkers that have been shown to be very useful, that if we're to be added to your maternal factors, to your mean arterial pressure, to your scan findings, and then you add this, you are likely to get your detection rate to quite very high levels, and you're going to be missing very few people in your population. And one of those suggested is placenta growth factor, which we know that is synthesized by the placenta. It is part of the vascular endothelial growth factor, a family of proteins, and it is a potent angiogenic function. So in pregnancies that developed preeclampsia, it tends to be lower than in normal pregnancies as a consequence of placental hypoxia. And if you look at the detection rates, they are quite reasonable, 55% for early onset preeclampsia, 33% for late onset preeclampsia. So I come to this because we're going to, it has a bearing on what you do in the second, also in the third trimester, the serum soluble FMS-like tyrosine kinase 1. So it is an anti-angiogenic factor, and it has been shown that in those patients with established preeclampsia, their levels tend to be increased. And we know, or studies have actually shown, that this increase in their levels actually precedes the development of the disease by about 5 weeks. And then after that, it then appears to correlate quite well with disease survey. So it is a very, very useful anti-angiogenic factor that we need to be able to think about for the future, even in our setting. But however, there's more caveats to it, that it is not routinely used for the first trimester screening, but is useful in the second and third trimester, because if you're to measure it between 11 and 13 weeks, it does not seem to improve the prediction of preeclampsia, even if you're to compare this with maternal factors alone. So it is most useful if you do it around 22 weeks for you to be able to predict preeclampsia at less than 32 weeks. And we know that if you measure it at 36 weeks, it will be very useful for you to predict preeclampsia at greater than 37 weeks. So you see that throughout pregnancy, there's no point or there's no stage of that pregnancy where you cannot have some form of prediction of whether this woman is going to develop preeclampsia or not. Why I'm saying this is because I've heard many people saying, our women, they present the second trimester, their disease has already started, there's nothing that we can do. There is something that we can do if we seriously think about what else we could offer at whatever gestation that they are going to be presenting it. So there is no time where you could say, there's nothing I can do about this patient's prediction of preeclampsia. You can see that you could actually even measure the serum soluble FMS-like tyrosine kinase even at 36 weeks to see if a woman would develop preeclampsia at greater or equal to 37 weeks and offer surveillance and early diagnosis and be able to deliver that woman earlier than necessary. So having spoken about all this, how then do you personalize, how then do you assign a risk to a woman? I think Dr. Verenga, before the break, showed this screen. So what has happened now? Once you have done your maternal factors, so your maternal factors with the FMF and protocol and you are going to come up with this, where you're going to, if you are to like Dr. Verenga spoke about how you can be licensed by the Fetal Medicine Foundation for you to be able to use their protocols. So you would come to a screen where you are going to put everything, the maternal factors about that patient. You are also going to be able to measure their blood pressures, the mean arterial pressure. You are also going to be able to do your scans and be able to put your uterine artery pulsatility index. After that, you're also going to be able to determine the placenta growth factor, the levels of PAP-A, and many other things that you may be able to determine, the other biomarkers. So at the end of the day, the screen, or what is going to show you, is going to be able to show you something like this. Maybe Dr. Verenga quite clearly was able to demonstrate this, that once we have put in this, the calculator is able to give you the personalized risk of the woman. So in this woman, we see that her risk of developing preeclampsia before 34 weeks was 1 in 8,184. For fetal growth restriction, for women's delivered before 34 weeks. So it is going to give you, at the end of the day, a personalized risk that we are then going to be able to counsel the woman upon and be able to offer the best care to that woman. So you should be able to put all this in the software that is going to then be able to calculate every day the risk for the woman. So the question is, so what happens when you've got that risk? How are you going to use it? So the next stage now would depend on that one is high risk or that woman is low risk. By high risk, we mean that the patient is a greater or equal to 1 in 100 chance of developing preeclampsia. And we know that it is only about 10% of our women who are going to be classified as high risk for preeclampsia before 37 weeks. And it has been shown, I'm going to come back again, that treatment with aspirin, 150 milligrams per day from 12 weeks to 36 weeks, will be able to reduce the risk of preterm preeclampsia by about 60%. So the other women who are going to score low, we are not going to tell them, go home, everything is okay, we'll see you at delivery. No, those women can be assured that development of preeclampsia less than 37 weeks is unlikely, but that they require reassessment of risk again at 22 weeks of gestation in the second trimester. Because this is important, because we have seen women who have been screened before, they're told their risk is low, but come back at 38 weeks fitting. It's because we have missed this very critical information to be able to supply to them. To say the risk is like a moving target, we need to be continuously engaging with this to be able to screen them in the second trimester and also in the third trimester. So we don't tell those women who are low risk to say, no, there's no chance of it developing preeclampsia. We even stop measuring their BPs. We even stop determining the mean arterial pressure. We need to continuously keep them with us so that we could be able to diagnose even a maternal condition early, be able to offer not aspirin in this time, of course, but to be able to offer antihypertensive treatment, admit them for steroids, and plan even an early delivery before we have intrauterine fetal demise. So this slide is trying to show us how we can go about screening in the second and the third trimester. So we don't stop only in the first trimester. This is the point I was explaining earlier, to say even if our women do not come in the first trimester, there's something else that we can still do for them in terms of their risk assessment, even in the second and the third trimester of screening. So you would see here that in the second trimester, if we are to, I can see my pointer, if now we are to add SFLT1 for those countries who are well resourced, there's 100% prediction now in the second trimester of preeclampsia developing before 34 weeks. So there's something that you could do by adding the other marker. You see even here that at 32 weeks, if you to add SFLT1, you have 98% prediction of preeclampsia before 37 weeks. So it is important that we continuously offer these women screening again in the second and the third trimester. So this I put this up so that I could give a summary of how we ought to be moving in the algorithm. So in the first trimester, all pregnant women need maternal factors, mean arterial pressure, we need to scan them, placenta growth factor. We risk evaluate for preterm preeclampsia using the software. We're going to have high risk women, low risk women. High risk, we give them aspirin. We bring them again in the second trimester, where again, if we are to start in the second trimester, this middle one is if we are to start in the second trimester, all pregnant women, we offer them the same things. We include SFLT1. We again risk evaluate for preeclampsia. If we are high risk now, we don't offer aspirin, it's too late for aspirin. What do? We offer them high level surveillance for preeclampsia symptoms and signs between 24 and 35 weeks. And we are going to reassess again at 35 to 37 weeks of pregnancy. Those patients who are low risk and not on aspirin, we bring them again in the second trimester, we determine their risk. If they are still low risk, we offer standard surveillance, we reassess again at 35 to 37 weeks. So it brings me to the point that the risk assessment for preeclampsia is an ongoing. You don't stop at the first trimester or stop at second trimester. You can still find some high risk women even in the second or even in the third trimester, as demonstrated here by this algorithm. So we cannot speak about prevention of or screening for preterm preeclampsia temporary or pre or term eclampsia without talking about aspirin prevention. We have got a lot of evidence in the aspirin trial that have shown that without a doubt that aspirin really works. It has been shown from that study from the trial that if you're to put women on aspirin, you reduce their risk by 82% of them having preterm preeclampsia. So it is not it's not a drug that we can underestimate. It's something really that is a very good tool, a very huge arsenal in our weaponry against preeclampsia. It has been shown that it is able to reduce quite drastically the chances of these women developing preterm preeclampsia. Of course, without much benefit in reducing term preeclampsia. There is this meta-analysis that I put here by Robert et al. In 2017 that actually affirmatively concluded thus, that aspirin less than 100 milligrams per day starting at any gestation has no benefit. Aspirin started at more than 100 milligrams a day started after 16 weeks has no benefit. It also showed that aspirin of more than 100 grams a day started before 16 weeks has a major benefit. So the dose matters, the timing matters. I've seen women who are on 75 milligram, women who are on 100 milligram. All that has no benefit in reducing that woman's overall risk. I'm running out of time. I'll try to be as fast as I can. So is this something that is feasible? Yes, it is something that is feasible to be able to do, especially in those well-resourced countries. How so? Because recording maternal history and the measurement of blood pressure are universally carried out as part of routine pregnancy care. So it is something that can be easily implemented, even in our own setting. And also that the measurement of mineral pressure is also done routinely, but it requires adherence to a protocol. So if we are to implement this, we need to adhere to a protocol. And we know that it can be undertaken by healthcare assistants after minimal training. What about the measurement of UTAP, of the pulsatility index of the uterine artery? It requires specific training of sonographers and quality assurance of their results. I think which is something that we are trying to encourage, that we've heard about in the morning and throughout this meeting, that we need to be very good in undertaking these scans and following a proper protocol. And the machines are part of routine of ultrasound scans. That the same machines that we use in scanning women almost on a daily basis can actually be hooked up to be able to carry this of course, with the right training. And in those countries where they're able to do this, they actually found out that those same machines that they use for the unemployed in the first trimester can actually be adopted or adapted to be able to measure the placental growth factors. So what is the challenge in our setting? I think the biggest challenge was summed up by FICO in 2019, where they said a key barrier to prevention of preeclampsia in low-resource countries is delayed access to first antenatal visit or contact with a skilled health personnel. And that is removing these barriers to antenatal care, such as acceptability, affordability, accessibility, and even quality issues can go a long way in making this a reality. Some may ask and say, of course, the tests such as placental growth factor, the uterine artery scans are not readily available in primary healthcare settings like ours. So what is the practicality of measuring the blood pressure and calculating the mineral pressure? And what about the software availability? Are we going to be able to have a software like this in Morambinda, for example, in Binga, for example? Those are some of the things that we ought to start to think about. So then in our setting, how can we then find a right balance? Are we able to do the standard test as recommended by the Fetal Foundation? Can we modify the screening protocol to have a two-stage screening strategy? What if we just use the maternal factors and miniature pressure and get the detection around 56% I spoke about? Will that be enough? It may be better than what we are doing now. What if we treat those with maternal factors only and screen those who are at low risk? If someone comes we find that on maternal factors, they are high risk, we put them on aspirin, and then we screen only those that are a low risk. What if we don't screen anyone and we give aspirin to everyone? If this screening is such a hassle in our setting. So I then thought, let me just discuss what someone could do with a two-stage strategy. The two-stage strategy actually seems to suggest that we could actually get the total population. We do the first stage screening where we are going to use the maternal factors and the mean arterial pressure. We are going to have some women who are screening negative, and those will be screened negative, and then we may then follow them up. But those who are going to screen positive are those then that we are going to offer a second screening stage where we are going to scan them and be able to include the placental growth factor. Where in this kind of screening strategy, we're only going to have a baseline test that combines the maternal factor with mean arterial pressure in such resource-constrained situations. Why? What if we treat based on maternal factor and screen the low-risk women? Again, this approach seems to be very problematic to me because it does not offer a risk to these women that you would get through a standardized algorithm. And remember, actually, that it is the level of that risk that you determine. That determines what you are going to do in the second trimester or in the third trimester as a way of follow-up. And if you're to do this kind of method, some women may receive unnecessary monitoring and anxiety between the 24 to the 32 weeks period. So it is a strategy that may look good and may look cost-effective, but it has some underlying problems with it. Some people have said, you cannot do this in Africa. Why don't you give everyone aspirin? We are already giving everyone folic, we are already giving folic acid, we are giving everyone ferrous sulfate, and in high-risk women, we are giving malaria prophylaxis. So why not? What is the fuss about all this screening that you want to do instead of just giving everyone prophylaxis? So they ask, why should you go through this laborious process of screening if the most effective intervention you have is aspirin or calcium for the high-risk group? But we know that if we are to screen and assign a risk, we are going to get much better compliance from patients who know that they are higher risk and they are going to be taking a drug because they have a risk assigned to them. It has been shown that if we are to give everyone aspirin, the compliance, especially in those who are at low risk, actually is less than what you would get. Again, you'd ask, questions are being asked, what would be the safety of aspirin in those large populations? It may be better to give to those who are at high risk to be able to have a justification for any unintended harms that come from the aspirin prophylaxis. The risk of hemorrhagic disease, is it justified in low-risk women? So the question is, should we be targeted or should we be preemptive? So these are, I'm going to the last two slides, Dr. Venga, sorry for the time. So what could be the solution? So recommended the following. It said, you could do universal screening where all pregnant women screen them between 11 and 13 plus 6 weeks using a combination of maternal factors and biomarkers. So this will be the standard Fetal Medicine Foundation protocol. But however, where resources are limited, routine screening for preterm preeclampsia by maternal factors and mean arterial pressure should be completed in all pregnancies. So if anything, we should not be using the maternal factors only, but we must endeavor also to add mean arterial pressure to whatever screening protocol that we can be able to achieve in whatever population of women. And once we identify these women, ideally we should put them on aspirin prophylaxis, not 100, not 75 milligrams, but 150 milligrams a night from 11 to 6 weeks of gestation. So how could we make a difference in our setting? We need to prioritize to be able to provide education, consistent adherence to clinical guidelines, and improvement in our referral pathways. And of course, Dr. Verenga spoke about this, the workforce shortages, availability of essential drugs, and even the gaps that have been identified in governance and in financing. So as a conclusion, I want to say this, that the current strategy of using only the maternal factors is not effective. We should do away with it. It is missing 60 to 70% of women who ultimately developed preterm preeclampsia. there's a strong body of evidence supporting combined screening. That pre-eclampsia screening should be part of routine antenatal care in the first trimester. And that this screening should be a continuous process. And that a minimum of a combination of maternal history and the neonatal pressure makes a difference even in low resource settings. I wanted to end with what Albert Einstein said. He said insanity is doing the same thing over and over again and expecting different results. Thank you very much, Dr. Verenga. Sorry for not keeping up to the time. I'm done.
Thank you so much, Dr. Dube. Great presentation. On a hot topic, this topic is such a topic that we should all feel for it. If you are managing pregnant women, you know the kind of damage, the suffering that we have seen women going through. I think it's about time that we begin to make real changes on the ground. We need all people who do scans, from radiographers, sonographers, obstetricians, midwives. We need you to learn how to do uterinatal Dopplers. That's the first step. We know blood pressures are being done, but we need to teach people how to do it properly so that we can start doing something. Implementation comes to people who are preparing themselves. Even if as a nation we say, okay, we have enough scans at certain place, let's adopt this. But we're not going to have enough people to do uterinatal Dopplers. In the same way, we may not have enough MAP machines. So these are some of the first steps we need to make, but there's no doubt that we need to screen for the disease. Well, the disease is causing a lot of damage that we see. And it is very painful for those women who book early, who have a scan without uterinatal Doppler, only to be told that your baby is FGR at 28 weeks and the baby weighs 500 grams. It is so painful. You always think, could they have benefited from aspirin? Could we have pushed the appearance of the severity later on by administering aspirin? But all these are lost opportunities amongst our people due to a system which is not moving with the times. So we need to move with the times. I think I need to introduce the next presenter. I think he's ready. So Dr. Dube, please stay for the questions. There is one question probably which I need to answer. I think it came late. Somebody was saying the serum markers perform better earlier on, around 8, 9, or close to 11 weeks compared to the nuchal then. And isn't it better for us to do a two-stage screening process where women may come at 8 to 9 weeks to have their biochemistry done and then their nuchal done? For sure, that idea was explored a long time ago. You are right. But the reason why people came to settle at 11 to 13 weeks, the perfect time to do screening is 12 weeks. It's because the 11 to 13 week appointment is not only for aneuploidy, as you can remember. It is also to do other things, including checking for the fetal doing fetal anomaly. You will find out that at 11 weeks, you will struggle to even see the kidneys of the baby, but you can see them better 12 weeks. At 13 weeks, the baby is not posing nicely for the nuchal. You struggle to put the baby in a good position to do the nuchal. In most cases, it is seated. Remember, it's not both of them, they are opposite. PAPA should perform better earlier on, but beta-HCG performs better later on, around 13 weeks. So a balance to be found to say what is the best time to screen these women. If a woman is to ask you, when should I go from 11 to 13 week appointment? It is 12 weeks. That's the best time in the 12 week. One, told you. And the performance of PAPA and beta-HCG, they cross around 12 weeks. Like I told you that beta-HCG differentiates better babies with Down syndrome around 13 weeks. At the end of the 13th week, my laptop is on. At the end of the 13-week period, while puppy performs better earlier on, around 11 weeks. So that's the reason why we talk. Problem if we put 12 weeks alone, you're going to miss a lot of women. So 11 to 13 weeks is a fair gap because it gives women, 3 weeks to come for screening. Right, so the next speaker is Mr. Shigayo. Mr. Shigayo is a radiographer who is almost a sonographer now. He is passion for fetal medicine, and Mr. Chigayo, besides the medicine unit, I've also worked with him. So he has developed a strong interest in the fetal defects. I think even his diagnosis of fetal conditions is becoming more and more accurate. I even see some of the patients that we have scanned outside. I no longer doubt his diagnosis now because in most cases it's spot on. So he is a budding specialist in fetal defect diagnosis. So this is Mr. Chigayo, who is going to present to us on fetal anomaly scan, excluding the heart. Please go ahead, Mr. Chigayo.
Okay, thank you, Dr. Verenga. Good afternoon to everyone. Okay, so today I'll be presenting on fetal anatomy scan excluding the heart. So basically, the anatomy scan or anomaly scan is done to check for structural fetal abnormalities or fetal survey. It is also done to check for markers for chromosomal abnormalities. It is also done for dating if the patient doesn't have any dates, or it is done for growth assessment if they have prior dating scan or they know their last normal menstrual periods. It is also done for screening for preterm, as previously mentioned, and it is also done for screening for risk for preeclampsia. Then from the on the next slide, worldwide congenital anomalies constitute around 270,000 of all congenital anomalies according to statistics, which is almost 10%. So congenital abnormalities constitute quite a large number of fetal deaths. Then locally, the prevalence of these defects based on cohorts done at Harare Hospital, looking specifically on the central nervous system, ventriculomegaly tends to be with the highest prevalence, then anencephaly, and then we also have Arnold Chiari, and then meningocele, and then we also have sacrococcygeal teratomas. So we are going to discuss some of the pathologies that are on this cohort, especially the ones with the highest prevalence, like ventriculomegaly, anencephaly, and holoprosencephaly. Then we move on to the GIT and the abdomen. So according to the cohort done at Harare Hospital, fetal ascites is the highest prevalence. There's also gastroschisis, exomphalos, and then there's jejunal atresia, amniotic band syndrome. So all these pathologies are very common, as you can see from the frequencies that they are picked from the cohorts done at Harare Hospital. Then from the renal defects, hydronephrosis, echogenic bowel, and then multicystic kidney. These are the common pathologies that they are normally picked during the anomaly scans. So the effects of undiagnosed abnormalities. Undiagnosed abnormalities significantly increases the perinatal mortality and morbidity and maternal morbidity. So the undiagnosed abnormalities affect both the mother and the child. Undiagnosed abnormalities impact upon clinical outcomes, sometimes with devastating consequences. So specifically looking at the child, when the defects are not diagnosed, the child has a missed opportunity for in utero fetal therapy. So for some conditions, when we diagnose, there is an intrauterine procedure that can be done to relieve this from to relieve the child from the effects of congenital diaphragmatic hernia. Then also lower urinary tract obstruction. In these cases, relieving the child from this obstruction before birth can protect the fetal kidneys. Then we have also another effect, which is missed opportunity for fetal surveillance and assisted delivery. So when we do not pick the abnormalities, sometimes the child misses the opportunity for fetal surveillance, as we know that surveillance might be introduced in fetuses that have abnormalities. So when we don't pick the abnormalities, then the mother is not going to be followed up, and eventually this might also lead to devastating outcomes like fetal death. And then the other thing is that there is inadequate preparation. As we know that for some pathologies, we have to prepare for the child, especially during at delivery and soon after delivery, so that the prognosis of that pathology is greatly improved. In cases where there is, for example, or exomphalos, the survival rate is 90%. But if the child is delivered at the wrong place, where there is no non-surgical, when there's no at a non-surgical center, then the prognosis decreases to 20%. Similarly to duodenal atresia and gastroschisis. So if we do not diagnose these pathology, these defects, then this child will miss or will be delivered at the wrong place, and the survival chances will then be lowered. We move on to the effects on the mother. When we do not diagnose these congenital abnormalities, this will lead to unnecessary cesarean sections being done to the mother. Why? Because most probably the defects, because of the defects, the fetus might not be able to undergo the process of normal delivery. Hence, the mother will then have to, a cesarean section will have then to be done to deliver the baby. And then interventions for fetuses who cannot survive. So after noticing later on that there's a defect of which the child cannot undergo the normal spontaneous delivery, then the mother is forced to have a C-section for a child, most probably that will not survive if the pathology is lethal. Then the mother is also deprived of perinatal palliative care to enable them to prepare for their baby's death. That is in cases where the condition is lethal. Then there's also another effect on the obstetricians, which will continue to deal with unexpected birth outcomes and sometimes extremely complicated deliveries because of the abnormalities on the baby. Right. So the anomaly scan is usually performed between 18 and 22 weeks of pregnancy. all pregnant women should be offered this scan. The anatomy of the fetus is checked systematically from the head to the toes. Each practice should develop a protocol so that we do not miss these abnormalities. So, for example, when we are doing the 18 to 22 week scan, that is the anomaly scan, we should then be able to fill in these all this information to say whether the head is normal or is abnormal, or whether you might not have been able to examine that particular part of the head, the face, the thorax, and the rest of the body. So after doing the anomaly scan, we should be able to completely fill in this table for us to say we have completely done the anomaly scan, and for us to be able to identify all abnormalities that will be present. So how then can we do the anomaly scan? We now move on to how we assess the fetus to rule out abnormalities during the 18 to 22 week scan. So we first of all assess the head. When we are doing the scan to assess the head, we should assess the head at the level of the transventricular plane. At this level, we should be able to see the anterior horns of the lateral ventricles. We should also be able to see the cavum septum pellucidum, which appears as a triangular box in the anterior compartment. Then we should be able to see the midline, the flux, and we should also be able to see the thalamus on both sides. And then we should also be able to see the posterior ventricles on both sides. And unfortunately, in this case, there's some shadowing, maybe probably because of the skull. So at this level of the ventricles, that's where we diagnose ventriculomegaly when the ventricles are dilated above 10 millimeters. We also want to check the shape of the head, as it should be ovoid, and it should not be lemon-shaped, that is scalloping, and it shouldn't be strawberry-shaped or clover-leaf shaped. Then after doing after assessing the head circumference, we move on from the ventricular plane. We move on to the transcerebellar plane, where we want to assess the cerebellum and the cisterna magna in the nasal fold. In this plane, we are expected to see the cavum septum. We also expect to see the cerebellum, the vermis of the cerebellum, and then the cisterna magna, which is a fluid filled space behind this cerebellum. At this plane, we should also see the vermis, but it is better appreciated in the coronal plane. So there shouldn't be any communication between the fourth ventricle, which usually lies just in front of the vermis, and the cisterna magna. We shouldn't, the cisterna magna should be assessed also to rule out mega cisterna when the AP diameter is more than 10 millimeters. The cerebellar vermis agenesis should also be ruled out to exclude conditions like Dandy Walker malformation and a mega cisterna magna in the black pouch cyst. After doing these planes, the transventricular and the transcerebellar plane, we move on to check the face of the fetus. When we are assessing the face of the fetus, first of all, we should assess the profile where we are supposed to see the nasal bone, the maxilla, and the mandible. We should be able to see these three structures for us to say we are in the correct mid-sagittal plane. We are also supposed to assess the orbits, and we should be able to see the length of the orbits. We should be able to assess the distance between the orbits. There should be the distance between the orbits for us to exclude conditions like hypothyroidism. There should be enough space to fit at least one orbit in between the two orbits. If there is more space between the orbits, then which fits more than one orbit, then there is most probably hypertelorism. Then we should also assess the palate to see whether there are any defects to rule out cleft palate. We should also assess the nose, in the upper lips and the lower lips to rule out a cleft lip. Then, if possible, we can also do the 3D image. From the head, we have to move on to the abdomen. At the level of the abdomen, we have to assess, first of all, we have to assess where we take the abdominal circumference, where we are supposed to see the stomach bubble. We are supposed to see one complete rib to make sure that we are not oblique. And then we are supposed to see the adrenal gland. And we are also supposed to see the umbilical vein as it enters the portal sinus. We are also supposed to see the liver, and we are supposed to see the aorta more to the left side, and the IVC, which is not very clear, on the right side. So we should make sure that every time we do this assessment, we should be able to see the stomach bubble, as absence of the stomach bubble with associated polyhydramnios might be a diagnosis for esophageal atresia. We then, still on the abdomen, we are supposed to see, assess the cord insertion into the fetal abdomen when we want to rule out conditions like gastroschisis and exophallus. We are also supposed to assess the umbilical cord insertion at the placenta. Then we should also assess the kidneys, both in transverse plane and in coronal plane, where we apply color Doppler to see flow the renal kidneys into the kidney. We see flow into the kidneys. Absence of renal flow might be indicative of renal agenesis. We are also supposed to see the umbilical arteries surrounding the fetal urinary bladder. We are also supposed to check the kidneys on both sides and measure the renal pelvis to exclude conditions like polyhydramnios. In this case, they were not measured. Okay, then we move on to the spine. When we are assessing the fetal spine, we are supposed to assess the fetal spine in both longitudinal, in longitudinal, axial, and coronal plane. We are supposed to see all the vertebra up to the sacrum. And we are also supposed to see the most distal part to exclude some meningocele that occur distally. And then when we are also assessing the spine, we are also supposed to see the cisterna magna so that the fluid behind the neck, this fluid that is indicated over there, which is the cisterna magna, so that we exclude pathologies like meningocele. Then from the spine, we move on to the anatomy of the extremities. We are supposed to assess both the lower and the upper limbs from in this case, from the femur, the tib, fib, and the foot. There's another image that we are supposed to include, where we assess the angle of the foot from the tib fib. So we have to take our measurements on the diaphysis and exclude the epiphysis. And then on the upper extremity, we are also supposed to assess the humerus, the radius and ulna, and all the digits. After having done all that, then we can then be able to fill in this table and completely, and in that case, we know that we've completely done the anomaly scan. So it is very important for us to make sure that we develop a protocol that we use when we are doing the 18 to 22-week scan, so that we make sure that we do not miss anything. So from the anatomy survey, we are now going on to the abnormalities. So we are going to begin with ventriculomegaly, which is one of the most common pathologies that is seen. So as we previously mentioned, when we are assessing ventriculomegaly, we should assess it at the level of the atrium of the posterior lateral ventricles. So these are some of the key features that we expect when we say we've thoroughly assessed the fetus to rule out ventriculomegaly. So first of all, we should measure the ventricles at the transventricular plane, where we see these posterior and the anterior ventricles. It is this superior plane that we are talking about. So the cerebral hemispheres on both sides should be symmetrical, meaning that the distance from the midline to the outer margin on top and below should be the same, which means that the cerebral hemispheres are symmetrical. The glomus of the choroid plexus should be in view. The glomus of the choroid plexus is this echogenic structure. Then at the level of the parieto-occipital fissure, so this measurement should be done at the level of the parieto-occipital fissure, which is at this point. Then the calipers should be placed at the inner margins of the ventricles, meaning to say they should be placed in the inner, not the outer margins. Then the measurements is made in should be measured. The ventricles should be measured perpendicular to the long axis of the lateral ventricle. So the measurement should be made at a perpendicular angle. Then if the measurement of the atrium is more than 10 millimeters, then there is ventriculomegaly. So we are going to define it in the next slide. Then the reason why we use this specific position to measure the ventricles is because first, this is the first area to dilate in the fetal ventriculomegaly. So this posterior portion at the level of the atrium, it is usually the first area to dilate when the ventricles are affected. Then it dilates to a greater extent than any other region of the lateral ventricles. There's also lack of constriction from the striatum in comparison to the anterior portions of the lateral ventricles. So the atrial diameter also remains constant between 20 and 40 weeks of gestation. So any measurement that is above 10 millimeters is considered as abnormal. So long we are above 20 weeks to 40 weeks, the measurement, the atrial diameter remains constant. So any measurement above 10 is considered to be abnormal. It was perpendicular to the ultrasound beam in the transventricular plane. That's the other reason. And measurement has a low intra and inter-observer variability. So meaning to say that even wherever the measurement is done, if it is done in another place, the outcomes usually are the same. Then
Simba, we've lost your slides. Maybe you might want to bring them back.
Okay.
Mm-hmm. Right. So those who have questions, while Mr. Chigayo is going through the presentation, please post your questions in the chat box, including all the previous presenters, starting with Dr. Dwe's presentation. You are more than welcome to post questions. Please proceed, Mr. Chigayo.
Okay, just a minute. Okay, so we were discussing ventricular omega. So we were saying the last point was that there is a low false positive. There's a low false positive when we measure the antral when the antral diameter is greater than 10 millimeters. So basically, the definition for ventriculomegaly is an antral. So the definition is an antral diameter greater than 10 millimeters. So it can be divided into severe and mild. So mild ventriculomegaly is antral diameter, which lies between 10 and 15, and severe ventriculomegaly is antral diameter greater than 15 millimeters. It can also be classified as isolated ventriculomegaly, or it can be isolated ventriculomegaly when there are no other abnormalities, and then symmetric ventriculomegaly when the difference in antral diameter, the right and the left is less than 2 millimeters. Then asymmetrical ventriculomegaly when either unilateral ventriculomegaly or a difference of greater than 2 millimeters in the antral diameter is observed. Then we move on to the etiology. So it can be as a result of obstruction or as a result of a non-obstructive cause. So some of the obstructive causes include aqueductal stenosis, intraventricular hemorrhage, intracranial tumor, Chiari 2 malformations, maybe Dandy Walker malformation, and the non-obstructive causes of ventriculomegaly might include Down syndrome or some infections. And then, so for us to be able to diagnose the actual cause for the ventriculomegaly, it is very important for us to take thorough history, which includes family history, a previous pregnancy or a child with a malformation, previous fetal or neonatal intraventricular hemorrhage, maternal medical disorders, or a history of fevers or exposure, or pets at home, history of traveling to endemic areas. We also have to do an extended neurosonography, and then we also have to carry out some tests, and then if possible, we can also do an MRI. So the prognosis of ventriculomegaly varies depending on the etiology and associated lesions or syndromes. Then from still on ventriculomegaly, there's also hydrocephalus. So when the cause is obstructive, then it is now a case of hydrocephalus rather than ventriculomegaly. Then we move on to holoprosencephaly. So holoprosencephaly is a lethal condition. Diagnosis on ultrasound begins from 11 weeks, which means that this pathology should be diagnosed during the 11 to 13 week 6-day scan. It is when there is total or partial failure of separation of the proencephalon into two separate hemispheres. So depending on the level of separation that is happening on the hemispheres, there are 4 variants of holoprosencephaly that can be derived. So there is the lobar type and the semi-lobar type, of which these two are the most lethal conditions. So the lobar and the middle variant have a better prognosis, but lobar and semi-lobar are the most severe forms of holoprosencephaly that should always be diagnosed. So the prevalence is, these statistics are from data collected from the UK, is 1 in 1,000 births. Etiology, lobar and semi-lobar, they are associated with chromosomal abnormalities, which include trisomy 13 in 47% of the cases. The diagnosis for holoprosencephaly is done by ultrasound, and there are some associated features for holoprosencephaly, which include hypotaylorism. Hypotaylorism, as we mentioned earlier on, that there is the distance between the two orbits is reduced, that we cannot fit another orbit in between. Then there is cyclopia, when there is just a single eye, and then there is also facial cleft when there is a defect on the lips, and then there is nasal hypoplasia or proboscis, which proboscis is a structure that forms on the forehead of the child. So management, there are some there's fetal karyotype, and then when there is a lobar or a semi-lobar holoprosencephaly, in most cases the mother is offered a chance to terminate, as the prognosis is very poor. So the lobar holoprosencephaly on ultrasound, there is this is the most lethal condition and is the most severe form. There's a single monoventricle and fused thalamus. Like, so from this image, we can see that there's a single monoventricle and the thalamus is fused. So we have also some associated features like hypotaylorism, like in this case where we cannot fit another eye in between. Then they might also be a cleft lip and palate, and also other abnormalities in the extremities and within the abdomen. So in semi-lobar now, there is the posterior part of the fetal head is partially separated, but still there is a single monoventricle, and part of the thalamus is fused. Then in the lobar and middle variant, usually the anterior lateral ventricles communicate, and there's also absence of the cavum septum pellucidum. So the lobar and middle variant are a bit less, more severe than the lobar and semi-lobar, which are lethal conditions. Then from holoprosencephaly, we move on to Jandy Walker malformation. So in Jandy Walker malformation, we diagnosed Jandy Walker malformation at the transcerebellar plane. So from those planes that we initially mentioned previously, the transventricular and the transcerebellar, it is a display where we diagnose the abnormalities of the posterior fossa. So in Jandy Walker malformation, there is communication between the fourth ventricle and the cisterna magna. There is agenesis of the vermis, which is the structure in between the two hemispheres of the cerebellum. So agenesis of these vermis will result in the posterior fossa abnormalities, which also include Jandy Walker malformation. Okay, so there are certain pathologies which may appear similar to Jandy Walker malformation on ultrasound, like megacisterna magna, the black pouch cyst, and the vermin hypoplasia. So the coronal plane now, in this case, it's not very clear, but the coronal plane now is the one that becomes very important to distinguish.
We have lost you, but we've lost your slide.
Okay,
And,
let me try to connect again.
But are you winning? If you are not too, are you winning?
I'm trying to connect again. Just a moment.
All right. To our guests, please bear with us. Our presenter will reconnect with us shortly, then we can proceed. Simba,
just a minute.
What has happened to your device? Have you disconnected? We wanted to.
Just a minute, I'm almost done. Okay, sorry for the inconvenience. So we were discussing then the Walker malformation. Then we moving on to acrania. So acrania is also a lethal condition that should be diagnosed during the early obstetric scan. So in acrania, this is a neural tube defect. So the structure that forms the neural tube during the 4th or the 5th week of embryology is supposed to fold and close to form the neural tube. When this folding doesn't happen properly cranially, then we are going to have abnormalities like acrania. And then when it doesn't fold properly along its length, then we are going to have abnormalities like open spinal bifida, which we are going to discuss later. So acrania should be diagnosed during the early 11 to 14 week scan. The definition is absence of a cranial vault with visible cerebral hemispheres. Then as the pregnancy progresses in the herniation of the brain structures, then we have anencephaly. So this is a lethal condition, and on ultrasound, despite failing to see the brain structures, we also see the frog's eye appearance. Then the prognosis is poor, as we mentioned, it is incompatible with life. Then we move on to open spinal bifida. So open spinal bifida is another neural tube defect. There is on ultrasound, there are indirect and there are also direct signs. So the direct signs are C or U shaped on the vertebra when we are scanning in transverse, instead of the vertebra converging along the center, there is a C or a U shape in the appearance. Then the indirect signs include a scalloping of the fetal head, which is anterior curvature. There's also anterior curvature of the cerebellum to form the banana sign, and there's also obliteration of the cisterna magna. So it is associated with Talip's bladder distension, hydronephrosis. Chromosomal abnormalities are okay in 8 to 16%. Then karyotyping is done, especially if not there's no other association. Then fetal therapy is still experimental. Then exo, when we move on to the abdomen, when we do the scan for the abdomen, as we mentioned earlier, that we should always see the cord insertion. In exomphalos, there is herniation of the liver and some of the abdominal contents within a sac at this position. So the umbilical cord then attaches to the sac. The attaches on the apex of the sac containing the abdominal contents. So when you are trying to take this image, eventually you see a mass which is the membrane containing the abdominal contents. Then for gastroschisis, there's herniation of abdominal bowel. So gastroschisis, there's no membrane, and then the contents are usually on the right side of the cord insertion. So when we are doing this assessment at this level, that's where we diagnose exomphalus and gastroschisis. Then we move on to duodenal atresia, where there is a double bubble sign that we see on ultrasound, and as a result of an enlarged stomach and the duodenal cap. So atresia, so this is the sign that we see for duodenal atresia. And for esophageal atresia, initially we mentioned that when we want to do the abdominal circumference, we don't see the stomach bubble, and then we can also diagnose we can also diagnose ileoduodenal atresia, where there is dilated small bowels greater than 15 millimeters. So duodenal atresia is also associated with polyhydramnios, and then trisomy 21 are found in 30% of cases. Delivery is done at 38 weeks. The survival rate is usually greater than 95% if delivery is done at the proper place. Then this is an image of gastroschisis where there is no membrane, and it usually happens besides the insertion of the umbilical cord, usually on the right side. Then delivery is done at 38 weeks. So this one, trisomy is not increased, which means that this one has got a better prognosis when compared to exomphalus. Then we move on to urinary tract abnormalities, which include hydronephrosis, which has got the highest prevalence from the cohort that we initially presented. So dilatation of the renal pelvis greater than 10 millimeters is considered as mild hydronephrosis. So when we diagnose hydronephrosis, we should go on and check the urethra if possible to see where the obstruction is happening. If we don't see any obstruction, sometimes when it is isolated, then it might be as a result of a marker of chromosomal abnormalities. Then we also diagnose posterior urethral valves, which will appear on ultrasound as a distended bladder with thickened walls and a keyhole sign. I think that's all. Thank you.
Thank you very much, Mr. Chigayo. There are some questions in the chat box. Probably you can start tackling them now. Then as soon as the next two presenters are done, we'll open the floor for questions. To our guests, we just have two presentations for the day, then we can call it a day. Then we can pose all the questions you want at the end. The next presentation, Mr. Chigayo, you may stop the screen sharing for now.
Okay.
Then so that I could share my screen. So the next presentation really is to try and address a gap which is there in our practice. I think you saw from the data that Mr. Chigayo shared on fetal defects that fetal heart defects are weakly diagnosed or are grossly underdiagnosed in our population. But we know from global data that fetal heart defects are the commonest defects. So it is on this background that I want to to just talk about fetal heart examination. But before I do that, I just want to test those who do scans to find out where they are. Again, we're not going to mark you, you mark yourself. I'll play you this short video. In that video, there's nothing there which is frozen, guys. It's a live scanning. What you are seeing is what it is. So don't think there's some slowing of the video. The video is what it is. This is a live video we took on one of our babies we were scanning, and I've just thrown it there. And I'm saying, what do you think is abnormal about that baby? It's a heart. Then the next one, oops. Right, so that's the next one there. Again, it's a 4-chamber view. What is abnormal about that heart? If you see more than one abnormality, you can go ahead and list every abnormality you can see on that heart. Then overall, you should tell us what you think is the diagnosis. The diagnosis of the condition shown on the picture. I'm just hoping these videos are playing on your side. Admin, just confirm, are the videos coming through, or I could be talking on my own? Admin, are we getting the videos on?
Yeah, we are getting the videos, Dr. Verenga.
Okay, thank you. So I'll go to the next one. This is the next video again of one of our patients. Again, what is list the abnormalities? There are about 5 abnormalities. It's just a 4-chamber view, because I think this is where we need to start as a country to look at the 4-chamber view properly. Because outflow tract, I feel this is important, because 80% of the fetal defects will be identified by a proper examination of the 4-chamber view. So list 5 defects that you can identify. Don't say, why is it moving? Fetal echocardiography is better to interpret a moving heart than a still heart. Because if I made this video to stop, it will look totally different. You may miss some of the things that we are seeing as the heart is moving. And finally, what do you think is the pathological condition here? What is the underlying heart defect we are dealing with in this case? Right, next. This one, what is the condition? I'm sorry, there's a shadow coming on this one. I think this one is a little bit slow, but just mention the cardiac defect. We are looking at on one of our babies as well. There, right. Then I think I should be done, but let's see. Probably I have another one. Right, there is another one. There is the other one. Oops. What's happening to this one? Oh la la. So this one is refusing to play, but this is the heart. I'm not going to bother you with this one because it's not playing. So I'll jump it. I'll go to the next one. Let's see if the next one will play. Oh la la. So this one is refusing to play again, but let me see the color one. I don't know why these ones refuse to play. Anyway, I think this is the end of the pre-course test for the cardiac talk. I will go to my presentation. Just bear with me as I share with you another screen. I'll come back with this presentation later on, with the pre-test later on. I'll just share with you the presentation of the day. I'll not be very long with this topic. I feel I just need to emphasize the 4-chamber view more than anything else. The talk is mainly on just examining fetal heart, but I've used my slides for fetal echocardiography. I thought it is important for me to just remind everyone that there are certain category of patients that need a fetal echo, not just examination of the fetal heart under a normal fetal anomaly. And who are these candidates? So anyone with a suspected cardiac defect on routine scan, they need a fetal echo to diagnose and to prognosticate the condition, and also counseling. Any baby who has an NT during the first trimester scan, which is above the 95th centile, remember, an abnormal nuclear translucent is also a screening tool for cardiac defects. So remember this, it's very important. Then family history of congenital cardiac defects. When we are talking about family history, remember we're not talking about the mother's family history. We are talking about the baby's family history. The baby in the uterus is our patient here. So when you are saying first degree relative family history, please, I should have put in bracket first degree relatives. It is only the first degree relatives that increase the background risk of a cardiac condition to the baby, not to the mother. So if the mother comes and tell you that, look, my sister or his sister, he has a cardiac condition, it doesn't increase the background risk of this unborn baby. It is only if the mother herself, the one who is carrying the baby, and the father of the baby, the one in uterus, the father of the baby, or other siblings, that means brothers and sisters of that unborn baby, if they were born with a cardiac defect, that will increase the risk to this baby to about 3 to 5%. That will become the background, which is a very high risk, considering that millions of women deliver every year. So it's a very high risk, 3 to 5%. Then diabetes mothers who are on insulin need a fetal echo, because we know that endocardial cushion defects, they occur at an increased frequency in women whose diabetes is not well controlled. So women who are on insulin deserve a fetal echo, a proper examination of the heart. Then women who have lupus with positive and anti-Ro and anti-La antibodies. It is important that if you are looking after women with lupus, that you know whether they are positive for anti-Ro and anti-La antibodies, because we know that they have a potential to cause heart block. So it is important that the anti-Ro and anti-La antibody status be known. If they indeed have them, then they will need a fetal echocardiography and they will need a fetal heart surveillance. That means even if we do a fetal echocardiography now, it's fine. They will need a follow-up of that fetal heart to make sure they don't get heart block, which may compromise the baby's life. Ideally, fetal heart examination should be done for every woman. That is fetal heart examination. But in the context of fetal echo, if there is a high risk for a cardiac defect, we can start as early. Of course, at 11 to 13 weeks, we examine the heart, but we cannot make any conclusions on which we can make a pregnancy care decision. If we suspect that the heart doesn't look normal at 12 weeks, we ask these women to come at 16 weeks. Then we check their heart properly. So we can start as early as 16 weeks. But most women who are not very high risk, we ask them to come at 20 to 22 weeks to examine the fetal heart during their normal scan. And what are we looking for? It's not just the cardiac defect structural. We also want to make sure that there are no arrhythmias, there are no situs abnormalities, and of course, the structural defects of the heart. And whenever you are doing a fetal heart examination, always think of these things, that this is what you need to do, to look for. So knowing how to do a fetal heart rate properly is important. Sometimes people just look for something which is beating within the baby's chest, they put the pulse wave gate, whatever tracing they get, all they want to do is to measure their heart rate. But if you practice like that, unfortunately, you are going to miss a lot of fetal cardiac arrhythmias. So what is the approach? First of all, ideally, we want to just know the rate and the rhythm. If you are just doing a routine fetal heart, you want to know the position of the heart and also the abdominal situs. You want to make sure that organs that are supposed to be on the left side of the baby are indeed on the left, and those that are supposed to be on the right are indeed on the right side of the body. Then we want to check the great arteries, the left outflow tract, the right outflow tract, and the arch views. And of course, we want to do cardiac biometry and Dopplers. I'm not going to cover cardiac biometry and Dopplers because this is just a routine fetal heart examination expected during the anomaly scan. I'm not going to cover in detail the great arteries in the arch views. I'll just pass through them because I still feel as a country or as Africa, we are still struggling with doing the 4-chamber view itself. So we need to get it right on the 4-chamber view so that we can at least pick 80% of the defects. For now, we can take 80 rather than to take nothing. Then we'll come back for the outflow tract to take the other remaining 20 another time. So basically, I think there's somebody with a mic. Who is that somebody with a mic on? I think it's the Fetal Medicine people foundation. Yeah. All right. So I've muted them. Let's continue. So when you are doing the scan, you know that from abdominal circumference, this is the abdominal circumference. If you look at these planes demonstrated here, these are straight planes. You don't have to do much to move from the abdominal circumference to go to the position of the 4-chamber view. Of course, you need to play with the probe a little bit to get the left outflow tract and to play with the probe in terms of rotating it again, the opposite direction. You rotate the left for the left to get the right outflow tract. And you just need to continue going towards the baby's neck in an oblique way where you look inside the baby, you get your 3-vessel trachea view. Like I said, those will not be the subjects of my talk today. I will just stay with the 4 chambers. I'm not going to spend much time here, but to just show you that they are common. This is our cohort, not many patients there, but we have an updated one, which we'll share with you another time. So if you look at our cohort, it was the second commonest defect, but if you look in the international literature, it's the commonest defect. The reason why it is second common in our case is because our screening protocol, or people who are screening, probably are not well versed with screening for heart defects. I think that's the most plausible explanation. And it is easier for most people to pick a ventriculomegaly than for most people to pick an asymmetry of the ventricles. So this may explain why we have these figures which sort of differ from others. This to just triage them, to just show you the common things, okay? Commonly, AVSDs are common. We have some tetralogy, we have arrhythmias, VSDs, aortic stenosis, hypoplastic left heart, and others. And out of our of our cases, what we noted is that almost more than 2/3 of our cases were just picked by just doing a 4-chamber view. We could suspect them that by doing a 4-chamber view, but unfortunately for the other third, you needed to do more views. This is the argument which we always say that we need to learn to look at the fetal heart beyond the 4-chamber view. It's not good enough to just say I can do a 4-chamber view. There is more you can do to increase the detection rate of fetal cardiac defects. But like I said, today I want to zero in on the 4-chamber view because we want to do it right. Because if we start there, we improve. So when we have a 4-chamber view, how should we do a fetal heart rate? How should we do it in the right way? So your pulse wave gate should always be less than 2 millimeters. Should not be more than 2 millimeters. within the 4-chamber view, which is a very good 4-chamber view, like we see on the screen here, you have to put your pulse wave gate just inside the ventricle, just on top of the AV valves. In this case, I'm putting it just on top of the mitral valves there. But as I'm putting it on the mitral valve, I'm trying to put it very close to the interventricular wall here, the IVS, the interventricular septum, so that I could capture two things there. One, I'm capturing the inflow of blood into the heart. Two, I'm capturing the outflow of blood into the heart. So that means I'm able, with this kind of heart assessment, I'm able to comment on the rhythm, whether it is a sinus rhythm or it's not a sinus rhythm. How can we do that? If you look, this is blood flowing into the ventricle. So we have the E and the A wave, which is the passive and the active filling of the ventricle. Then the other waveform you see is part of the outflow tract as blood flows out of the ventricle. So if we are going to have a situation whereby every arterial contraction is being followed by ventricular contraction, arterial contraction, ventricular contraction, then in this case, we know that the heart is beating at a sinus rhythm. If the heart was not beating a sinus rhythm, with a sinus rhythm, you will see on the other images. And of course, we have to measure the heart rate to make sure that it is within appropriate for gestational age. For the basic, I think this is what we need to know. Whenever we do the fetal heart rate, we should not just look for any part of the baby's heart, as long as there's some activity, and we just go on and measure the heart rate. Measure the heart rate in a way that helps in screening for fetal abnormalities, which in this case are fetal arrhythmias. I'll move on to the next. This is just show you some of the fetal arrhythmia. This is a case of fetal bradycardia. There's no slowing of the video here. The way the heart is beating is how it was beating. I'm not sure if we have a video of where we measured it, but you can see that there was bradycardia here, some sinus bradycardia on this baby. I'm not sure if this was the case of lupus, but we tend to get quite a number of these sinus bradycardias. I'm not sure which case was this one for this one. I think the other one is again another case of, let's play this video. No, not this one. This one is another abnormal case. Is this video playing? Let's see. Something has happened to this video. It doesn't want to play. I wanted to show you again another case of arrhythmia, but let's move on. Let's look at this one. So the baby came, we did exactly what I was teaching you there that we have to do. You can see our pulse wave gate within the mitral valve in this case. You can also alternatively put it on the tricuspid, but it's always easier to put it there. So you can see here that we are trying to see if this baby indeed was having a sinus rhythm. So because the heart is in the basal view, so expect the arterial waveform to be down here. So we can see here that here it's okay, here it's okay. Then somewhere here, the waveform seems to not to look normal. Here, it doesn't look normal. And then you follow again here, probably not looking normal, normality is restored. And we see another small waveform there. This baby had ectopic beats, but these ectopic beats did not affect the overall heart rate. It was 123 at 36 plus 6, which is within normal for that gestational age. But there were ectopic beats with this baby, which would mean that some of the ectopic beats were not going through to give us a proper ventricular systole. So this is how it works. Then again, for this is the same baby. So we're now measuring the velocities at the aortic valve here to just illustrate to you that ectopic beat. You can see that there's a missed beat there where the ventricle actually doesn't contract. due to these ectopics, which are not going through. So this is an example of a skipped beat, which you can identify if you measure the heart rate properly. But if you are going to just throw your pulse wave where there is something that is just beating, there is no way you are going to make this kind of diagnosis. And in most cases, these babies may be sectioned for an irregular heartbeat if proper assessment is not done. So this is how serious these issues are, that if the heart rate is not properly done or the heart rhythm is not examined, obstetricians will do a knee check. If the baby's heartbeat is not okay, a section should be done, which is fair if you don't know what you are dealing with, because sometimes this may save the baby. Then here we are again. We are trying to assess this baby's heart beating. You can see that we have a dissonance here. Look at the atria. Again, this is a basal view, so you expect them to be here, but you don't see a ventricular contraction. Atria, there is no direct ventricular, and look at the ventricles, the outflow, which is being picked here due to ventricular systole. You can see that these two are totally disjoined. There is no communication between the atria and the ventricular electrical activity in terms of the heart beating. So in this case, there was a complete heart block. They were not in sync. Each one was beating at its own rate here. So this is another example of a fetal, look at, this is fetal bradycardia, and there's total disjointedness between the two. We normally see this in cases of lupus with anteroid and antler antibodies, where there's blockage of communication. So that's how to assess the baby's heart rate in a proper way. Then we go to situs abnormality. How should one assess the situs? How do you know that their heart is pointing in the right direction and the organs of the baby are arranged in the normal way? Because it's just part of routine heart assessment. First of all, you should identify the baby's left shoulder, see where the left shoulder is. Once you are certain that you have seen the left shoulder, the next step is to look for the stomach and say, is the stomach to the left as it should be? Then you also have to look for the aorta and the inferior vena cava. I'm not sure if my image is showing nicely, but let's just see if I can show you. That's the aorta there. You can see the aorta is this one, the inferior vena cava is there. The great vessels, the aorta is to the left of the spine, while the inferior vena cava is anterior and slightly to the right in their arrangement with each other. They should never travel along each other or close together, these two big vessels. If you see two big vessels close to each other, the other one won't be the IVC. In most cases, it will be an interruption of the inferior vena cava with a zygous continuation. So you see the stomach to the left. When you continue to scroll down, you see that the heart apex is pointing to the left. You can do this within 30 seconds. After you have finished measuring the abdominal circumference, all you need to do is to scroll and make sure that the heart is indeed pointing to the left as it should be. If it's not pointing to the left, then things are complicated. Then that person will need a fetal echo now by fetal medicine until we have fetal pediatric cardiologist. So very easy situs, but in most cases, the patients we have diagnosed with either dextrocardia or those with left isomerism, with heterotaxy with left isomerism, most of those cases were missed. they're actually reported as normal because this simple maneuver is not being done the way it should be done. So if we do it properly, it is very easy to see that, look, the heart and the chest are not pointing in the same direction. These are just two images to just show you there. Sometimes make it your scanning protocol that you always try to show the baby's stomach and the heart this way as part of the images you store. And you can see here we have the spine and the inferior vena cava. You can see the inferior vena cava is to the right of the spine, and the aorta. This is the spine, the vertebral body, and the aorta is more to the left. This is the adrenal gland, and this is the stomach. So you can see the heart apex here, that they are both pointing in the same direction. So this is correct. Look at this one of our case. Using the same maneuvers, just try to follow what is happening on that image or another. This one didn't show the heart, but there's something very interesting, which when you look carefully, you are going to see. If you look at the great vessels in that image, you are going to see that there are two big vessels close to each other, a situation we said should never happen. You can see here that if you look here, this is the aorta, but there is another vessel just behind the aorta on the right. This cannot be the inferior vena cava. The inferior vena cava should be somewhere here. So in this case, there was, this is an azygous vein due to the interruption of the inferior vena cava, which we see in heterotaxic conditions. So this is abnormal. So situs goes beyond seeing the stomach. You should also see the relationship of these big veins, vessels, that is the aorta and the inferior vena cava. If you don't find the inferior vena cava, then there is a serious underlying cardiac abnormality. They need to be referred for fetal echo. Other cases, which are often missed when patients come to us, to be honest, the patients who had diaphragmatic hernias we diagnosed, I think out of close to 10 of them, maybe only one, they'd been identified as having such. The reason comes from exactly the same videos I showed you from the beginning that should make a sweep and check the relationship of the heart and everything, because congenital diaphragmatic hernias invariably shift the heart position or the stomach is shifted. So look at this one. You can see we are trying to get the heart. You can see the ventricles depicted the color there, but all we are seeing now is that there is a bubble in the chest and the heart is squashed to the corner. So this was a case of a left diaphragmatic hernia, which pushed the heart to the other side. This is a left congenital diaphragmatic hernia here. We are seeing, sorry. Then we have another case again here. You're trying to get the heart. You don't find it where you expect to find it. All you are now seeing is the heart squashed again to the corner. These are the ventricles. And you see a bubble, which in this case is the stomach. And you can see this structure here, the echo appearance of it, that this is the liver. So this is one of the ugly congenital diaphragmatic hernia where the stomach and the liver are all in the chest. Very easy to identify if you follow the right protocol. But if you don't follow the protocol and you don't bother to check baby hearts, all you want to confirm to the mother is that there is a heartbeat, surely you overlook all these very, very bad defects, which in our case, probably they are close to lethality. Because we are not doing balloon insufflation yet, endotracheal balloon insufflation. So we are not offering that. So these babies, we have nothing to offer them. So all we do is we calculate the lung head ratio to try and come up with a prognosis to know whether we should offer them termination or offer them hope. So very easy to diagnose by following the protocol. Let's go to the heart itself, 4-chamber view. I'll play the video. So when you look at the heart, how should we then look at it? The heart should occupy between a third, but not more than a half of the surface area of the thorax. And the apex should be seen to be pointing to the left of the heart. If you draw an imaginary line from the spine to the sternum, it should be seen to be pointing to the left. On top of that, you should make sure that the ventricles appear symmetrical. These ventricles, they should appear symmetrical. And the left atrium should look morphologically the left. You should see these vessels. These vessels are the pulmonary veins here, which are draining into the left atrium. And the right atrium, as rounded as you see it, is the way it should appear. And within the right, because after having done that, to go a step further, you should also know the morphology of the heart. When you are saying morphology, you are saying how should the heart look? How should the left side of the heart look? How should the right side of the heart look? The left side of the heart should be filled. Sorry, let me do the pointer thing. Laser. Yeah. So the left side of the heart should be seen to be apex forming. In other words, it should go all the way the left ventricle, and the right ventricle of the heart should be seen to have this band of tissue, which is sort of obliterating its end here. The tip of it is being obliterated by this band of tissue, which is called the moderator band. The valves should open and should not appear thick, abnormally thick, these valves here. And the offset of the offset of the tricuspid septal leaflet should be lower or towards the apex compared to the septal leaflet of the mitral valve here. So, and the lungs should be looked at, and they should appear almost symmetrical. If you are going, of course, the left always looks smaller because the heart is tilted that side, but you should see good amount of tissue both sides of the lungs, as you see. And the aorta, the ascending aorta should be seen here nicely as a single vessel. You should not see two vessels at this level. If you see two vessels, this vessel here, then there is a problem. So this is how the heart should be looked at when you are doing a four-chamber view. How can you obtain this image? If you transition from the four-chamber, from the abdominal circumference plane in a straight line without angulating your probe or rotating your probe, you will arrive at the four-chamber view. Of course, you need to do some twists and turns to make sure that you are covering just one rib. You are not cutting through the ribs, because if you are cutting through the ribs, you will be oblique. Interpretation of the heart is only based on obtaining a correct plane of the heart. If your plane is wrong, you are going to make wrong interpretations, or you are going to see wrong things. The interventricular septum should be seen throughout. This is not the best plane to examine the interventricular septum. If we have VSDs, we have to go in what we call the septal view of the fourth chamber, which I think is beyond my talk today. I will not bother you with that one. Let's move on. Let's show, now I think I have to show you some defects. I will not show color. I won't bother you with the colors. I just want to show you some abnormalities of the four chambers, just the four chambers. That's where my presentation just show you how to measure the axis if you are concerned, but this is not part of routine examination, just some abnormalities. Look at that heart. Remember, I told you the heart should not be more than half. And when you look at this heart, there is some element of dilation, that there is some element of dilation, that the heart, there is some dilated cardiomyopathy here with a thin rim of pericardial effusion. We normally see this kind of appearance in babies with severe placenta insufficiency, where the umbilical arteries are so high and the baby's heart is overworking to try to push blood to the placenta. So we normally see this kind of appearance in those conditions. This heart, is this a video? Let me see. Sorry, I just want to make sure if it's a video, I can play it for you. So if we look at this heart, this is the feeling. We can see that there is an asymmetry of the two sides of the heart. The right ventricle looks bigger than the small, but in uterus, always remember that what may appear small is the one likely to be abnormal than what may appear big when you're talking about symmetry. Of course, there are situations where it is not like that, but what happens in the uterus, due to the anastomosis and so forth, the heart, which is the side which is obstructed, does not enlarge like what happens in adult life, in extrauterine life. The side which is obstructed actually atrophies and becomes smaller. So, which is different from adults. If you have a blockage on the right side of the heart, the right side will balloon, but in uterus it shrinks. So you can see the heart there. That's we suspected coarctation of the water on this baby here. Let's go to another 4-chamber. Probably this video will play this time around. Will it? I wanted to show you this video. But anyway, this video is the same one with this one. This baby is a complex cardiac defect. We don't know whether the baby had 3 chambers, as you can see there, but this was the feeling of it. What we could see is that there was a large ventricular septal defect here, and the left was feeling nicely, but the right wasn't feeling nicely. So we suspected tricuspid atresia because you can see there's a valve which is not opening here. This valve is not opening the way it should. So we ended up with a diagnosis of this one is the atretic valve here of the tricuspid. So this was a case of tricuspid atresia. Let me move on to the next slide. I think my time is almost up. I need to round up. Right. Look at this one. I will not show you the color one. Look at this heart again. It's globally large, severe cardiomegaly. When you look now at the AV valves, you can see it's abnormally thick. Remember, I said this should never be abnormally thick. Here it is. And these valves will be leaking. This is the jet you are seeing there, the regurgitant jet, which if I turn it on, you are going to see a lot of red flow due to the regurgitation or blood in that jet. And you can see there, so, and the valve is inserted way, way lower than it should be, the septal leaflet of the tricuspid valve there. And this is a case of Epstein anomaly. Epstein anomaly. It's a lethal condition in this setting because you can see the lungs are gone. There are no more lungs here. Nobody is born without lungs and lives, right? Yeah, nobody will go home if they are like this. So please don't give these babies hope. There was a time when I was in France, at some point, a case like this was thrown on the group, and people actually agreed that it is better to deliver this baby by C-section, but this is wrong. This is a lethal condition, a total lethal condition. You cannot offer C-section here with giving the woman hope. There are no lungs here. No one walks in the streets without lungs. So this was a rare case of what you described as a heart failure, severe preeclampsia case. Look at this heart. You can see it's quite globular. Look at the ventricles. Everything is now dilated. It's a dilated cardiomyopathy. We now have pleural effusion. You can see the lungs hanging. And these were the ductus venosus. You can see there's now reverse. The heart is literally failing from a case of severe placenta disease. This one, another 4-chamber. You can see it's feeling nice. Look, the heart looks small. It's smaller than it should be. We said it should make up at least a third. This is not a third of this thorax. The lungs are looking like they're big, right? Because the heart is small. The reason why it is small is because you can see it's filling nicely on the right there. The right ventricle is filling nicely with blood, but the left has a very small flow going through this VSD, big VSD there. This was a case of hypoplastic left heart in one of our ladies. She came at 16 weeks We saw this at 16 weeks. Yeah, it was around 16 weeks for this one. So this is how you can recognize some of the defects. I think I'll stop here. I don't think I should continue. I wanted to cover 4 chambers. I'm not going to continue with the can I show you one image of AVSD? Where is it? Right. So look at this image here. You can see that the 2 valves are opening and creating a common channel. This is what we mean by common AV canal, which is AVSD, right? You can see that as they open, they're opening a common channel, which should not be the case. You can see there's a large VSD and an arterial component of the septal defect as well. So this is a case of AVSD. You can see even the way blood is flowing, that is going through a common channel and filling the 2 ventricles. What is happening here is that the ventricle, the valves, there are actually 5 valves that are around, because there's no middle structure to insert the septal leaflet. So we have 5 valves that are going right around the atrial ventricular junction, and they are opening all at once. These are some small VSDs. Right, I think I'll stop here for the heart. Quickly, I'll just take you through the quiz again, so that you can, from what I've presented, I think you should be able to figure out 1 or 2 things there. Let me see if I can bring back the quiz. To just bring back the quiz, let's see. Oh la la. I think it's still opening this Microsoft. I don't know if you can see my screen, but the quiz is taking time. I think for the sake of time, I will hand over to Mr. Zanga. Then we will entertain all your questions at the end. Mr. Zanga is the last speaker of the day. I will hand over to him to start his talk. Then if we have time at the end, I'll show you the quiz. So Mr. Zanga, you can go ahead. Then if there are any questions in the chat, I will attend to them. So Mr. Zanga is a sonographer, specialist sonographer. He's one of the fetal medicine fellows, one of the fellows who started with us in fetal medicine. He's a specialist sonographer and is a lecturer with the University of Zimbabwe, and has been a student of placenta disorders. Is currently doing a PhD looking at fetal growth restriction, the issues of Dopplers. So he's a real student of placenta disorders. So today he is going to present to us on obstetric scan, just basic approach. He will highlight some very important points that most people probably may not be aware of, or you take for granted when you are doing obstetric sonography. So Mr. Zanga will come in and address all that, so that we are enriched as we see pregnant women. Please go ahead, Mr. Zanga, once you are ready. We can see your screen is coming. It's taking time, but it's coming. Are you okay with your screen there? Mr. Zanga, are you winning? Do you want to speak, to say something so that we know you are there? Maybe you want to unmute yourself, just unmute yourself and speak. While he's coming, let me see. Right, I'll address some few questions here while he's coming. The first one, I don't know if Simba didn't answer the question on acrania. It's not a neural tube defect according to the literature. Acrania is a continuum of anencephaly, and we classify it as an open neural tube defect. I don't know what literature, Justin, do you think acrania and anencephaly are two different conditions? If you can answer that question, I think we'll have the answer to that question as well. But we understand that acrania is a continuation, is the beginning of anencephaly. No baby is seen without a brain at 11 weeks, including those you will not see the brain at 36 weeks. They will be having the brain. What they will be missing is the skull component. So if you could answer that one, then I think that answer will be, that question will answer itself. Then how can we differentiate fetal heart block and atrial fibrillation? Very good question. Normally in atrial fibrillation, it may be difficult to see to see some of the waves passing through when you do pulse wave Doppler, but the atrial fibrillation is likely to have a very high rate of the atrium compared to the ventricle. There is a component which I didn't mention when I was doing the fetal heart because I thought it is beyond just routine, because sometimes if you want us to do the right fetal heart examination, that routine, if it becomes too complicated, sometimes people will give up before they even tried. So I try to simplify it, but what happens is that the arterial and the ventricular rate should always be measured separately and compared, and see if the arterial rate is of any multiple to the ventricular rate, for you to be able to see that the atrium is discharging probably at a faster rate than in the ventricle, or that there are some more of the waves which are not passing through, which are supposed to pass through. So yeah, probably that's what I could say. Heart block, very easy in terms of differentiation. Like I showed you on one of my images, that the easy one, which is easy to distinguish the complete heart block, of course, where you will see that there is no matching between the atrial and the ventricular rate. They are not communicating to each other. That is very easy to determine. Mr. Zanga is trying to restart the machine, so I'll be going through some questions, and please clarify on the angle between the foot and the tip and the fib. Simba, you should answer these questions. If you are available, please answer the question. There is a question in the chat box. People want to know, how do you distinguish? How can you say there is club foot, there is no club foot? Just few questions while Mr. Zanga is sorting out his machine. So what is the abnormality here? You can answer yourself, but I've already told you that there is a fetal bradycardia due to a heart block here. The heart is not beating the way it should, as you can see. Then the next one, what condition is this? What can we see? We can see a dilated atrium. We can see a dilated ventricle. We can see a very thick dysplastic septal leaflet of the tricuspid valve. And we can also see that the left side is dilated as well. So this condition is Epstein anomaly. The next one, oops. So the next one lists the abnormalities. There is an AVSD here. Then the atrias look symmetrical. They don't look normal. So we thought there was a duplication of the left atrias here, so that we had left isomerism because they look symmetrical, they don't look morphological left and right. So, and we can see two vessels here. I told you that you should never see two vessels here. The other one was the azygous vein. So there was also interruption of the inferior vena cava for this baby. So our diagnosis for this one was heterotaxy with left isomerism, of course, with all the other defects which I showed. You can also see that the heart is deviated more toward the left. The angle of the heart is not normal. And the beating as well. The reason why they beat like this is because they will be missing the sinoatrial node. Remember, the sinoatrial node is in the right atrium. So if we have duplication on the left atrias, the sinoatrial node is missing. So they beat closer to the ventricular rate, which is a very low rate. Normally it's under 100. Sometimes they'll be around 100. Sometimes they can go as low as 60 or 50. Unfortunately, in our setup, this condition is near lethal. The ones we have had, none of them have gone home, unfortunately. Even the pacemaking will not help here. So, because they'll be having other defects. Remember, heterotaxy, for those who know pathology, that heterotaxy is not this which we see. Even on the lungs, they won't be having 2 and 3 lobes. You could have duplicated 2 lobes. Then on the intestines, there could be malrotations. They have a lot of other problems. They could have problems of respiration, ciliary disease, because it's to do with the traction and the movement at the micro level, so that organs don't move the way they should. So as a result, they have other things that complicate their lives, these babies. The last one, I think this is the last I showed you. Yeah. The other ones didn't play. So here we can see that the heart is pushed. Looks like a small heart. I'm sorry, this is not the best of our images, but you can see there's an ABSD here, a common opening on this heart. There were other things, but I didn't show you those. So I'll not talk about those abnormalities. So yeah, so if you manage to get anything from this quiz, then which means you are not, you should be scanning the heart, and you should attend our fetal echocardiography course, especially if you got half of what we showed you here. Then you need to pursue your skills in examining the heart. That means you have this goodness about knowing the heart, and you can even become better and be a fetal echocardiographist. So good. So Mr. Zaga, are you ready now? He told me that his PC had frozen and he was trying to restart it. So what we can do now is we can open the floor for questions while we are waiting for Mr. Zanga to plug in. Do we have any questions from all the presentations that have been done during the day? I'm just checking. I don't see what is the variation if the client is laying down. I'm not sure about what this question is directed to. Maybe you can clarify. There's a question there which we cannot answer properly. It's not very clear. So what other question do we have? Right. I think most of the questions in the chat have been answered. Admin, do you want to contact Mr. Zanga? Just find out from him if he can resume the presentation, or if his situation is untenable. Since the last presentation, Mr. Zanga could postpone his presentation to another time so that we don't keep people waiting for a presentation. Just find out from Mr. Zanga if he's winning. If he's not winning due to network issues, I think it's okay. We can. While they're on it, let me just announce certain very interesting events that are coming up, which some of you may be interested in. There is a Fetal Medicine Congress which is happening in the month of June, from the 26th to 30th of June, which the Fetal Medicine team will be attending. So if there is anyone who is interested in attending this Congress, which will be in Crete, Greece, just get a hold with our Fetal Medicine Foundation team. I think their contacts, they've been shared, or we have them from the registration. So just get in touch with them, then we can link up together, and they can let you know what is required to go there and so forth. Then you can go if you are interested in the field of fetal medicine. So the next point is that Fetal Medicine Foundation Zimbabwe will host an African Congress in fetal medicine sometime in October. You will be informed of these dates. And we are looking for abstracts of African origin. What I mean by African origin, we want to encourage young Africans to partake in research and present their research in an international forum. So we want to encourage research in the field of fetal medicine. And if there are any young people amongst us who say they want to pursue their research in the field of fetal medicine, please come and see us so that we can help you to pursue your dream in the field of fetal medicine. Yeah, so remember these very important events that are to do with fetal medicine. A lot of fetal medicine studies and research that have been taking place over time will be presented at the Fetal Medicine Congress in October. So be ready for that very exciting meeting. It will be a 2-day virtual congress that will encompass the whole of Africa. So yeah, are we winning? Admin, could you please communicate? Did you get any feedback from Mr. Zanga?
Hello, Dr. Verenga.
Hi.
Yes, we just spoke to Mr. Zanga. He said he's winning. He's joining in soon.
All right. So please bear with us, our guest. Mr. Zanga will join us, and he will finish the talk of the day. I think after Mr. Zanga is done, we are done because we have addressed the questions of the day. And yeah, so as soon as he joins, Hello, guys, are you in touch with Mr. Zanga to find out how he's doing? It's all right. Maybe what we can do, because we can't keep waiting and it's the end of the day. We are going to postpone Mr. Zanga to another CME day. Mr. Zanga will have a day to present to us on approach to obstetric sonography. Internet, probably where he is facing internet challenges. These are the challenges of our times as we try to implement blended conferences, workshops, seminars. It's a challenge we expect. So all the same, I want to thank you, everyone who took their time to attend this meeting. These refresher courses will keep on happening every year, where we will be addressing various fields in the field of fetal medicine. We still feel that fetal medicine is in its infancy in this country. Hence, we are going to be having courses in between scientific meetings. So the courses will be an annual event where topics and or new fields that will be emerging in the field will be shared by experts or upcoming experts in those fields. Thank you so much. Like I said, your CPD points will be sent to you by the Fetal Medicine Foundation team. The CPD points will be based on your recorded hours within the webinar platform. The webinar platform will record how many hours you were in the meeting, and you will be calculating your CPD points at 1 point per hour. So please bear with them. Don't say, why did you give me 8 points? The system captures all that information. So please just be understanding, because we are trying to do things the right way so that we promote learning or lifelong learning amongst people who are already practicing in the field. So then the next thing is you'll be given certificates of attendance to these courses, which you can keep, and the topics will be listed in terms of what was covered at the back of your certificate. Thank you so much and enjoy the rest of your Saturday. And yeah, bye-bye. Lastly, our presenters, you did an amazing job. Keep it up. You are the future people who make fetal medicine grow through your dedication and your work. And your studying and your reflection on your work will help to advance the field, not only in Zimbabwe, but in Africa as a continent. Bye-bye.